Hello, welcome New Zealand and internationally to an online symposium on science and policy for COVID-19. Coming up between now and 4 o'clock today, we've got 10 presentations, 5 from top overseas experts commenting directly on New Zealand's situation as we find it right now and as it's been over the past few months. I'm Mark Blackham, I'm your moderator for today. All but one of the presentations you're about to see are live over the course of the day, including the ones coming in internationally. Each will last about 20 minutes with questions afterwards. There's about 500 people that are going to be participating in the webinar over the course of the day. You'll see that the chat channel is disabled, but those people who are participating can submit questions through the Q&A tab, and I'll ask those questions of the presenters at the end of the presentation. We're also broadcasting this webinar out on YouTube and our Facebook page, where we will hope, and it looks as if there'll be many more people watching. At the end of the day, we'll put all the videos up on our website, covidplanb.co.nz. This is a science and policy symposium. Some of it might be pretty heavy going. This is the real deal. This is not the place for assumptions and wild conjecture, not for social rumours, myths, rebellion, no political advocacy or criticism. And it's certainly not the place for conspiracy theories. Questions advocating conspiracies of any sort will not be entertained. Emotions are running high for all of us, every New Zealander. Fear is contagious. Commentators, thinkers, experts, scientists, media, politicians and policymakers have not been immune to this fear. Even those who don't catch a dose of fear have been heavily influenced by the actions of those who do. Society collectively finds it harder to have a coherent discussion and make decisions in this environment. But each of us is a scientist in our own right. We're all trying to work out what's happening, and how should we respond. To do that, we're forming theories, we find data, we ask questions, we even change our minds. Sometime soon, our society is going to regain its head. Facts will become clearer to us. The perspective will broaden and reason will catch up. And that's why the COVID Plan B group is holding this symposium. That's why the group exists. It wants to help society return to normal faster. The group believes people don't need simple stories and daily instructions. We can think for ourselves and we can decide together. That's what a nation of free-thinking people do in a democracy. New Zealand is in an almost singularly unique position. When the Plan B group organised the symposium, New Zealand was free of community transmission. While incredibly fortunate, never before had so many of us felt so lucky to live here, it nonetheless posed quite a conundrum. How long could we or should we keep that effort going? And now that COVID-19 has resurfaced here, as we predicted, this symposium is even more timely. The question remains exactly the same. No matter if our attempts at elimination are successful or not, how long should we keep trying? You'll be surprised by what you learn today, but you'll also be reassured, as our group have been speaking to the international experts. There are many reasons to be far less fearful of this virus than we are. One last thing before we start, today's effort, as with the Plan B group itself, is voluntary. There's been no funding. This live stream was only made possible by an appeal for public donations. So if you like anything you see here today, please go to the website, covidplanb.co.nz, and click the donate button. The donations will help our work and you'll return to New Zealand to normal faster. Thank you. Right, we're going to start with the very first presentation, which is Dr. David Katz. He's a medical doctor and preventative medicine specialist in New York. He's with us now on the panel. David caused a storm in the US in late March with an op-ed in the New York Times titled, "Is Our Fight Against the Coronavirus Worse Than the Disease?" It was perhaps the first airing of criticism against lockdown-style public health responses. Despite claims at the time that we didn't know enough about the disease, Katz was subsequently proved right in his suggestion that it was elderly and the infirm who were most at risk. And it was they who needed protection, not the whole of society. David has a YouTube channel called COVID Reality Check, which I recommend you take a look at. And today he's with us and he's going to do a reality check for New Zealand. David, you there?
Mark, thank you. Outstanding introduction. Very well framed. It's an honor for me, everybody, to kick this off with a view from altitude. Good morning to friends in New Zealand. It's Sunday evening here in Connecticut. And I am going to provide a view from altitude, and Mark referred to some of the heavy going, and I suspect some of the participants here will take you deep into the weeds of epidemiology and number crunching. I will obviously reference some of the relevant numbers of epidemiology, but I'm going to leave the minutia of R naughts and so forth to my other colleagues, because I really do just want to frame this in terms of perspective. So that's the first critical thing. This is a view from altitude of a perspective that is perhaps being overlooked. Second thing I wanted to say, Mark, is I really have great admiration for Prime Minister Ardern. You know, everybody around the world dealing with this is making difficult decisions in a complex crisis without the best information about all the different options. There's no way to test them. Everything has to be done in real time. And you know, certainly, I am not directing any criticism at decisions that have been made in New Zealand, looking at alternatives. But I think Prime Minister Ardern has demonstrated commitment, effective leadership, passion, compassion. Frankly, I wish we had the same set of attributes on display here in the United States. But let's get to it. In June, when Time magazine wrote about the best global responses to the pandemic, New Zealand had an honorable mention along with Australia. So the winners were Taiwan, Singapore, and Korea at that time. But New Zealand was next on the list because of what Mark just described and what you know so well, essentially a lockdown that prevented any transmission of the virus. And of course, it helps a lot to be in the part of the world that you're in and isolated the way you are, and effectively to be an island nation. But even so, this was obviously policy related. But the trouble with declaring winners and losers during a pandemic is you're doing it in the middle of a complicated race that's really very hard to call. So, you know, who really is winning the battle against this pandemic? And I think there are three ways to look at this. One is that if you have high case counts and high casualties, you're losing. And the United States is in that category. There's no part of the pandemic that we've managed effectively here. So, you know, if you want a place to look to see how not to handle the pandemic, here we are. New Zealand is in this second group, low case counts and low casualties. And that was viewed by Time magazine in June as winning. Maybe some of you view that as winning. I view that as hiding. And I would say there's a third consideration that nobody around the world has really demonstrated, and that would be very high case counts and very low casualties. That would be winning. And let me show you why. One way to think about confronting the pandemic would be a battle. And so you can go out in a battle ill-prepared, you can lose. You can hide away from a battle and you know, it's waiting for you, or you can go out and win it. I don't think it's the best analogy, because the virus is not actively seeking us out. It's just making a living the way its nature requires. So it's really more like a fire than an enemy that's seeking to do harm. It will burn whatever it can burn. It's not thinking. And the other thing is, if you don't go out and confront a fire, it burns anyway. And so what is the pandemic burning down if we don't actively manage it? Well, it's burning through livelihoods. It's burning down jobs. It's burning away people's places of employment that will close down and not open up again. We're very concerned here in the States about the effect it's having on education, socialization, psychological milestones in kids. And of course, it is rampaging through the social determinants of health. While I was waiting to get my cue and start talking here, I was looking at social media feed out of Canada that their opioid and drug use epidemic has surged as a result, byproduct of the COVID pandemic and the mental duress that results from the policies in Canada. So it's a fire. So then let's look again, who's winning? Well, if you go out to fight a huge fire, you're ill prepared, you don't have the right protective equipment, and a lot of people are killed or injured, well, you've lost. That was a really bad response. On the other hand, if you just hide away, in a concrete bunker, you may not be directly affected by the fire, but everything you care about is potentially burning down. And frankly, that's an alternative way of losing. And that's the reason for my involvement here, my concern that I think there's a better way as New Zealand explores what to do in the next phase of all this. So a high case count, low casualty experience for COVID would be the equivalent of you go out, you meet the fire, you're well prepared, you have all the right equipment, and you actively control the fire and put it out. And I think that's what we can and should be doing with regard to SARS-CoV-2. I started opining very early, actually, even before that op-ed in the New York Times, because it seemed to me as data were coming out of Wuhan and South Korea, we were catastrophizing. The media were eating this up. There was a huge opportunity for drama. And so we were getting reports about the toll of COVID in pretty much every news cycle. And overlooked, it seemed to me, in the mix was, here in the United States, for example, we're a big country. 8,000 people die every day without a pandemic, 8,000 people a day. And yet the reporting of the toll of the pandemic would lead one to believe that nobody here dies of anything other than COVID. So we had massive risk distortion that reverberated around the world. I think New Zealand is a victim of that as well. The early data showed very clearly that there was a massive risk differential. This is a really bad disease in the frail elderly. It's a pretty bad disease in the elderly who aren't frail, and it's a pretty bad disease in the frail who aren't elderly. It's a really bad disease in the frail elderly. But in young, healthy people, the risks of this infection are actually considerably lower than many risks we encounter in our daily routines. Certainly with children, for example, the risks of an adverse outcome from COVID tend to be lower than the risk of riding a school bus, for instance. So I was concerned about the catastrophizing. And I wrote this op-ed in the New York Times that ran March 20th, which seems like several lifetimes ago. And the issue I was raising when I asked, is our fight potentially worse than the disease, was, will we maybe harm more people with a society-wide lockdown than are directly harmed by the virus? And what I had in mind was not a trade-off between lives and dollars, but rather the social determinants of health, which are referred to in this Health Affairs article as the social determinants of death. If people are unemployed, if their livelihoods are imperiled, if they are desperate, destitute, food insecure, extremely anxious, a lot of bad things can happen. In the short term, those things include depression, drug use, addiction, domestic violence, child abuse, suicide, and we have seen global surges in all of those. Over time, you worry that the consequences of an unraveling of social determinants can be even greater. And this perspective was shared by three-time Pulitzer Prize winner Tom Friedman, New York Times columnist. So he contacted me after my op-ed ran and channeled my opinions in a column of his own, which he's done a number of times since, ran me up a very high flagpole. So here I am. That's why I've become as visible as I have on this topic. And in Tom's column that followed mine by just a couple of days, we explored the notion of, okay, an initial lockdown, but then a pivot to a risk stratified approach where we recognize that SARS-CoV-2 is not a one-size-fits-all threat. It's a really bad disease in some, it's a really mild disease in others. Can we take several weeks to do a nation-specific data assessment that allows us to know what those risk stratifications are, and then develop more elegant policies, a more surgical strike, if you will, as opposed to open warfare, so that we protect those who need protection, but we don't shut down things that don't need to be shut down. And the other critical consideration is if you have no exposure to the virus, you're obviously propagating no herd immunity. And that means you just remain exactly as vulnerable as you were at the start. But as I explored this issue more thoroughly, I met a number of experts, some of whom are participating in this symposium, one of whom, who is not, to the best of my knowledge, is Nick Bloom, an economist at Stanford. We did a webinar together. Nick cited some of the primary literature that shows the following. For every midlife adult who loses their livelihood for an extended period of time, there is 1 to 1.5 years of life expectancy loss. Well, here in the United States, and obviously the trends are the same in the US and New Zealand in terms of social upheaval, the numbers are very different. Here in the US, 40 million people have lost their jobs as a result of the pandemic. And the estimates are that about half of those job losses are permanent or long-term. So that's 20 million long-term job losses. If you multiply 20 million by, say, let's use the lower number, 1 year, that's 20 million person years of life lost. We've had 160,000 deaths from COVID in this country, and the estimate is that on average, people are losing 10 years to the virus. And I think that's actually high, but even if we accept that number, that's 1.6 million person years. In other words, the life lost from the lockdown is 15 to 20 times greater than the life lost from the virus itself. And that's what I meant at the beginning. There's more than one way for this scenario to hurt people, and our goal should be to minimize the total harms. One other critical consideration: lockdown is in the service essentially of flattening the curve. I met two expert mathematical modelers in the early going here, Maria Chikina at the University of Pittsburgh and Wes Pegden at Carnegie Mellon University. They published this article on Medium calling for honesty in pandemic modeling. They actually went into a pandemic model used in the New York Times to argue for flattening the curve. They turned it on and used that very tool. They didn't invent a new tool. They turned on the tool that told us all to flatten the curve and said, if you run it, here's what happens whenever you release the clamps. You've achieved no herd immunity. Your population has had no exposure to the virus. Everybody is completely vulnerable. And if at any point you expose your population to the virus, all of the same horrible things happen on a different day. A just flatten the curve or just lockdown policy doesn't save lives or prevent any of the harms of infection. It just changes the dates. Unless deus ex machina, unless between now and the time you release the clamps, there is a highly effective vaccine mass distributed to your population that works beautifully in everybody, including, by the way, the frail elderly who tend to respond least well to vaccines. But that's what you're counting on. Something you don't have direct control over needs to come in from the outside and save you. Otherwise, if you release the clamps with no exposure, everybody's vulnerable. The bad stuff is just delayed. These were the perspectives that concerned me. I do want to note here, I have not functioned as an armchair epidemiologist opining from the comforts of home. I volunteered. I'm a physician. I did 30 years of patient care. I now have retired from patient care to do other things in public health, but I effectively came out of clinical retirement to volunteer in New York, and I served a number of shifts in an emergency department in the Bronx. I just missed the peak because of the time it took to go through the process of volunteering, but I have seen this up close and personal. So my perspective is informed by actually caring for critically ill patients with COVID. But of note, while I was in the emergency department in the Bronx, ambulance after ambulance arrived with patients from, in particular, nursing homes, frail elderly. And the people who were in the ED who had COVID but were otherwise pretty young and generally healthy, most of them didn't even know they had it. They had no symptoms of it at all. And that bears out the global experience here. I've also argued we don't need to test everybody, not in the US, not New Zealand, to know what's going on, but we do need a data pyramid. I think the most efficient way to achieve this is representative random sampling, which could be done at intervals, by the way, even with limited test supplies, to know who has this. And of course, in New Zealand, if no one's exposed, you already know the answer, nobody. But if you change your tactics, I think you would want this kind of testing. Who's had it? Who has antibodies? And from that group, who developed symptoms? Who needed the hospital? Who needed the ICU? How many died? Everything you've heard about fatality rates is wrong, because in order to report any rate, and I say this as someone who's authored multiple editions of a leading epidemiology textbook, you have to know the denominator. Absent reliable denominator data, you can't report a rate. You know the total number of deaths, but you don't know out of how many people who got infected. We have recent data in the United States suggesting that our estimate of 4 to 5 million people infected is wrong by at least an order of magnitude. And so if 40 or 50 million or more have been exposed or infected, obviously the case fatality rates also go down by an order of magnitude. It's nothing remotely like 3%, it's more like 0.3%. And the global data suggests that as well. And that doesn't mean you should haphazardly expose vulnerable people and take even a 0.3% risk, because that risk is concentrated in the vulnerable, so it's higher there. But what it does mean is we have massively distorted the magnitude of the risk for want of a reliable denominator. One of the few places that did a good job getting the denominator early was South Korea. They went out and in Seoul actively tested 200,000 people within days who didn't have symptoms, and they reported some of the lowest rates of severe infection of any country in the world. Most of the rest of us around the world are way behind in denominator testing. So as a result of these considerations, what I have advocated from the start, and I've not seen a reason to change my mind, is total harm minimization. Look at the potential, and the title of this talk, as you saw, was Look Both Ways Before Crossing a Pandemic. You look in one direction, you see the potential harms of infection. We need to minimize those. And the best way, I think, to do that is a risk stratified approach. You look in the other direction, and you see the harms of interdiction done haphazardly. You shut everything down, you cost people their livelihoods, and you do a great deal of damage to health mediated via the social determinants of health. We want to minimize both. And the way to minimize both is a risk stratified approach, which, by the way, can be a beautiful phase too. So New Zealand doesn't have to choose, in my opinion, between staying locked down until there's a highly effective vaccine or opening up and exposing everybody and being at risk. We can control waves of the pandemic by letting them be our waves, not waves of viral exposure, but waves out into the world, the lowest risk group first to see, okay, actually, if the virus circulates, but nobody gets severely sick, that's actually a good thing. That's how all pandemics historically have ended. Virtually no pandemics have ended with Deus Ex Machina. No pandemics have ended with a vaccine. Certainly the 1918 flu pandemic did not. It ended because the exposed population bore the brunt of it and got over it, and herd immunity was achieved. We don't want to do that with mass casualties. There's a better way. And so we can learn from the follies of history. We can learn from the global experience. And by the way, I haven't seen any country do this. So I'm obviously leaving these slides behind, and you'll all have access, but I've developed this simple color-coded risk grid. There's age-related risk in tiers, and then there's health-related risk. And I think we could stratify the population and adapt our policies. And for the sake of time, I won't dive into the details of the cells, but one of the critical considerations, I'm a preventive medicine specialist, those white arrows indicate opportunities to go from one risk tier to a lower risk tier by modifying your risk factors. We can't change age. We absolutely can change the health factors that most relate to COVID. And by the way, we can also measure them at the individual level and quantify them. Associates of mine at a company called Everest Health have developed a very elegant personal COVID risk calculator that expresses your risk of hospitalization, ICU, or death if you were to get infected. And it's all based on information about your personal health status as well as your age. You could learn more about this at everesthealth.com, but we're very interested in leveraging the power of that. But before we had a COVID pandemic, we had pandemics of chronic disease, which we were mostly overlooking. In fact, diet alone in the United States kills 500,000 people prematurely every year, and it's contributing to the COVID deaths by compromising cardiometabolic health. So colleagues and I have published a couple papers in the Journal of Emerging Infectious Disease looking at the prevalence in the US, around the world, of these major risk factors: obesity, diabetes, hypertension, dyslipidemia, coronary disease. In the US, 60% of adults have one or more major risk factors for an adverse COVID outcome. 40% or more have two or more of these risk factors. The epidemiology in New Zealand is not terribly different. I am sorry for not knowing it as well, but the numbers are fairly similar. We crunch the numbers for the US. This has received high-level attention. New York Times did an article on the overlap between chronic diseases and risk factors for chronic diseases and adverse COVID outcomes. And then our latest preprint, colleagues and I published, is on the opportunity to reduce hospitalization rates by a very significant amount. 36% was our estimate, simply by modifying these very modifiable risk factors. So again, there are heart disease, lung diseases, but in particular obesity, diabetes, hypertension, dyslipidemia. And we know the mechanisms by which these contribute to COVID risk. Excess adiposity contributes to insulin resistance, inflammatory responses that are out of balance, increases the likelihood of the famous cytokine storm, and severe obesity is probably the leading risk factor for bad outcomes in younger people. And often, by the way, when we hear about healthy young people succumbing to COVID, what's being overlooked when we say they're healthy is an extreme elevation of their BMI. So they actually have a major modifiable risk factor. We understand the contributions of hypertension. COVID is, to some extent, a vascular disease. It impairs endothelial function, so does hypertension. So the two together are a double whammy, if you will, on the vasculature, impairing oxygen delivery, compromising vital organs. And so major risk factor, very modifiable. Diabetes, interestingly, in addition to being a major risk factor, there's a very strong gradient with glycemic control. These are data out of China, similar data out of New York City. Well-controlled type 2 diabetes reduces the risk of a bad COVID outcome by a factor of 4 relative to poorly controlled type 2 diabetes. And all of this can be achieved with lifestyle intervention, improved diet, physical activity, and much the same with cardiovascular disease. So rather than belabor this just to move along, massively elevated risk with factors we could fix. And I really haven't heard a lot coming out of New Zealand, which I think, again, I applaud the overall enlightenment of Prime Minister Ardern, but there's an opportunity, I think, to say, well, 2 pandemics are better than 1. We have a lot of chronic disease and risk factors. There's an opportunity here actually to improve overall health. I would argue there's never been a better time to focus on getting healthy now. And if there is an alteration of the overall policy approach in New Zealand, this should be configured into it. So, obviously your situation has changed. You were hiding away from the virus. There were no cases. Now you have some cases. You're back in lockdown. The problem with the current approach, which is really all about avoiding exposure to the virus, is you're all vulnerable, and that never stops until something comes in from the outside. And each time you let the population back out, this can happen again. So rather than an either or choice, I'm proposing the middle path, total harm minimization by means of risk stratified return to normalcy. Sweden obviously is the opposite extreme. They let everybody stay exposed all along. I think they suffered casualties they need not have. I think they could have better protected the frail elderly. But at this point, it's unclear who really is the winner, because obviously it appears now that the pandemic is largely behind them. So I don't think we need to pay quite so high a price, but we're in the middle of this, and it's really far too soon to say which is the winning policy. But we should be looking at all the options and trying to use all available information to the best we can. I live in Connecticut. We are fortunately in green because we're in the greater New York City area. And what we can say here is the United States is sort of Sweden by accident. We do not have effective leadership right now. We have bungled our way through the pandemic. But much of the country, which liberated haphazardly, now has high transmission rates. But those parts of the country that experienced the brunt of this early, we now have extremely low and falling transmission rates. And it looks like the pandemic is mostly over here, and the rest of the country is headed in this direction. So I will leave it there. I hope I didn't take more time than was available to me. And Mark or anybody else here, happy to take questions at this point.
David, that's great. Thank you. We do have a lot of questions that have come through. I'm going to try to get through as many of them as I can. In some cases, people who are submitting questions, I'll be combining them together. The first one, David, is I just wonder if you could talk a little bit further around the concept of controlling it with the waves concept. You're talking about that we control the waves. With one of our leading people here, David Skiggs, said over the weekend that we really had to do something else besides lockdown. I'm wondering whether you could give us a firm description about what those are. As I understand it, you're saying definitely people improving their health as much as possible. That's going to make it less likely that you catch COVID or that you get badly affected by it. But also, if you could address perhaps things like masks, which are popping up all over the place here now, tracking and tracing, and some of those other ways of perhaps isolating or introducing just the healthy population to the disease.
Absolutely. So, first of all, Mark, there's a lot more information than I can provide in the time available here, compiled at truehealthinitiative.org. That's a nonprofit I founded, and we've used that site to organize peer-reviewed articles, essays, risk models, and we detail total harm minimization via so-called vertical interdiction there. It's a challenging question to answer because, I don't know any nation that has done all of the necessary work to practice elegant risk stratified interdiction. I think, frankly, it's a 1,200 or 1,500 page policy manual. What I regret is that when countries went into lockdown, New Zealand or any other, there wasn't a statement that we're going to lock this down, but we recognize these massive risk differentials, and we'll be back to you in X amount of time, 2 weeks, 3 weeks, and between now and then we're convening an army to work on Plan B. The very purpose of this symposium: is there an alternative approach that is more effective at minimizing total harm? But when I talk about waves, Mark, what I mean is, again, people under age 50 in good cardiometabolic health have orders of magnitude less risk from this disease than people over 70 in poor cardiometabolic health. The mortality experience is massively concentrated in frail elderly people. And the global risk among people under 30, unless they've had intensive exposures by, for example, doing bronchoscopies in hospitals, or they have some severe health risk, extremely low. And the risk to children, as I said, is globally appears to be less than the risk of riding a school bus. That has been distorted because every adverse outcome, particularly if it's an anomaly, makes global news. And so, if there's a case in a child, if there's a death in somebody under age 30, it's in the news, it's right in front of us. But these are very, very rare events. And the fatality rates by age group, we collated that information at the True Health Initiative site. So the waves that I'm talking about would essentially be: use a color-coded scheme for the population, and say everybody who is in the green cells has no restrictions, return to the world, school, work. Essentially, you are at liberty to return to life as we knew it before the pandemic, which, in a country like New Zealand, until there's more transmission, may still mean a very low risk of exposure. But in a country like the United States would mean you're very likely to encounter the virus. But actually, it's probably a good thing, because you get it, you get over it, you make antibodies. And again, maybe this pandemic will end with a highly effective vaccine developed faster than one ever has been before. But pandemics historically have ended with herd immunity. And there's a lot of interesting information on the topic of herd immunity, Mark. I think that's also been distorted. We can return to that. But I would, when I talk about waves, I would literally talk about a return to approximations of pre-pandemic normalcy, based on those color-coded risk tiers of the population. So the lowest risk people out first, followed by the next, followed by the next, and essentially a 2-week delay each time to see, is there any bump in hospitalization? Obviously, we ought to do testing, whether it's systematic or representative random sampling, to see what transmission is like. But if I can refer back to the beginning of my slide deck, I think winning this looks like a high case count, but no spike in hospitalization. In other words, people get it and get over it, but it's mild, because people who can safely get through this infection are the ones who are exposed. But we don't get a spike in hospitalization or death because people who can't be exposed don't get exposed. And then if you phase out, 2 weeks, so you basically you have no indications of spikes in hospitalization, then the next wave is out, and then the next wave is out. And we work our way through this. And that gives you time at each step to extend the restrictions on the more vulnerable. The other thing this requires, Mark, and there's no way we can pretend this is not nuanced. And it's one of the problems we have in the world these days. We tend to like yes, no, either or kind of decisions. We're very bad at nuance. But what about, okay, so we're letting lower risk people return to normal activity. What about their interactions with higher risk people? What about multi-generational households? What about, when kids going back to school interact with their grandparents? Well, what we need in place, and this needs to be a combination of what's required by the government and some degree of responsible behavior by individuals. And I think there is a case to strike a balance. I've actually talked about hierarchical responsibility here, where you need government policies, you need organizational responsibility, restaurants and public facilities that determine, okay, we need to comply with government policies, but there are different ways of doing it, and we pick the one that works best for us. And then you need individual responsibility. So, I think masks, social distancing should be imposed anytime someone from a lower risk group is interacting with a higher risk group. And you can start to see why New Zealand and the rest of the world gravitated to what really were very simplistic choices. Lock it all down or liberate it all. They're simple. There's not much nuance there, right? So I think that dichotomy gives us a bad set of choices. I think they're both bad. The only thing bad about total harm minimization is that the how, risk stratification, does require nuance. So, essentially you would need to think, okay, I can behave a certain way. If I'm a kid interacting with other kids, if I'm a young, healthy adult interacting with other young, healthy adults, I don't really need to worry at all about protection. The minute I interact with my parents, I do, right? So there's some subtlety there, but that is the price we would need to pay for a better policy than lock it all down and wait for a vaccine.
Thank you. Hey, you just mentioned recently an article about second waves. Is there such a thing?
Not yet. And so, it's really, just to be clear, I have colleagues, you'll probably hear from some during the symposium, who will sound more confident than I. I'm okay with that. I think we've got to be really humble. And I think anybody who says anything about the pandemic and acts like they've got total certainty is just not paying attention. Pandemics are unpredictable. Any of us could be wrong. So we're talking about doing the best we can with the information we have, being realistic, being dispassionate, looking at the data, interpreting the data, knowing when we do and don't have a denominator. As best I can tell, Mark, there is no second wave anywhere in the world. There is the New Zealand experience, where people have essentially kept people and the virus apart and then let people go back out and get exposed, but the virus never went away. So a second wave of a pandemic, seasonal flu is a good example. So your behavior stays the same, normal behavior. There's a high circulation of flu. The flu circulation and transmission dips to near nothing, but you didn't change a thing. And then the flu comes back because of a seasonal change. That's a second wave. The virus controls those waves. It went away, it came back. SARS-CoV-2 has done nothing of the sort. Every place a population is exposed, the virus continues to circulate, and the only thing that has caused it to stop is the population has developed herd immunity, which Sweden appears to be doing. Frankly, I think we've done it here in Connecticut, or people hide away from it. So there's no evidence anywhere in the world yet of a second wave, and I don't, and I've conferred with experts like Mike Osterholm, who are very cautious about this. Maybe there'll be a second wave. Yeah, but in order for a virus to come back in a second wave, it needs to have gone away. And this virus didn't. So, it's your winter, it's our summer. We're in the middle of our summer. And SARS-CoV-2 is circulating quite rampantly throughout the entire country. There's no evidence that this virus is in any way deterred by the heat of summer months. Now, ordinarily with a flu, we would not see high levels of circulation during the summer. The flu, I guess, is a lazy germ. It takes the summer off, but SARS-CoV-2 has just kept working straight through the summer. I don't see any evidence that we are at risk of a second wave. Can't know for sure, but this appears to be, that this virus will infect you if it can. It doesn't seem to care at all about seasonality so far. And once we get through it, since the population will have been exposed and the virus will have had its chance to confront everybody, it doesn't seem likely to me that there's a big second wave risk. So I'm hopeful about that.
Thank you. Now, as the real mortality rate is beginning to become evident, and to people like yourself, that was a long time ago, but as it's becoming clear to, I think, the wider public, worriers are beginning to focus on the ideas like COVID-19 causes long-term damage, even though you might not die from it. You're hearing things like scarring of the lungs, myocardial inflammation, long-term problems that people have to live with. What from your perspective and from what you've heard or have seen, what are those effects?
Yeah, so there does appear to be, there are a number of them. Obviously, one of the things that was missed early in the pandemic is that blood clot formation, thrombosis, was a common complication of COVID. And so we were hearing about strokes, and they were being described as if they were long-term, unexpected consequences of the disease. We now know that the pathophysiology of this disease involves the vasculature, increases the risk of thrombosis, and it's now standard care to use antithrombotics when people are being hospitalized for COVID, and that effectively prevents that particular complication. But the other, and the one you're referencing here, Mark, is a fairly significant myocarditis in a subset of patients. And the distortion there is that this is being reported as if it's a very prevalent complication, but most of the data I've seen are in people who've been hospitalized, which are a very small segment of the overall population. Keep in mind, we talk about 4 or 5 million cases in the United States, but we have seroprevalence data from around the country suggesting that we've had 50 million cases and maybe more, because actually we have other data suggesting that only half of people who get exposed wind up making antibodies. So maybe 100 million people in the United States have been exposed, half made antibodies. So then what is the prevalence of the myocarditis? It's extremely low. It's, again, you need a denominator to know what the threat is. So one of the distortions here is these complications are being seen in patients who have severe infection in the hospital. The other, Mark, and again, this just to go back to a comment I made, and I'm not in any way insensitive to the toll of this pandemic. It's touched me personally, friends, family. So, I feel the human toll of this, I really do. But that doesn't change the fact that we are distorting it massively. So 8,000 people die every day in the United States without a pandemic. That's a big number of miscellaneous causes. We are mortal. We're all going to die. Well, similarly, a lot of systemic diseases cause cardiac inflammation. In fact, there's a cardiomyopathy called Takayasu's cardiomyopathy. Many listening in will have heard of it, which is a common consequence of almost any major organ system disease. You have cardiac dysfunction, a decline in your ejection fraction. It's transient, but it's a consequence of essentially multi-organ system failure during any serious systemic disease. It could be an infection, it could be pancreatitis, it could be any one of a number of things. So this is not in any way unique to COVID. And the reporting we're getting, since it's all COVID all the time, makes it sound like, wait a minute, there are these long-term dire complications of this disease. Well, yeah, I've treated patients over the years with pneumonia, pneumococcal pneumonia, who were still weak and short of breath 6 months later. A year later, they were fully recovered. Well, we haven't had a year for anybody to make a full recovery from COVID, but people who get severely sick and stay in the hospital for a couple of weeks or a month, for any reason, take a long time to get better. We're reporting it as if COVID's the only thing that does that. It's a standard experience after a major systemic disease of any kind.
Right. One last question in the time we've got. Thank you. And it's about New Zealand. So you say we've been hiding. What do you think is the right way of us stopping that? What could we do next? What's our solution given the, what you're explaining about the States, although the effect has been bad, you're implying that at the least you're gaining some sort of extra immunity above it. Which
but don't do it our way, right? So
No.
You can look to the United States, for how not to handle it. I mean, we are the worst because, again, we're sort of like Sweden, but accidentally. At least Sweden did what they did on purpose. The United States has been ineptly managed through this. So you're better off than we are. You still have the option of controlling your destiny. We basically just let the virus run over us like a bus. No, so what I think you ought to do, so again, you've effectively shielded almost the entire population from the virus and suffered a very low toll of casualties, and I think that's wonderful. But rather than continue with just flatten the curve, you could do that. But then, essentially every time You let the population back out, there'll be a few cases and you'll lock down again. That's a horrible way to live for an indefinite period of time. And you are waiting for Deus Ex Machina. The only way this ends, if that's the national policy, is relief from the outside, a highly effective vaccine mass distributed. Until that happens, you're stuck. Get unstuck by pivoting to a risk stratified return to normalcy. So again, there's some subtlety required, but maybe the group that's assembled to discuss Plan B is the very group that could help detail the policy responses. How do we manage interactions among risk tiers? But let's risk stratify the population of New Zealand. Let's return to normalcy, and let us not lock down just because there's a rise in cases. We expect a rise in cases. It's a virus. It's going to infect people. But if nobody gets really sick and nobody gets hospitalized and nobody dies, it's okay. We live with infectious disease in the world. Infectious diseases infect people. That's how they propagate themselves and survive. We want to avoid them if there is a high risk of a severely adverse outcome. But just being a case is not a bad thing. I think right now New Zealand is conflating any case with a calamitous case.
Yes.
I say prevent the calamitous cases, allow the cases, because then you have two ways of putting an end to this. One would be that highly effective vaccine we're all hoping comes sooner than it ever has before. Okay, that would be great. But we don't know yet. They're just beginning phase 3 trials. Everything may fall apart. We may be back to the drawing board. The other way to get there is to get through this with herd immunity. And again, I think we're much closer. Many studies suggest there's a much higher seroprevalence than we've been able to document. We may be much closer to herd immunity than we realize. I think essentially New Zealand could achieve the herd immunity of Sweden without the casualties by doing a risk stratified return. That's what I'm proposing. And that means, okay, stay in lockdown for the 2 or 3 weeks or however long it takes to develop that policy manual.
Yeah.
How do we artfully manage the interaction among our risk groups? But it's not rocket science. We could put that manual together.
David, thank you very much for your time. Really appreciate it. It's been wonderful. It's a great opportunity to have you come and join us and offer some solutions to New Zealand. Really appreciate your time. Thank you.
Pleasure to be with you, Mark. Thanks for having me.
Right. Thank you. Okay, everyone. Couple of things. I think, have we got our Facebook stream actually working yet? So it's just YouTube. We're going to have a Facebook live stream of this working, but it's only on YouTube. I believe that at the moment, Jacinda Ardern is announcing whether or not we are going to have a delayed election. Some people might want to dip out and see that, but we're keeping track separately, and we'll bring that news in as we hear it. Right now, we're moving to Jay Bhattacharya. He's a medical doctor and professor of medicine at Stanford University. And Jay is really quite the package. He's a medical doctor. He knows a lot about the health impact of the virus, and he was considered an essential worker during the height of the pandemic. In some senses, just like David, these guys are going from the lab, as it were, to the hospital. But he's also has a doctorate in economics. So he's done a lot of thinking about the weighing up of the economic costs of our response to the virus, and in particular, the wider health impacts of economic failure. One day after David Katz had written in the New York Times, Jay wrote a piece in the Wall Street Journal, which was countering the claims of presidential advisor Dr. Fauci, who had been citing a death rate that forecast up to 4 million deaths in the US. His courage and his willingness to consider the data deep and wide is why we're fortunate enough to have him with us today. Jay, over to you for your presentation, and we'll take questions at the end.
Oh.
Jay, there?
I'm here. It's a real
Okay.
pleasure to be here. Thank you for having me. And I should clarify, unlike David, who actually takes care of patients, I've spent my sessional worker credentials in the lab. So,
Right.
anyway, so with that aside, I have some slides I'd like to share, and I hope folks can see them. Just to give you my perspective and point of view, and also to, I think, to put things in perspective that in a way that I couldn't do without the slides. So COVID-19 in New Zealand, in some ways, is a remarkable thing, because the number of cases that New Zealand has experienced is incredibly low relative to the rest of the world. and in a way, because of that, you've missed the how deadly COVID-19 infection actually can be. Part of that, I think, also is interesting because the perceptions of how deadly it is don't correspond to the actual scientific data. So I'm going to run you through some of the considerations on thinking about how deadly it is and show you the data that about it. Then I'll turn next to the economic damage from the lockdowns, and I'm going to put it in a New Zealand context just to give you some sense from the forecasts that have been put forward. And then I'll end with just with talking about policy. All right, so how deadly is it? So the key distinction, and I apologize if you all have already seen this, but I want to make sure that it's clear in everybody's head. The key distinction is between the infection fatality rate and the case fatality rate. The infection fatality rate is the number of deaths among the infected divided by the number of infected. The denominator is the total, all the people who have been infected with the disease. The case fatality rate is the number of deaths among the cases divided by the number of cases. Well, it looks like, if you look at it, it looks exactly the same, but it's not, because a case is not the same thing as an infection. A case is somebody who, as a patient, who's been identified either by public health authorities or by a hospital or by someone as either probably having COVID or confirmed to have COVID via PCR test or some such thing. There's the selection problem is enormous there. The set of people who get tested is not a random set of the population. Completely reasonably, the tests are reserved for people who doctors think actually have COVID, or people who suspect they have it or have some other good reason to be checked. It's not universal. I mean, there's no way to do a universal PCR test of the entire population. And even if you manage to do it one day, the next day you'd have to do it again, because the PCR just checks to see if you're currently infected. The number of infected people may include a much larger fraction, in fact, the part of the population. And in fact, the evidence suggests that that is actually true. Now, if you want to understand how deadly is the disease, you want to know what the infection fatality rate is. Like you, a random person in the population, me, a random person in the population. If I want to know, well, if I get it, how bad is it going to be? How likely is I going to die? Well, you want the infection fatality rate. The case fatality rate tells you if I get it, and I end up in the hospital, just like David was saying earlier, I end up in the hospital and I get a severe case. Well, what fraction of those folks die? Okay, in the U.S., in the early days of the epidemic, the initial forecast suggested an incredibly high case fatality rate. The World Health Organization thought it was 3.4%. There was a paper published in the Journal of American Medical Association analyzing Chinese data saying it was like 2.3%. Those are enormously high numbers. Those numbers suggest a deadly disease. And actually, to some extent, the deadliness of the disease has been borne out. If you get this severe viral pneumonia, it is deadly. Upwards of 4, 5, 6% of the population that end up in the hospital or can die from it. If you end up in the ICU in the early days of the epidemic, 90% of the people who ended up in the ICU with a ventilator died from it. And so people looked at this, they looked at the pictures, and they thought, gosh, we better do everything we possibly can. And again, a not unreasonable response in the face of numbers like this. The problem is these numbers and those pictures present a very, very misleading picture of the full scope of the epidemic. They present a small fraction of the most severe cases and pretended as if everyone is at risk of getting exactly that, when in fact, there's a very large number of cases where there's no symptoms at all or very, very mild symptoms. Let me show you some evidence for that. And that comes from seroprevalence studies. So what is a seroprevalence study? Seroprevalence study, instead of looking to see if you actively have the virus in you, a seroprevalence study looks to see in the population of interest, what fraction of the population has antibodies to the virus. Well, antibodies, they fade, we now know they fade over time, but the rate at which they fade is unclear. But they provide evidence that you actually were infected even after you've cleared the infection. This is not like HIV or even like chickenpox, which hangs around in your body forever. These viruses, just like common cold viruses, get cleared out of your body if you survive them. And the question is, what fraction survive them? So the seroprevalence study, what it seeks to do is it says, okay, let's look at this population, draw samples from the population, and see what fraction of the people in the population chosen to be at least somewhat representative of the population. It's hard in the midst of an epidemic to get a fully representative sample, but it's certainly more representative than case number reports. Well, what fraction of them have it, and then extrapolate that to the population at large, from the sample to the population. This is completely standard methodology. I should say a couple of notes about seroprevalence studies. They almost certainly, at this point we know, provide an underestimate of the total number of cases, because there's evidence that there's some patients or some people react to the virus with a T-cell mediated immune response with minimal antibody formation. And as I said, the antibodies fade over time, so we might catch you too late. So we're going to still underestimate, but this is still better than just going by case numbers alone, which underestimated, which turns out by order of magnitude. So the question is, like, what are we finding? In the early days of the epidemic, I worked on probably one of the very first seroprevalence studies. Since then, there are now somewhere on the order of 50, 40, 45, 47, 48, something like that, papers reporting on seroprevalence data, and many, many more not put into paper format. And I'm going to just show you a few of them here. In fact, I just want to run you through a couple of the numbers. These are drawn from a study that Johnny Anides, who's a professor here at Stanford, has done. Basically, he's been collecting these numbers, collecting these studies. Now, what you can do with the seroprevalence studies, you can actually get a better measure of the death rate, the infection fatality rate, than with the case fatality rate. And now, since there's been 45 studies, I have a lot of these. These are all from John's meta-analysis. Let me just run you through what they found. And I won't go through every line because it's not worth your time, but I'll just point out a few highlights. So in Iran, for instance, in early April, 33% of the population was found to be infected, have antibody prevalence. That would imply approximately 770,000 people had been infected as of early April, orders of magnitude higher than the number of cases that are identified in Iran for that. If you look at the number of deaths, 2 weeks before, with a 2 week lag, 2 weeks after rather, so that you can figure out what the death rate is, because it takes a couple of weeks to die, given that you develop a severe case. Well, it turns out, but 0.07%. What is that? That's 7 in 10,000, or 0.7 in 1,000 deaths. How much would you change your life? Would you stop sending your kids to school at 7 in 10,000 probability of death? In Boise, Idaho, there was a study done in late April. 1.8% of the population. Again, that looks like a small number, but Boise, Idaho is a small town, and that turns out to be much larger than the number of cases identified in Boise, Idaho at that time. And the inferred fatality rate is 0.13, so 1 in 1,000. Among people who are under 70, it was 2 in 10,000. 2 in 10,000. In Japan, 10.9% of the population, 1 in 10,000 for the under 70 population, 2 in 10,000 for the population at large. I said, I promised you I wouldn't go through all of them, but I wanted to highlight a couple more. New York, 14%, represented in April, representing 2.7 million cases, and a case fatality rate among those under 70 of 3 in 1,000. In China, 8.4%. Remember, in Wuhan itself from March to April, with a inferred infection fatality rate of 0.4%, 4 in 1,000. Remember, the early estimates from Wuhan itself were 3.4%. This is 10 times fewer. The CDC conducted a study in the United States of six cities from commercial labs, and they also found very low rates of mortality among those under 70, and even over 70 overall. They found in Utah 0.08, Connecticut 1.5, a very high rate. I'll show you a few others. The median mortality rate, the median infection fatality rate in these studies was 0.27%, somewhere between 2 and 3 in 1,000. And for those under 75, it was 0.05%, 5 in 10,000. Okay, so what can we learn from this? First, the disease is much more widespread than the official case numbers would suggest. It's less deadly for the general population than for us, but than the case fatality rates imply, especially for those under 70, though it's obviously still a very deadly viral disease for those who develop those symptoms. A very large fraction of the people, maybe half, maybe more, who are infected experience only mild cold-like symptoms or no symptoms at all. That's the typical normal presentation of this disease. What you see in the newspapers, what you see in the video is the worst presentations of those disease, and those are terrible, and we should seek to avoid them. But we should seek to avoid them by understanding who's most likely to get that presentation, as people set 70 and over. The other thing is the fatality rate is a function of the last thing I should have put on here is that fatality rate is a function of both the host and the virus. It's not a single number, and it depends on the circumstances of treatment. So in places that are overwhelmed, that are managing the patients improperly, you're going to get high death rates. In places that have the resources to manage the patients they have, even the more severely ill patients, with the better knowledge of how to manage the disease we now have, you're going to get much better looking numbers. Okay, let me talk about flattening the curve versus eradicating the disease. Now, the whole policy has been to try to avoid this light blue line. Without protective measures, the dashed blue line is the capacity of the healthcare system. This is the notional curve I'm sure you all have seen. You get a number of cases that is above the dashed blue line. You've overwhelmed the healthcare system, you get mass death. We've seen that. We see that in Wuhan. I think to some extent we saw it in New York. If you have protective measures, you flatten out the spread when the disease happens, and so you never exceed capacity. The point I want to make is that the area in the light blue line is the same as the area in the dark blue. The same number of cases eventually happen. The only question is when. There was a very interesting paper, post, and I assume paper by two mathematicians, Chiquina and Pegden, who they labeled the paper a call to honesty in pandemic modeling. They re-evaluated models like the one that led to the lockdown policies. What they said was, okay, well, you have a flat curve as long as you have the lockdown. But what happens after you remove the lockdown? Well, you see a very, very sharp increase in the number of cases. The models imply that you're not eradicating the disease. The models imply that you're just delaying when they happen. You either pay the cost now or you pay the cost later. So the lockdowns are not a mechanism for disease eradication. They'll only delay when the disease happens. Okay, and I think the experience that Auckland is having right now is evidence of that. Now, while it's not yet certain exactly what led to the outbreak, and I know there's theories of containers from abroad and so on. I'm sure we'll learn more about it in coming days. One possible idea is that the disease was spreading sub rosa, basically in the population, even despite the lockdown. There was present. Though you think you've eliminated it because you have no identified cases, most of the people infected have very mild illness, and they may not know that it had it. So it could have just been spreading around. I actually searched for a seroprevalence study for New Zealand. It would be very, very interesting for New Zealand to do seroprevalence studies and continue to do them to track exactly how widespread the infection actually is, as opposed to the current numbers, which don't tell you that. Let me finish with some notions about economics, and I want to emphasize the epidemiology economics trade-off. And the theme in this last part is about lives versus lives. And the reason why I put it lives versus lives is a lot of times people try to say that, look, we want to save lives. They're incredibly valuable, which is true. We should pay any cost whatsoever so that we can protect the people from dying from COVID. The problem is, and so folks who are skeptical about lockdowns are put in a corner to have to defend the economic gains versus the lives, and I don't think that's the right argument. The right argument is, and the right facts are, that the economic costs themselves have consequences for the lives of people. Poorer countries are poorer, have shorter lived peoples, and there are real health harms from the economic harm caused by the lockdown. So I have three propositions I'm going to defend here. Proposition number one, this should be not at all controversial, which is that lockdowns slow the spread of the epidemic. We've seen that in New Zealand. We've seen that around the world. Lockdowns are an effective tool to slow the spread of the epidemic. Not eliminate the disease, but to slow the spread. Proposition two, the more severe the lockdown, the more severe the economic harm. That, I think, is also indisputable. Proposition three, economic prosperity improves population health. Economic devastation kills. It's not lives versus dollars, it's lives versus lives. Proposition three is well accepted among by health economists, and I think is pretty non-controversial, although it may be surprising to some. Okay, so let's look at what the GDP hit is of the. This is from Stats New Zealand. I pulled the GDP hit of the and what you can see is a very widespread economic damage between December and March from the first quarter lockdowns alone in New Zealand. The only folks who industries that escaped are mining and information, media, and telecommunications. The construction industry was hardest hit. The retail, trade, and accommodation, transport, postal, and warehousing. So the tourist industry was enormously. Here you have I pulled some numbers from the UN Comtrade UN database on exports, and you can see that in 2018. There was about $10 billion in people visiting New Zealand and spending money in New Zealand. That's an enormous fraction of the New Zealand economy, which is about a GDP of about 200 billion. So it's just to get some sense of how large the actual number here. 208 billion. This should say billion. Yeah, so this 10 billion is an enormously large number, a fraction of travel. And here's daily border crossings. Since March, there's been very few. The tourist industry has collapsed. That's $10 billion that evaporated. The question is this permanent, or is this just a temporary measure? I think that given the current trajectory policy, this is more or less permanent, because if you want to protect New Zealand from all cases forever, you can't have travel. You can't have people coming in from the outside, because they'll bring the cases in, as you've seen already. Okay, what I plotted up here is I've taken New Zealand's IMF growth forecast for 2020. In fact, I've done it for a variety of richer countries versus the number of COVID-19 deaths as of yesterday. Per million population. New Zealand is up over here on the top. New Zealand is they've had very close to zero deaths. On the other hand, economically, New Zealand, you should be as David said, don't compare yourself to the U.S., which has had an absolutely horrific response to the virus. Compare yourself to the countries that are up here. Greece had a worse economic outcome with roughly the same number of deaths. Korea, Singapore, Taiwan, Japan, Hong Kong, Slovakia, Czechoslovakia, the Czech Republic, all had better economic outcomes with roughly the same number of deaths. So New Zealand has done well, but as far as limiting the deaths to date, and has the opportunity to continue to do well, but at great economic cost, about 7% GDP hit. So what does that mean? Well, when you're poorer, and the lockdowns themselves have all kinds of effects. Higher suicide rates, domestic violence, derailed education. Now, for the most part, New Zealand has avoided that because they've been able to lift the lockdown after the number of cases went to zero. The lockdowns, if they come back, these consequences will come back. What I'm going to focus on here is shorter lifespans, and shorter lifespans arising from the economic hit. So what I've done is I've plotted for New Zealand from 1961, which is over here. This is income on the x-axis and life expectancy on the y-axis. And this is from Gapminder. I just tracked how New Zealand has fared in terms of life expectancy and income. And you can see New Zealand has done very well since 1961, with life expectancy going from 71 to almost 82 in 2019. And income per person going from about $16,000 per person to about $36,000 per person. Enormous progress by any standard. So 36,500 per person, 82. That's how New Zealand was last year. It's a success of the healthcare system, a success of the economy. New Zealand, I would say, I would grade as an A+ if I had that kind of authority. Okay. Well, what is this 7% annual growth rate mean? Well, it translates to about a $3,000 per person loss in income, or 4,500 New Zealand dollars per person loss. Well, if we go back, how far back do we have to go before we get the $3,000 loss? Turns out it's 2012, right? 2012, there was $33,300 of income per person, and a life expectancy of 81. The economic harm from 1 quarter of lockdown wiped out 7 years of economic progress, and in the long run likely will wipe out at least 1 year of life expectancy gain. You're getting loss of life in addition to the economic harm. It's not just dollars for lives, but lives for lives. There's a very rosy forecast for 2021 for the whole world put out by the IMF. It forecasts that New Zealand will have a plus 6% growth rate up over here. I hope that happens. But this happy scenario was developed before the latest lockdown. Repeated lockdowns, if they happen, will mean that New Zealand will do economically worse than the rest of the world that have stopped locking down. And it seems likely that much of the rest of the world won't be in a position to lock down. Okay, thank you for your time. That's all I have. I say for the policy going forward, we know a lot about the disease now. You protect the older population who are most vulnerable from dying, and then let the rest of the population face relatively minimal risks from the disease. I mean, not no risk, obviously, it's a deadly disease still, but relatively minimal risk from the disease, go about their business, because this is not a let's protect people at all costs situation. It's a question of trade-offs. Thank you.
Right. Thank you, Jay. And thank you enormously for that work you did at the end there on New Zealand specifically. Really appreciate that. And you know, I think although we've talked about some numbers here in New Zealand, actually seeing it there 7 years lost with 1 quarter and 1 life year lost is quite stunning. I'm going to start, if it's all right, in terms of questions, taking you up on the seroprevalence studies, which were it's incredible work. I'm not sure if you're aware. You said that you looked for studies in New Zealand. The thing is, we haven't done any. We've done no studies here whatsoever. The government has not done them. I think it may have been asked once, and I'll probably do injustice to the answer, but it seemed to suggest that we would just know about prevalence via the case rate, which you're obviously suggesting wouldn't be the situation. Have you got comments on that? Just that for itself, about the fact that we haven't done these studies?
I think it's really hard to make good policy without knowing actually how widespread the disease is. And so this is what's motivated my work on seroprevalence, is try to just paint a much better picture of how big the iceberg actually is. If you just looked up in the top and you say, okay, I'm going to crash into the top, and you're going to miss everything underneath, you're going to make bad policy. I think that it's a very good investment. They're not expensive to run, and they would provide an enormous amount of information for New Zealand, actually for every country on earth, I think, in how best to manage it.
Would it be too late for us to do this?
No, it's not too late at all. I mean, I think if you understand how many people have actually already been exposed, you might even get a better sense of how likely it is that there's still reserves of the population out there. There's, I think, a debate happening in New Zealand right now. Did the new cases, I think what now, 70 new cases, come out from the outside in, or were they homegrown? It would help provide some evidence on that question, for instance, and then just make guide policy better.
You touched on that briefly. Do you think then it's very possible that that after 3 months of no cases that this could still be homebred? It's
quite possible. I mean, I obviously can't know until you've done until all the work's been done. But I think there's no reason not to believe that person A has it with a very mild case, passes it on to two people among the young. They have it. You don't end up seeing it, and you're not looking for it because you've solved it. There's 120. So someone dies of a pneumonia that you don't necessarily record it as COVID. I mean, it doesn't look. I mean, not every COVID case looks exactly alike. I mean, it's not like it's certain that that's what's happened, but it's certainly a possibility.
All right. The reliability of data. I mean, you're working a lot with data. it seems as if we've been caught out internationally, either in recording of cases, recording of deaths. Could you comment on how reliable data is? Was it at the start? Is it becoming more reliable? Can we?
I mean, it's hard to comment on that universally. I mean, part of the issue, for instance, in the United States, if you are seeing if you're a hospital seeing a patient with COVID and Medicare, the over 65, you get paid a 20% bonus on the case relative to if you're not seeing a non-COVID case. So there's strong incentives to over-report in some settings. In other settings, you may end up missing, as I said. So there are certainly data quality issues. The other issue is like whether you call a case a COVID case or not. So do you need to have a PCR positive to call it a COVID case? Or can you diagnose it on the basis of symptoms that look like COVID? And countries differ in how they're treating that. Some are requiring a full PCR positive to say, yes, it's COVID. And some are saying, okay, a probable COVID case should be counted as COVID, whether there's PCR verification or not. So this is definitely an issue where international standards will be helpful. This is something like it's a group like the World Health Organization could play a really important role in sort of regularizing how we do report around the world.
I'd like to explore a little bit more around this economic cost. You gave some great assessment of the things that happened due to economic downturn. It has been interesting to see the same people who claim that economic improvement helps improve quality of health and lifespan also now say that there isn't going to be any losses from the economic hits we've been going through. But I just wonder if you could kind of explain, by way of example, perhaps, how that direct connection happens between the economy and health discrepancies.
There's a lot of an enormous literature. This is one of the favorite topics of health economists to study. So for instance, education is a good example of this. When we are poorer, we invest less in the education of our kids, and that has lifetime consequences. More poorly educated kids have worse, in the long run, when they're older, have worse health behaviors. There's fewer resources available to take care of the folks when they get sick. Investments in health are enormously profitable in improving health. So it's not surprising that when a country is poorer, invests less in health, you're going to get worse outcomes. There's 100 mechanisms, all incredibly well documented. It surprises me that this should be seen as a controversial topic. Investments in health are worthwhile, especially in places like New Zealand that take pride, justifiable pride in their healthcare system, and the investments that you all have made in your healthcare system. And the returns from that I think are quite evident in the high life expectancy and the high quality of life you have. Reversing that, how can it not reverse that? I mean, it seems like not a controversial point.
Okay. Perhaps comment also on the international impact, and by that I'm talking about the developing countries, poorer countries. I know you've had a bit to say about the way in which the Western world has gone into its shell and almost broken its connections with the developing world. Could you explain a bit more about that? How has that happened?
Sure. I was going to say more about that in my remarks, but I sort of ran out of time with all the slides I already had. I think that we have a compact. So, for instance, there are organizations like the World Trade Organization. We made a promise to the developing world. The developing world has made a promise that, okay, you join the global economic system. We'll have mutually beneficial trade, and it'll enrich all of us. And that's like a classic theorem in economics, and it's played out. Trade is a really, really good thing. New Zealand's benefited enormously from trade. Countries around the world have. Essentially, what COVID has done is it's created autarkies of every single country. And the worst hit are going to be countries like our poor countries that rely on the promises we made of them. We're already seeing around the world a huge reduction in a huge increase in tuberculosis cases, untreated tuberculosis. We're seeing malaria reduction programs stopped because of lockdowns and COVID risks. We're seeing vaccination campaigns like Gavi shuttered for the time being, again, for COVID. We're going to see a resurgence of these diseases that we thought we had suppressed all around the world. And I view that as a failure of the developed world and the promises it has made to the developing world. Because we're so scared of COVID, we're gonna end those we're gonna violate the promises we made about the benefits from global economic cooperation. In effect, we'll turtle up into our shells, protect ourselves from COVID at the cost of enormous suffering in developing countries as they get poorer and less healthy. And I think the trade-off is such a bad one, because it's not like we also will face those costs in our own countries as we become poorer. So I think this is one of these things where, like, it's hard to get a full accounting of the number of it. I mean, I'm trying to develop an accounting. Maybe at some point I'll be able to put something convincing together. But the direction and the magnitude seem pretty clear to me, of the harm that we're doing to the developing world from these lockdown policies we've adopted.
Thank you. We've got time for some more questions, and there's a whole lot of them, Jay. There's a few questions there about the accuracy of the tests, the accuracy of testing for whether or not you've got COVID. There's a number of them around it being possible to test positive but not harbor a virus. Could you comment on that? Are there different tests? Is there different?
Yeah, so those are all good questions. So the antibody tests, in the early days of the antibody tests that were available, there are two kinds of tests. There are these very, 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 very accurate ones with which you can draw blood, and they're called ELISAs. They're like 99+% specific, which means that you have very few false positives, and they're 95+% sensitive, which means that they have very few false negatives. There were also these like small test kits, very cheap test kits that had a wide variation in accuracy. Some were very, very accurate, and some were inaccurate. Some of the bad black eye that seroprevalence studies got in the early days have to do with the fact that some of the studies were run with relatively inaccurate test kits. The one that I ran, for instance, Santa Clara study, it turns out that the test kit we used was incredibly accurate. It's now FDA has approved the technology, for instance. But in any case, even with an inaccurate test, it turns out that you can do statistical adjustments to adjust for the inaccuracy as long as you understand what it is. The seroprevalence studies that I reported on all those papers, many of them are peer-reviewed in the scientific literature. They tell the same story over and over. The virus is more widespread than you realize, and the disease is less deadly than you realize in every country, in every state that's had such a study. Right.
Why is it, do you think, that these numbers are not getting picked up? Why? Let's start with the economic costs. Are they just sort of too hard at the moment? You know, you talk about the now or later issue. Well, right now we do have deaths. Later, we've got estimates of loss. Now, most people are instinctively going to say, "Well, I'll worry about the later." You know,
yeah, we're built that way as human species, right? We react to what we see in front of us, and the idea of the deaths that are going to come from the economic harm are just abstract. I think that's part of it. There's the psychology of like seeing what you see now, but that doesn't make what's going to come any less real, mind you. Those deaths are still deaths. The other thing is, I think there's been a false and sort of facile moral argument that people sometimes make against people who are skeptical of lockdown, as if somehow because we're pointing out the economic harm, that we think that the economic harm outweighs the deaths now. That's not the argument. The argument isn't, I don't know what the value of life is, dollars per value of life. I know there's a big literature on this, but I personally have absolutely no idea what it is. And I don't actually care what that number is. What I care is we need to adopt a policy that improves the health of the population in the long run. We shouldn't look back and say, okay, we saved these lives, but we in effect killed all these other people by our policy. But that's exactly what we've done worldwide.
Well, what was interesting about your slide with flattening the curve versus pushing it out was that, it's exactly the same number. I don't think people quite appreciated that. How do you think that it's possible that countries like New Zealand have shifted from the idea of flattening curve to trying to eliminate the virus? And is it possible to eliminate the virus?
I don't think it's, I think a disease eradication, we've eradicated a single disease, a single virus. We've eradicated smallpox on the face of the earth. That took 30 plus years and an enormous amount of effort and a very, very effective vaccine. But there's not, we don't have those kind of conditions, and this is not smallpox. Most of the people getting it are going to have a relatively mild illness. They won't even know they had it.
Right.
This disease is not eradicable. It's an incredibly infectious disease. For most of the people that get it, it's relatively mild. For a few unfortunate folks who get it, it's very, very severe. Luckily, we now know who's most at risk. So policy designed to protect those people, make sure nursing homes are bubble zones that no one can where the virus has no chance of entry. Right? If a country just does that, just does exactly that, it will have a much better outcome than, say, New York did or Italy did. Or, you know, I mean, I think if we've learned a lot also how to treat the disease better. So I think in the early days we were mismanaging patients with ventilators. We've learned, for instance, about the use of steroids to manage patients in ICU settings, to avoid cytokine storms or to treat cytokine storms. And we're getting better at managing, and maybe the vaccine will come up. Now that's an actually interesting point I wanted to address also.
Sure.
The vaccine thresholds are for whether a vaccine is declared effective. I think now it varies from study to study, but I've seen numbers like it has to be 50% effective. Okay, that would be great to have a 50% effective vaccine. You can't eradicate the disease with that. You can't eradicate the disease with that, with universal vaccination. Even with a vaccine, New Zealand will get, if it opens up to the rest of the world like it used to have, it will get cases. You will get cases, and if you close the world down, if you close New Zealand down, every single time there's 10 cases, you're going to keep doing that forever. It's never going to end.
So, final question. I'm asking everybody, what's the solution for New Zealand specifically? In New Zealand at the moment, Sweden's come back in as a possible approach for us to take. But there's a lot of talk about Taiwan as a model as well. I wonder if you can tell us the difference, or whether either of those is suitable for what we've
it's polar opposite. I mean, I think New Zealand, I think, has taken an approach closer to Taiwan's. Right. So if I fly into Taiwan, I'll be quarantined for 14 days presumptively. They have an app you put on the phone, and I'll be mandated to put on my phone that tracks me. I'll have to check in every morning for every foreign visitor. Life actually, I think, for the most part outside is open. Although I think Taiwan, there's more universal masking than there is in New Zealand, than there has been in New Zealand. So in a sense, you all have taken the Taiwanese policy. You've lived it. Maybe a little less enforcement of some of the restrictions that Taiwan has had, but roughly. Sweden, by contrast, I think in the early days, their mistake was that they didn't protect the nursing homes as well as they could have. I think they learned from their mistake, and they've adopted almost no mandated social distancing policies, no mandated lockdown at all. There was actual social distancing, voluntary social distancing, because people were justifiably scared of the virus because we didn't know how deadly it was. So it's not like there was nothing that happened in Sweden. But it seems reasonably clear that in Sweden, the virus has spread is pretty much as far as it's going to. There may be pockets of people who haven't been exposed, but it would be very surprising. It's possible that they're through with the epidemic altogether.
Right. Okay.
It came at a deadly cost, though.
Yes.
I mean, they had many deaths. The question is, they paid those deaths and now they're done. So like the same thing in the United States. New York paid those deaths, probably more than it needed to, because it didn't protect the elderly population. And their cases look low. Is that a success or a failure? I mean, you be the judge.
One final question, if that's all right. One of the reasons that our Plan B group is here is to hope that we can learn from this and perhaps not take the same approach next time, that we can be prepared with something more subtle. Do you think we can learn from this event, that the world can learn, governments?
I really hope so, because I think this response to this epidemic was unprecedented in human history. The whole world shut down, the whole world locked down, one after the other, on the basis of almost no evidence. We looked at what happened in China, and in effect, I think we panicked.
Yes.
In retrospect, we need to set in place processes that make a response like this much more difficult, at least much more based on actual data as opposed to guesses. I think we have to take a very careful look at the models that led to some of the predictions that they had, because I think they were they provided a very misleading picture of where the epidemic was going to go. And I think the other thing is that we can put in systems that give us better information much more easily than you might think. So why is it that there hasn't been systematic seroprevalence studies everywhere all the time over this? This is something that I would think the disease, like in the United States, the Center for Disease Control could do. The health agencies all around the world could implement. Health agencies do surveys all the time. Why not have a panel of people that you go back to over and over again, draw a little bit of blood and do and it doesn't have to be seroprevalence for antibodies, whatever the key statistic is, or the key set of statistics are, let's track them. Instead, we have all around the world this haphazard system of case reporting. And the cases we know are not the number to look at. What I look at is how many people over 70 get the disease, how many people have died from it over 70, how well are the hospital systems doing, are they overwhelmed? Those are the kind of statistics I think would be, if we looked at those from the very beginning, we'd have better policy.
Actually, I do have another question. Sorry, Simon Thornley has put a question through. He's saying skeptics are possibly pointing to the high overall mortality peaks recently, which contrasts with the low infection fatality ratio calculations. What have you got to say about that?
Maybe I can I'll try to find Simon's question, but I don't fully understand. So the question is, the total number of deaths are high?
Yes.
How does that square with the infection fatality rate? So, I mean, the total number of deaths is the numerator. The question is how many people have got the disease is the denominator. So the infection fatality rate is you're trying to get an estimate of that total denominator. The problem with the case fatality rate is you're just looking at a set of identified cases and you say, okay, this fraction of those have died. Well, if these numbers of people have died, but only this number of people got the disease, you're going to get a very high fatality rate. But if this number of people, the same number of people died, but this number of people got the disease, well, it's not that deadly a disease. So the question is, how many people actually got the disease? Oh, Simon, you're online. Can you clarify the question?
Jay, yeah, I guess the skeptics for me often come and say, well, the overall mortality in a particular country has a peak. And so that suggests that that's more than that what's happening with COVID is more than what's happening with past influenza viruses or.
Oh, it is, Simon, is more deadly than the influenza virus. That's especially for people over 70. It is more deadly than influenza. I think based on the IFR numbers, it's at least 2 to 3 times more deadly than the deadliest influenza epidemic in the last, I mean, not counting the 1918 epidemic, which I think was more deadly than this. It's certainly in the last 50 years.
Sure, okay. Thanks, Jay.
All right, Jay, thank you very much for your time. Really appreciate it. And also the effort you put into to put that data in about New Zealand. I really appreciate that as well. Thank you very much.
Yeah, my pleasure. Thank you for the invitation.
Great.
And thank you for the question.
Okay, everyone. We have a couple hundred people both participating and in on the YouTube, which is fantastic. Can I ask any of the panel members, if you're there and available during the day, feel free to answer some of the questions that are coming up on the Q&A, because we're not going to possibly answer them all. So you can answer them directly. Now we're going to take a 15 minutes break. You can go into your kitchen and grab yourself a cup of coffee or something, or tea. We're going to do the same thing, and we're going to be back at 11 o'clock with Byron Brittle. All right, Talk to you soon. Thank you. Well, welcome back, everybody, to the 100 or so participants in this webinar, and a few hundred more that are tuning in via YouTube. Facebook Live is not screening. People are being redirected to the YouTube video. All of these videos will be put up on our website at the end of the day, as will sort of a highlights package as well. I really thank everybody who's been tuning in for listening right through. It has definitely been worthwhile. These are very, very interesting points of view and facts that we've probably not been getting in its entirety otherwise here in New Zealand. Up next is Brien. He's an associate professor of viral immunology at the University of Guelph in Canada. Historically, his research program had focused on a couple of areas, but particularly a novel vaccination strategy for cancers. And in response to the pandemic, Dr. Brien, in conjunction with some virology colleagues, has proposed to convert their cancer vaccine platforms into a novel vaccine technology against coronaviruses. And it's into that situation that we're invited in because New Zealand has an elimination strategy, which is apparently waiting for a vaccine, and we've had various dates that have been proposed for when such a vaccine would be around and available. And some of the developments in there that I think are particularly interesting for New Zealand, because if we are eliminating and if we are locking down, then we're waiting for a vaccine. And that's in which case that's a situation to which we invite Brien. Brien, are you there?
Yes, can you hear me, Mark?
Yes, we can. So fire away and we'll take questions for you at the end.
Sounds good. Okay, can you see my slide?
Can. Yes, we can.
Okay, great. And one final check, can you see the laser pointer moving around?
We can see that as well, yes indeed.
Okay, that's great, so I'll start. Okay, so thank you very much to the symposium organizers for inviting me to speak. I'm excited to be here. Welcome to all the participants. So I'm here to talk to you about COVID-19 vaccines, and just want to give you an overview of all the facts, give you an overview of what goes into vaccine development. And hopefully a lot of these facts will help those of you in New Zealand make informed decisions, especially those who are policymakers. So what I've done is I've set this presentation up so that I'm happy to provide a copy, and will provide a copy to the symposium organizers. Anybody's welcome to request a copy from them, or you can request a copy from me. I've inserted into here some hyperlinks for some additional reading. I've got a table of contents here if you want to jump right to some of the key areas, and I'm going to jump right into it then. So first of all, in terms of who I am indeed an associate professor of viral immunology. I'm trained as an immunologist, have a PhD in immunology, and do a lot of work with viruses. And indeed, one of the things that we've been working on for years is using viruses as vaccine vectors to try and treat cancers. And so these vectors that we work with are very much sort of plug and play compatible. We can use these vaccines to target any protein that we want, including proteins that are derived from pathogens. So in other words, these vaccines can really easily be adapted to infectious diseases as well. And so indeed, that's what we've done. In fact, the type of immune response that is most effective against cancers is the same type of immune response that's most effective against viruses. And so in fact, my group has been commissioned by the government of Ontario to develop vaccines for COVID-19. So we have funding from that. We've also received funding from the institution that I'm at, and we're actively pursuing this. And I'm working, it's a large collaborative effort at my institution, and we've made very rapid progress. So in fact, we currently have 4 vaccines that we've developed, and we have several more that we're working on. And a couple of vaccines are looking very promising. And that's a term that you will have heard over and over and over again, and will continue to hear over and over and over again. And I can tell you very bluntly that even though we have some very promising looking vaccines, they are not going to help us with COVID-19 at all within the next 4 years at least. But you'll see why we're excited about this research when we get to the end of this presentation. We do think this will be valuable in the future. Okay, so one of the things I just want to go over first before I begin with the science behind vaccines I just wanted to let you know that I teach the value of high quality and well-validated vaccines. The students that I teach can tell you I'm very passionate about it. I promote the use of vaccines. I really believe that vaccines are probably one of the best technologies that have ever come out of the field of immunology. It's the most efficient type of medicine. They can cost efficiently save millions of people from sickness and death. And so, on one hand, some people wonder why, if I'm developing COVID vaccines, do I sort of speak out against all of the promises currently being made. It's because I really care about vaccines. Okay, and so I feel compelled to speak bluntly as somebody, as an expert in the field, because for the sake of global health, we really need people around the world to maintain faith in vaccines, because vaccines are very important for maintaining global health. And if people lose faith in this through what I would argue is probably going to end up being, COVID-19 vaccine debacle, we don't want reemergence of diseases that are being well controlled now with current vaccines. All right. So in other words, I really worry about the potential damage to the credibility of the field of vaccinology if we keep pushing for unrealistic timelines. And I think you'll see in just a few slides what I'm talking about. So just to make sure we're on the same page, what we're talking about again is COVID-19, which is a disease identified at the end of 2019 called coronavirus disease. And it's caused by a virus called severe acute respiratory syndrome coronavirus 2. And this is number 2 because the original SARS coronavirus outbreak that happened about 17 years ago, that was the original SARS coronavirus. Here's a picture of what the virus looks like. And what I want to do is, many of you probably didn't think you're going to be learning about immunology. Immunology can be very complex, but it doesn't have to be, your understanding of it does not have to be all that detailed in order to understand how vaccines work. So before we talk about vaccines, I just want to take you quickly through a couple slides. If you listen carefully to these few details about the immune system and how it works, then you'll really be able to understand what's important in terms of developing a good vaccine against SARS coronavirus 2, which again is the causative agent of COVID-19. So first of all, what you need to know is that the immune system is a complex collection of organs, cells, and molecules, and they all come together in the body to get rid of dangerous microbes, things that we would call pathogens. So these could be bacteria or they could be viruses. All right, and what you really need to know is that pathogens can be subdivided into 2 basic types. There's dangerous microbes that live outside of our cells, and that would encompass most bacteria. And there's another set of pathogens that live inside our cells, and those are viruses, like SARS coronavirus 2. Okay, so keep in mind that there's these 2 different types of pathogens, and that also means that an appropriate immune response against viruses is very different from the one that's most effective against extracellular bacteria. Okay, so there's 2 types of immune responses that our body can initiate. And one of them is effective against viruses. The other one is designed to be effective against extracellular pathogens. So keep that in mind. Also, an effective antiviral response, so the one that we want against viruses, will induce 2 basic components of the immune system. T cells is one thing that we want, and antibodies. There's been a huge emphasis on antibodies during vaccine development, but there's no question that a really effective vaccine against viruses has to induce a balanced response. That means we want antibodies, and they have to be a certain type of antibodies, and we also need T cells. Okay, so we need both of them. And this again is very important. So we're talking about the antibodies. For antiviral antibodies, the correct type is probably more important than the quantity. So a lot of people are focusing on how much of an antibody response they can generate with the vaccines that are being developed right now. But in fact, probably what we should be focusing on are what type of antibodies are being induced, okay? Because certain antibodies are better than others at neutralizing viruses, okay? So the second the last couple of things you need to know about the immune system is that the immune system needs to see 2 things before it'll produce these T cells and antibodies. So the first thing the immune system has to see is it has to know what the target is, all right? So in this context, it has to know that it's supposed to be targeting the SARS coronavirus 2. So the vaccine could contain the entire virus, or it can contain a piece of the virus, okay? But we have to show the immune system something from SARS coronavirus 2 so it knows what to target. And the second thing that the immune system always needs is it needs to know that target is being seen in a dangerous context. So it needs an additional signal that's telling the immune system that yes, this target you're seeing is from something that's very dangerous and therefore it's worth responding to, okay? So keep that in mind, it's very important because these two things that are needed for our immune system to respond to a virus is, we're gonna come back to this in just a moment when we talk about vaccines. And finally, the other thing you need to know is the immune system has memory. And it literally functions like our the memory that we have embedded in our brains. So, but this is programmed into the immune system. And what this means is that once our immune system has responded to a pathogen, if it sees that pathogen a second time, it will respond much faster and much more robustly. And the consequence of the immune system responding much faster and to a much higher magnitude means that upon second exposure to a virus, our body can clear the virus before the onset of disease. So that's why for the vast majority of infections, once you're infected once, when you're infected the first time, you often get sick. But once you're infected a second time, you no longer get sick because the immune system has that memory and can respond so rapidly, it gets rid of it before we get sick. All right, so that's very important. That's why over time, as we develop immunity, we start becoming immune to more and more pathogens, and we don't experience sickness from them anymore. Okay, so that gives us a basic understanding of the immune system. So now we can focus on vaccines and then ask the question how these vaccines work. Okay, so first thing you'll notice right away, a COVID-19 vaccine must provide two signals. This should sound very familiar because this is exactly what we talked about. When the immune system naturally responds to a virus, it has to receive two signals. So what we want is a vaccine that can also provide those same two signals. So the vaccine has to contain the virus or a piece of the SARS coronavirus 2. And the second thing that it has to provide is that danger signal. So the immune system sees that SARS coronavirus 2 or a piece of it in a dangerous context. And that then causes the immune system to actively respond to it, okay? And the reason why we're trying to develop a vaccine against COVID-19 is because a good vaccine will actually simulate the natural infection. And what that means is it'll cause your immune system to mount a response against that pathogen, but importantly, without causing the disease, because we're not actually infected with the causative agent. We're not infected with the live replicating SARS coronavirus 2. But the vaccine, a good vaccine, is designed to trick our immune system into thinking that our body is infected with this virus, so we respond to it. And now you can understand why memory becomes important, because the most important thing that a vaccine can do is confer this immunological memory. So we mount a response, and then our immune system remembers this pathogen. And then what happens is, the idea then is when a person actually becomes infected with the SARS coronavirus 2, right? When they actually get infected after vaccination, their body's seeing the virus, is infected with the virus for the very first time. But because of the previous vaccine, the immune system actually thinks it's seen the virus for the second time. And so this memory response is triggered, and the immune system will respond much faster and much more robustly than it did to the initial vaccination. And the idea is it'll respond so well, our immune system will respond so well that we don't get sick, that we clear the SARS coronavirus 2 and we don't get sick. And that's what would prevent ultimately spread of the disease from us to another individual. All right. And what this means is that vaccination is a way that we can accelerate progress towards what we call herd immunity. And this is the concept shown right here in this picture, where people in yellow are those who have been vaccinated. And so they are immune to the virus. And then we have individuals that are in blue, that are a few individuals, right? And these are people who were never infected with the virus, nor are they immune to the virus. Maybe these are people who chose not to take the vaccine, or these may be people who are vaccinated but did not respond particularly well to the vaccine, so that they're not actually protected. And then we have people who were not protected, but got infected. And these are red individuals. And so the concept with herd immunity is that once we have enough people who are immune, we don't need everybody to be immune, but there's enough people that are immune. Those that then get infected with the virus and that could potentially transfer that to other people, chances are they're going to come into contact with people who are actually immune rather than people who are non-immune and therefore susceptible. And what this does, literally, the large group of people in the population that are now immune literally serve as a physical barrier between those who are infected and those who are uninfected but susceptible. That's how herd immunity works. What it means is we don't need everybody to be immune, but we do need most people to be immune. And for SARS coronavirus 2, the estimates have been anywhere from 60% to, most people would agree it's in the ballpark of 70%. Some argue that it's a dangerous enough virus that we need up to 85% of individuals to be immune in order to achieve this herd immunity and stop the spread of SARS coronavirus 2 through a population, okay? Now, to get to the question that everybody's probably most interested in is, there's been promise after promise after promise, and this is why I'm speaking up, because I serve on so many grant review panels where people are proposing research programs to develop vaccines, and I can just tell you that the promises that are out there right now are generally incredibly unrealistic. So what I want to just take you through very quickly is so that you can understand what's involved in the development of a vaccine from the very beginning to when it would be distributed into people among the general public. So what we start with is exploratory research, okay? And this phase is focused on discovering, novel technologies to use as a vaccine and then developing these, and that can typically take 2 to 4 years. One of the things I want to point out, first of all, is that, of course, all these timelines that I have listed here are kind of typical average timelines, and they can vary dramatically. So just keep that in mind. But then what typically happens is once we have a vaccine technology that we think looks pretty promising, it has to go into the preclinical research phase where we start testing it in animal models. And ideally, we start optimizing the vaccine technology in these animal models. And that typically takes 1 to 2 years. Then there's a translational research pipeline. And this is where the vaccine is really looking promising. We have to start developing manufacturing tools, right? Ways to manufacture this such that they'll meet what we call good manufacturing practice guidelines, which basically means they're of a quality that could be used in people. And also there's going to be a lot of experiments that are going to use different animal models. And this is where often the use of things like non-human primates come into play to really focus on the safety of the vaccine and to try and generate additional evidence that the vaccine is going to work. And now this is really important because what I want to say is essentially this stage it takes about 1 to 2 years. So what I'm going to say very bluntly is what I said about my own research. So the research that I'm doing right now is in the preclinical phase. I would argue that any vaccine that's currently in this first, second, or third phase of the research pipeline are not going to be of any help within the next 4 years. Okay, and then so in other words, the vaccines that hold the best chance of helping us with the COVID-19 pandemic are those that are currently in clinical trials. Okay, so now let's focus on the clinical trials. If you have a vaccine that's very promising, you're gonna apply to a health regulatory agency, and this usually takes a few months. This is not particularly time consuming. And what'll happen is you'll end up agreeing on a clinical trial design, and then you go and you execute that. All right, and then what happens then is there's 3 consecutive phases of human clinical trials. It typically starts with a phase 1 trial, or it has to start with a phase 1 trial. These are relatively small trials, and the emphasis is completely on safety, making sure that that vaccine appears safe. This takes about a year or more. So what I'll say, and what I have for these timelines, these are generally very conservative times that I have listed here, okay? So at least a year. Then typically it would move into a phase 2 human clinical trial if the vaccine appears safe. A phase 2 human clinical trial scales up. There's more people that are enrolled. And this again emphasizes safety, but there also has to be some evidence the vaccine is working. So perhaps maybe it has to demonstrate that it's inducing, promising looking immune responses. And this will typically take 2 years or more. And then the vaccine would migrate, if everything looks good, into a phase 3 human clinical trial. This typically lasts about 3 years. These are very large scale studies, and that will again emphasize safety, but also efficacy. The vaccine has to be demonstrated to work at this phase, or it will not be approved. So if a vaccine can transit through these 3 phases of clinical trial testing, then what happens is it can be approved for use, but then it has to be scaled up. And you see I've got a question mark here in terms of the timeline for this. The reason being is we have never in the history of mankind attempted to manufacture a vaccine on a scale that is needed for a global pandemic like the COVID-19. So we really don't have a timeline. but this is not trivial. This could take a very long time. People are arguing this alone could take, you know, up to a year. And then after the vaccine is manufactured, then there's the distribution administration phase. And the reality is we do not have an efficient distribution system set up, again, for worldwide delivery of a vaccine and getting this administered to people across the planet. So again, I've got question marks here. This is not, if you look at the testing that people are trying to do in countries, and the timeline it's taking to get testing done, that doesn't bode well for the distribution administration of a vaccine, which would rely heavily on very similar or even the same infrastructure that's being used for the testing. This could easily take well over a year. So in short, traditionally it has taken vaccines at least 10 years to traverse these clinical trial phases, so steps 4 through to 8, okay? And what I want to point out is Merck, the big pharma company, Merck, to the best of my knowledge, currently holds the world record for the fastest time to be able to get a vaccine through this clinical trial research phase, and that was 4 years. And again, this is a record. This is an outlier. This is not typical of vaccine development. All right, and I believe they also probably hold probably the second fastest time to vaccine migrating through this system, which is 5 years for an Ebola vaccine. Okay, so there's just a certain amount of scientific rigor that has to be maintained. It's very difficult to try and go below this, okay? And so what I want to point out then is, as we move on here, is some conclusions. All right, first, it takes a long time to develop an effective and safe vaccine. Now, efficiencies for COVID-19 vaccines can be built into the approval process, all right, through things like accelerated funding, streamlining the paperwork. There's an awful lot of administrative red tape. And also there's what regulatory agencies are doing right now is they're allowing some overlaps in the clinical trial phases rather than them running sequentially. The second phase is being allowed to start towards the end of the first phase, for example. But again, the efficiency should never compromise scientific rigor. And again, vaccines that are in the early stage are not going to help us with COVID-19 within the next 4 years. And the COVID-19 vaccines that are in clinical trials likely won't have a substantial impact within the next 2 years, okay? And this assumes that they work well and are actually safe and receive regulatory approval. I hope I'm wrong, right? And this is something nobody can prove. Maybe we will have a vaccine, but I'm just trying to put forward what the realistic probability is, okay? And then some other things that I just want to go over with you quickly is some other things you have to think about when it comes to these vaccines, all right? Safety, of course, has to be paramount, both real and perceived. So I want to just point out a couple of interesting things, okay? So after the original SARS coronavirus outbreak, there were researchers who continued to conduct research on a SARS coronavirus vaccine. So that was the first virus. And what happened is in animal models, the vaccine looked very, very good. But what happened in those animals that were vaccinated and had very good looking immune responses, it turned out that the vaccine actually caused the severe acute respiratory syndrome to be more severe than in animals that had not been vaccinated. And this was because the vaccine had actually induced the wrong type of immune response, okay? The immune response that was induced actually promoted inflammation in the lungs. And so then when the animals were infected, they had this much more severe inflammation in the lungs than what the non-vaccinated animals would have experienced. And the other thing I want to point out is there's actually an historical precedent for a warp speed-like vaccine program, and actually that went quite awry, okay? So for those of you who don't know, I've got an article here where you can get more details if you want. But in the mid-1970s, there was actually an influenza outbreak at a military base in the United States. And what happened is several hundred soldiers became ill and one died. It turned out that was the only person who died. But it caused such a panic that there was this incredible race put on to develop a vaccine. This vaccine was pushed through the system very quickly. And the resulting vaccine actually only got distributed to less than 25% of Americans. But what's of concern is it caused 25 deaths and more than 500 people to become paralyzed, okay? So in other words, this vaccine was much worse than the disease. It caused a lot more damage than what the disease itself did, all right? And the other thing that I wanna point out is that even if a vaccine is truly safe, if the process to develop it gets interpreted as, quotes, cutting corners, that could negatively impact uptake, okay? And there's this disturbing number of polls that are starting to appear where they're showing that quite a few people in the ballpark of 20% of people who would normally be okay with taking a vaccine won't be willing to take a COVID-19 vaccine. And in some of these, up to 30% are undecided. So this could have a big impact on progress towards herd immunity, even if a very effective and very safe vaccine were to be made. Okay, and the other thing I want to point out is, unfortunately, a lot of governments, so the original goal behind this vaccine development program that's going on worldwide was to get a vaccine that would actually protect us from the disease. But what's happened is the bar has been lowered quite dramatically, such that a lot of governments and regulatory agencies will now define a vaccine as being successful and therefore worthy of licensing for use in people if it merely reduces the severity of COVID-19 and or prevents death, right? So in other words, what we're talking about, if that's how a vaccine is going to function, it's really becoming a therapeutic intervention, which would be used after the onset of COVID-19 and would not be a tool to eliminate it from a population, okay? And the other thing is we have to ask, are these COVID-19 vaccines going to work in the people who need it most? So elderly individuals and those who are immunocompromised or immunosuppressed are the people who are suffering by far the most severe cases of COVID-19 and the highest death rates due to COVID-19. And yet they're actually the people in which a vaccine would by far work the worst, okay? That's important to know. And the other thing is, so vaccinating young, healthy people that are around these people can help protect them in theory, right? But it's also important to know that even in the relatively young and healthy where these vaccines would probably work the best, the responses to vaccines follow a bell-shaped curve. And that means even among those who tend to respond best to the vaccine, there's always going to be individuals who are what we call low responders, and they do not respond well. So as you can see, all this adds up to a scenario where, well, an ideal, so I'll just state what I have here, right? An ideal COVID-19 vaccine that could accelerate progress towards herd immunity is one that would protect against the disease, provide the appropriate type of long-term immunity, that's the immunological memory. It would have a broad safety profile, including in those who need the vaccine the most, who are also the most fragile among our population. And it would also have to be broadly perceived to be safe, okay? Now, I want to highlight again, I nor anyone else can guarantee that a useful COVID-19 vaccine will not be available in short order, okay? It might be. And I certainly hope that I'm wrong in my predictions and that this does happen, but realistically, the chances of that happening are very slim, okay? It's got to get through the clinical trial pipeline, as I mentioned before, so we've manufactured in massive quantities and widely distributed in order to have a substantial impact. And I just don't see how this could happen within the next 2 years. And on that basis, I would advocate that a lot of caution be exercised when developing policies around the assumption that a vaccine will be available anytime soon. And so what I'm going to do is I'm going to stop there. But again, what I've done is for those who want to request a copy of this. Oh, sorry. Let me just say one more thing. Just to get for those of us who are doing this research, what I do think is realistic for the COVID-19 vaccines is developing technologies for what I would call the next big one. And what I mean by that is a so-called SARS coronavirus 3. So in other words, a dangerous coronavirus that may emerge in the future. And virologists will tell you it's not a question of if another dangerous coronavirus will emerge, but it's a question of when. And so what happens is we failed. As scientists, we failed to follow through with developing vaccines after the first SARS coronavirus. We failed to come up with a vaccine after the MERS coronavirus. And we can't afford to fail again after this one. So if and when COVID-19 is in the rearview mirror, we need to stick to the program. We need to continue to develop effective vaccine technologies that can be vetted among the scientific community to identify those that are going to work the best, and ideally technologies that are plug and play compatible. So in the future, we can quickly respond to a future SARS coronavirus. So again, I'll end there for the questions. But what I do want to do is, let's mention is, for policymakers, the media and investors, what I've done is I've actually put together here 2 slides. It's 9 questions, okay? And these are questions that a vaccine manufacturer should be able to answer if their vaccine has been well vetted and And I would certainly say before putting any trust or faith, or for example, investors putting your own money on the line with these, you should get these questions answered and to your satisfaction. If these questions cannot be answered to your satisfaction, I would really start questioning the quality of that vaccine. So are there any questions?
Yes, thank you, Byron. There are a lot.
Oh, okay.
I'm gonna start with one myself for a moment though, because over the weekend, because we're in lockdown here again in New Zealand, I don't know how closely you followed it, but Auckland is in a level 3 lockdown, which kind of means only essential work, but you're allowed to get takeaways and go to the supermarket. That New Zealand, the Minister of Health said that they were working on putting New Zealand near the front of the queue for the vaccine, or a vaccine, when it's ready. How realistic is that? And perhaps just to ask as well that if we continue to lock down, we're not going to be very well exposed anyway. So would that have any role in putting us closer to the front of the queue for a vaccine should one become available?
That's a great question. So you could argue it in a couple of ways. If the virus has not spread widely through your population, you could argue that New Zealand is in greater need than some countries who are closer to that herd immunity through a natural exposure to the infections. But typically what happens in these scenarios is that most people are going to focus on distributing vaccines, I would imagine, to countries that can document suffering the highest rates of severe disease and deaths. And so in essence, you may almost be shooting yourself in the foot by not trying to learn to live with COVID-19, right? Like other countries are, but by actually having these very strict lockdowns and very much limiting the cases, you're kind of limiting the data that you can show to make an argument that the vaccines are going to have a big impact on health and reducing severe cases and reducing deaths, right? I think that's going to maybe be the top priority. And ultimately, the reality is the only way for any country to ultimately guarantee that it's going to have rapid access to a vaccine if it's developed is if they're developing it. And unfortunately, this is where we're seeing a lot of politics as well, right? So for example, I work in Canada. We have a case where an agreement actually was almost reached, got nullified because the other country that we were dealing with indicated the vaccine was being developed there, and they clearly indicated that their population would be the first to get it. And of course, Canadians would like to get access quicker, so they're looking for another partner. So there's a lot of politics involved, but yeah, by having a low number of severe cases and low death rate, you might actually be inadvertently putting yourself further down that line.
All right, I'll go back to the start. There's quite a few questions about the nature of immunity that are coming up in our list. There's been some dispute or lots of chat about whether it's antibodies or T cells that do the work, and early studies had found antibodies were not being produced, but then we discovered T cells are. I mean, what is the status there? What matters most, and perhaps why did we not know this to begin with?
Well, I'd say we do know what the most effective immune response is against viruses. Typically, there can be certain variations. We have to understand the viral biology, but in short, when you're dealing with viruses, you want both. You want both antibodies and you want T cells. The reason is antibodies are you definitely want antibodies for sure. Like if you had to choose between one or the other, you'd probably pick antibodies of the right type. The reason is what the antibodies do is if they're in the right location, they will bind to the virus and it'll do what we call neutralize the virus. So it'll prevent the virus from ever infecting a cell. So when the SARS coronavirus comes into our lungs, if we have neutralizing antibodies there, they'll bind to the virus and prevent it from infecting the cells in our lungs. If the virus can't get into the cells in the lungs, it can't replicate. And so we get rid of the viral infection. These virus and antibody complexes will be cleared and we clear the infection. But the reason why you want T cell responses is if any viruses get past that antibody barrier, if you only have antibodies and you get any viruses that get past that barrier. Once the viruses want to live inside cells, they have to be inside cells in order to replicate. So, and antibodies cannot get inside cells. So if you have any viruses that get past that antibody barrier and into the cells, you have to have T cells in order to get rid of those virus infected cells. That's why you want to have both. And what's actually been frustrating me a lot as a scientist, I've been very surprised because, so first of all, I'm not particularly surprised when companies release information. The reality is the information is publicly released by companies. The scientific information is really lacking. The details are so lacking that scientists can't properly assess the quality of these vaccines. And then what happens is if you, and then a lot of people have been focused on antibodies and reporting this, but even the scientific literature, as these things are being published, I'm not seeing the scientific data that I would like to see, which is what are the types of these responses? So we're hearing that there's antibodies being induced and or there's T cells being induced. But for example, when it comes to antibodies, like I mentioned, there's two categories of antibodies. There's antibodies that are ideal for targeting extracellular pathogens like bacteria. And the reality is if you have an extracellular pathogen, those are the types of pathogens that actually induce the highest magnitude antibody responses. So we get very excited because we see a high magnitude response. The reality is that a natural antibody response against a virus tends to be of lower magnitude, but they're the right types of antibodies. They're the ones that can neutralize viruses. Worst case scenario, and this is actually, so that study that I mentioned where a SARS coronavirus, so that's the first SARS coronavirus, when the vaccine was ultimately tested in animals, it actually made the disease worse. People thought, the scientists thought it was going to be great because they had great antibody responses, but these antibodies were designed to target extracellular pathogens. It's because the vaccine was being perceived by the immune system as it was thinking the virus was an extracellular pathogen because the virus was inactivated, so it couldn't actually infect cells and mimic the natural infection. So the immune system responded like it was an extracellular pathogen, produced great antibodies, but those antibodies, what they actually did was they actually promoted inflammation because they were wrong type of antibodies. So I just want to emphasize, we want antibodies and we want T cells, but we need the right types of antibodies. And the problem is if you just look in the blood doesn't particularly help because the virus isn't infecting through the blood. We have to remember that. We need the right types of antibodies in the lungs, right, where the virus is actually infecting the body.
Right. Now, if I get you right, you're saying that the work done on the SARS-CoV virus and earlier ones, vaccine work, that it's given no advantage to the current studies?
Well, it has given advantage. So that's why there's some vaccines that could quickly be put into clinical trials in many cases. But one of the concerns is what happened in large part. That's why I just want to emphasize towards the end of my talk that we have to, quote, stick with the program. What's going to happen is if COVID-19 ends up in the rearview mirror, it's no longer a huge problem. Our economies are going to be wrecked, right? And when economies are wrecked, often one of the places where dollars are diverted from is research, because research tends to be a luxury, right? But we have to continue with this because that's exactly what's happened with the previous coronavirus outbreaks. Is first of all, if you can imagine, if you're a large pharmaceutical company that's invested a lot into a vaccine and that outbreak is now over, you're not going to have any vaccines to sell. So they often then focus on what the next problem is. And those who fund, for example, academic research programs are also often focused on what are the current problems. And so when a problem is in the past, it's hard often to get funding for. But government agencies, everybody who's working on this vaccine has to continue. We can't have that attitude again that we'll worry about it if it happens in the future. We have to understand, we now have a history that suggests that we're going to get a dangerous coronavirus maybe every decade, approximately once every decade. And so we have to get these vaccine technologies fully vetted and not drop them after the pandemic has ended. And there's so many vaccines that are being developed. We have a golden opportunity to spend the next several years testing all these head to head and finding out which are the ones that actually look really good. Because the reality is whatever comes through the clinical trial pipeline right now almost certainly is not going to be the best COVID-19 vaccine. And in fact, we have to be a little bit careful because as I mentioned, if we're dropping the bar too low and saying we don't even need a vaccine that's going to be protective if we can just find one that's going to help reduce the severity of the disease after somebody's infected. The problem with that is that's going to occupy the manufacturing and the distribution pipelines and divert resources away from the better vaccines that are sitting in the background. So we have to make sure that we continue to work with the vaccines that aren't as advanced.
So it sounds like what you're saying is, given that time frame, because I think you said that no vaccine within the natural curve, or not demise, but the reduction of the epidemic, no vaccine within that timeline. Is it possible then that the money runs out, or the commercial advantage of producing one runs out because the demand goes away, and that's the companies will just stop? Do you think this time around?
It's interesting. It's interesting to say that, because of course, as these vaccines are starting to move through the clinical trials, again, there have to be more and more people recruited. And once it gets to a phase 3 clinical trial, there's no question what has to happen in a phase 3 clinical trial is volunteers who are vaccinated. We have to be able to demonstrate that population of vaccinated individuals experience lower rates of COVID-19 than those that are not vaccinated. And in order to do that, you need pretty robust exposure, among a population in order to be able to run that study. The lower the case rate, that's just going to make the number of people that are required to properly test the vaccine balloon. And so we're actually running into a problem in a lot of countries where there simply aren't enough cases. So in Canada right now, we have all kinds of funded COVID-19 research projects, and we're actually struggling to get people with COVID-19 recruited to do them, right? And it's going to be the same thing with a vaccine, because there just isn't enough of it circulating in the population to ensure that vaccinated volunteers get properly exposed to it, to see if it protects.
Right, and after that, you run into ethical problems about introducing the virus.
Exactly. Yes.
Okay.
Which honestly, I wouldn't want to be the person to do that for what I just said. We have to be careful. There's this antibody-dependent enhancement of disease, right? There are precedents for if you haven't designed the vaccine properly, right? It might look safe in a volunteer. Remember, with that vaccine I told you about with the original SARS coronavirus, there were no safety issues at all in vaccinated animals. It was safe in the vaccinated animals. It made the disease worse once they got exposed to the virus, once they were challenged with it, right? So we have to be very careful. So I wouldn't want to, I don't think it's a good idea to intentionally try and expose people to the virus for that reason.
Okay. So therefore, we can't skip any of the important parts of the vaccination development, particularly the trials. We just can't do it. We don't want to hurry.
Mm-hmm.
Okay.
Yeah. Like I said, there are efficiencies that can be built in, but only so much, right? So if 4 years is the record, to me, it's like, for a sprinter running the 100-meter dash, right? The world record is in the ballpark of 10 seconds, right? To expect them to cut that down to 5 seconds, like there's just physical limitations. And like there's physical limitations in the human body, there's physical limitations in that vaccine timeline that I showed you, this pipeline that things go through. You can only shorten it so much. You can only find so many efficiencies, right? In order to maintain scientific rigor, there's a minimal amount of science that has to be done. And I just can't see that being completed in a way that could see a vaccine widely distributed within the next 2 years.
So does the same go for the types of vaccines you were talking about, which aren't really a vaccine? They just lower they lower the condition, the experience of the condition.
Well, I think it's kind of the desperation. You see, so what I'm worried about now is there's been, like we know, there's been billions of dollars invested in the development of vaccine. The reality, let's face it, if we're just very blunt about this, if a vaccine does not become available to help us with COVID-19, and we do find that countries just naturally, that they work hard to learn to live with this virus in a relatively safe fashion. So like the previous speakers were talking about, so yes, we experience cases, but they don't translate into very many severe cases. They don't translate into very many deaths, and we are able to achieve herd immunity that way and that naturally. And a vaccine has never been developed in time to help us with that process. The reality is, right, we're going to look back on this and it will have been millions and millions and millions of dollars wasted, ultimately, in many ways, except for the continuation of trying to develop those for a future vaccine. But like I said, with that said, most of that money is the organizations that have the greatest ability to push these vaccines through the clinical trial pipeline, who have the infrastructure in place, are usually the big pharma companies. And like I said, it just doesn't make any business sense to continue developing a COVID-19 vaccine if COVID-19 is no longer a problem, right? So we're kind of in a situation where we almost need COVID-19 to last long enough for there to be vaccines, or there's going to be a lot of investors who are going to be very unhappy, and a lot of people running businesses who are going to be very unhappy, right?
So is a vaccine actually possible? You know, given the previous work that you would say didn't result properly and what was aimed for, is it if you worked long enough, would you get one? So either this coronavirus or a following one.
Okay, so it's interesting. I think this goes back a little bit what Dr. David Katz was saying as well, right? I would say, going beyond that, even if there is a good and safe vaccine that is made, again, there's no precedent for getting it manufactured in sufficient quantities and distributed worldwide in time to have a really big impact. And worse, so I just mentioned that in terms of, like, a lot of organizations now are redefining a successful vaccine as being one that basically gets used as a therapeutic agent after infection, right? It's not going to prevent infection. But then Dr. David Katz mentioned, and this is absolutely true, for those vaccines that are still aiming for preventing infection, the definition of a really good one would be one that's 50% effective, right? At this point. And as you mentioned, so I mentioned, getting back to the herd immunity, if people are saying, you know, are correct in that we need at least 70%, if not 85% of a population to be immune to achieve that herd immunity and stop the spread of the virus, then, I mean, you just start putting so if the vaccine was 50% effective, you're only getting 50%, right? That's the whole point. And that's why he was saying that, why that's an issue. That's not getting you to herd immunity, right? And then if you add on to that the fact that there's a growing number, because of these crazy terms have been applied to this, right? Using warp speed in a vaccine development program does not confer a lot of confidence with a lot of people. And in fact, it's caused a lot of harm, right? Like I said, you look, you do the searches, there's all kinds of surveys being done now. And on average, they're showing about 20% of people who would normally take a vaccine won't take the COVID-19 vaccine, just because they're thinking that the process sounds like it's not the safest. Yeah. So if you have a vaccine that would only be 50% effective in a population, and 20% of the population isn't even going to take it, and then you have, you know, the relatively small number of anti-vaxxers that would be on top of that, and of course, like, you know, you're just not going to achieve herd immunity anyways. So I think this has to be recognized. So I just really think that waiting for a vaccine, even if this does come through quickly, I still think when you add up all of the facts, it's not the right thing to lean on when making policies.
So in New Zealand situation, we've got a closed border. This is the final question, Byron. We've got a closed border. We've locked down because we found some new cases. Should we be waiting for a vaccine, or should we be trying something else?
So again, the hard thing that I will admit is no vaccinologist can say with 100% certainty that there won't be a vaccine. But like I said, if you look back at my presentation, you look at all the considerations, all the people who won't respond well to a vaccine, the people who won't be willing to take a vaccine, the unknown length of time to distribute it and manufacture it, outside of the long time it typically takes to migrate through the clinical trial pipeline, it all adds up to the fact that, you know, you got to do cost-benefit analysis. So it's the chances of one being available the next 2 years is extremely slim. I can't say zero, but extremely slim. And I don't think most people would want to develop policies for their entire country on something, on a chance that's extremely slim.
All right. Thank you, Byron. Thank you. Look, we wish you good luck with your own efforts. This isn't the first coronavirus, and it won't be the last. So we need people like you doing the work over the long term. So good luck with that. Thank you for coming on. Actually, Byron, if you're able to stay for just a little bit longer, there are a lot of questions on the Q&A list. Some of them would deserve a written answer quickly, if you're able to. If not, we do have some other experts on the panel who can probably have a go.
Okay.
Thank you
Thank you
very much
for having me. Appreciate it.
Byron.
Take care.
Okay, we're just a little bit over time, but we've got one more presentation before the lunch break, and that's from Senator Gupta. This is a video, pre-recorded video. Sinatra is a professor of theoretical epidemiology at the University of Oxford. So for the time gap, we decided we'd do it, and this was recorded on Friday. Her work uses mathematical models to understand infectious disease systems. She studies the evolution of pathogens to see if you can develop a vaccine from the evolutionary dynamics, what she's trying to do for a universal flu vaccine, and has been trying to do. As I said, this was recorded on Friday by Michael Jackson, who's a research fellow at the in biological science at the University of Canterbury. He's also a member of the COVID Plan B group, and he's actually the main guy who organised the schedule of today's effort. Sinatra addresses 3 myths about COVID. She says we can't keep it out. It's nothing like the threat to each of us that we first feared, and that we can get herd immunity, and possibly in some countries we are already close to it. I think you should stay watching for the questions that Michael poses at the end. We won't be having questions from the participants. By all means, put some up, because some of the panel members who are with us right now live, they might be able to answer some of those questions you've got. But about 35 minutes into this presentation, which is just under 40 minutes, she makes some comments about Western governments, including New Zealand, which have been in the past few days communicated around the world. She's saying that that Western countries have abandoned their international social contract with each other, and particularly with the poor and the developing world. And that concept is quite confronting in lots of ways, that we've retreated behind our border and forgotten about our obligations to everybody. So we'll play the video and enjoy the presentation.
So let's talk about these mythologies, which are local and of course have also become global. The first myth, I think, myth number one, is the idea that we can keep it out, whether at a local level or at a global level. So lockdown has been instituted, of course, in New Zealand and many other parts of the world, with actually 3 different purposes. So there are 3 species of lockdown. There's the lockdown that attempts to keep the virus in. And I think the original lockdowns in Wuhan and indeed in northern Italy were implemented with that purpose, which can be thought of as a fairly noble purpose. That is to say, we will make the sacrifices that are necessary to prevent a bug about which we don't know enough, which could be lethal, from spreading out of our locality. That has a long history, and there are accounts of this village called Eyam in North Yorkshire, where they, in the 17th century, when plague occurred in this village, they did this thing of, they made this collective communitarian decision to shut down to stop it spreading. And perhaps in those days, and it worked apparently, or maybe even if it didn't work, it's clearly something that to be lauded. It's something one might expect a responsible citizen to do. And maybe in those times it might have worked, but obviously in these times, with the connectivities between different regions across such long distances, it's not something that is very likely to work. And particularly with COVID, which is first of all largely asymptomatic in people, and then even in those who have symptoms, a lot of the transmission occurs before those symptoms are evident. It really wasn't something that we could do. But that's among the species of lockdown, it's one that one can understand. Then there's the kind of lockdown that has been implemented in New Zealand until recently, apparently quite successfully, which is to keep it out. And that is also very, very tricky with a pathogen like this, which is so highly infectious. It's very tricky. And then the other dimension of it that doesn't get commented on is whether it's ethical. Is it ethical to try and keep something out at a national level? Is it okay to operate at a national level to say, we are going to shut our borders, we're not going to let it in, we're going to protect ourselves? Is that really something that is either sustainable or ethical? It can only obviously be sustainable if some sort of mitigation of this threat occurs, which can either occur through other people becoming immune or if a vaccine is developed. And to keep yourself locked down until such a time, I think it is a questionable strategy from an internationally ethical, whether it conforms to what I would consider to be an international ethic is something I think should be discussed and isn't. So what happens when, what all of this, and the third form of lockdown, of course, sorry, the third species of lockdown is one where you know it's there and you try and do something to stop it from killing as many people as you know it might kill. So how can we understand whether any of these things make sense? So the way we've been trying to look at it, and one of the tools that we have at our disposal for understanding whether these measures make any sense, is the mathematical model. And there is a very standard mathematical model, which is basically what everyone's been using. People have been using different forms of it. Some are more complicated than the other. But essentially at the heart of each is this very simple SIR model, which is a compartmental framework in which people are either susceptible, infected, or recovered. Very, very simple. So it's like a structure in which you have boxes in which people go, and then sort of plumbing to take people from one box to the other. So people go from being susceptible to being infected by becoming infected at a rate which is here represented by the symbol lambda, and then people recover and then exit from the infected box into the recovered box. So this is a sort of metaphor, a model for what happens with diseases like coronavirus, where once you recover, you remain uninfectable, at least for the time being. And you can study the dynamics of these diseases by writing down a set of equations corresponding to this structure. And when you do that, what happens is you can see, cursor will work, that if you start off with a fully susceptible population, it's in blue, and you introduce an infected individual, then the infections will, at first will take a while, but then they'll start to, there's a period when they grow but at a very slow rate, and then they suddenly increase, and as they increase, they're basically munching, the bug is munching through the susceptible population, and there comes a point where actually the pathogen runs out. The number of susceptibles keeps declining, so there comes a point which we call the sort of herd immunity threshold, where there are sufficient numbers immune that the numbers infected can no longer start to increase, and they start to decline, and eventually they drop off. Meanwhile, the numbers who are immune or recovered start to grow, and then will plateau at a particular point in this, within a particular, this time frame of the first wave or the first phase of this infectious disease event following the introduction of it. And one of the critical parameters that determines the magnitude of any of these peaks is something known as the R0 of the pathogen, its fundamental transmission potential, which is a combination of parameters that are linked to transmission and how quickly an individual stops being infectious. In other words, the recovery rate, sigma here. So this is a sort of fundamental framework that we use to try and figure out what's going to happen with this, with an epidemic of this kind. Now, so what can we say? What can we use this model to say? Well, first of all, we can, the first thing that that becomes obvious is that it is very, very difficult at this stage, when it is silently kind of growing in numbers, to know that it is present in the population. Secondly, that we know that it is going to munch through susceptibles, that there does come a point where it will turn over and go away. And one thing that's been missing again in the discussions about this pandemic is that this is a dynamic system. It is a system that includes us. What happens to this disease depends on how many of us are immune in a population, how many of us cannot be infected. It is not like an independent event. It's not like a tsunami or a hurricane or a tornado or something that is external to us. We can't simply batten down our hatches and wait for it to pass. What we are in an interactive state with this bug. The fate of this bug is determined by our continuous sort of response to it. The degree to which we develop immunity is crucial to the fate of this pathogen. We cannot simply wait it out. If we wait it out, we remain in this state of complete susceptibility and therefore are continuously available as a resource for the bug. So that's the first lesson to be learned. Second lesson is that once sufficient people are immune, it will turn around and go away for the time being. Now, of course, what I haven't plotted is what happens in the future when people start to lose their immunity, either because they're naturally losing the immune responses that protect them against it, or even if immunity is lifelong, new people are born into the population. So eventually the bug does come back for a second wave, which is smaller than the first, and eventually what happens is it settles into what we call an endemic equilibrium, and that is the most likely outcome, most likely fate of this, of SARS-CoV-2. But what can we do in the short term with this sort of a model? What can we do now? So for one thing to note is we can sort of infer from what we know to be the duration of infection and the possible R0 of this bug, that the time course, the natural time course of this epidemic is really a couple of months. It's not going to, if you let it run its course, it should be over within 2 or 3 months. So we know that from this. Then the question is, well, how many people will die in that period of time? And that we can also infer, and that's what people have done, from this model, simply by saying, well, let's assume that a fraction of those infected will die. Now, naturally, that depends on what you use as that parameter, the infection fatality rate, the fraction of people who die upon infection. So if you use an infection fatality rate which is closer to 1%, you'll get a quite large number of people dying, such as was predicted by the Imperial College modelers, who said, 500,000 people might die in the UK over the course of this pandemic. However, if you assume that the cumulative, the infection fatality rate is closer to 0.04%, I mean, is more like 4 in 10,000, then you get a much, much lower mortality, cumulative mortality. Which of these actually fits the data? The truth, so in March, when the UK government locked down, they assumed that this top projection was the correct projection based on the deaths, the cumulative deaths that one had observed up to that point. But what we did is we put on the table this fact that actually They all do. From the data that we had up to the 24th of March, there was no way to tell what was going to happen, whether we were going to have a really high cumulative mortality or a low cumulative mortality, because we did not have sufficient data to pin down the infection fatality rate. And indeed, there were scenarios that were equally compatible with this data, including the Imperial College scenario where you had a very high cumulative projected mortality, which was predicated on the idea that the epidemic had only just started, hadn't infected too many people, and a large fraction of those had already died. That was one scenario, but another equally possible scenario was that the epidemic had arrived much earlier, sometime in January, or peaked or started to take off sometime in January, and that a significant proportion of the population had already been infected and only a small proportion had died. Both of these extremes and anything in between we showed was actually compatible with the data. So that meant that we didn't actually know what was going to happen at that point. So myth number 2, which continues to prevail, is that we are all going to die. Because one of the things that was already clear by then, which contradicts that, even though we didn't have an idea of what the overall infection fatality rate was, is that the infection fatality rate was not distributed evenly across age classes. So it was very, very low indeed, almost no deaths in children and teenagers, and really, really quite low in anybody under 65. That was already evident at that time, the UK lockdown. And what that means is that we can't really use that very, very simple SIR framework to inform our decisions completely, because what we at the very least need to do is consider that there is this sort of vulnerable fraction of the population in which deaths will occur. So what we really have are two systems which are linked by virtue of how they mix with each other, and which will have quite different dynamics in terms of what the transmissibility of COVID, of SARS-2 is within sort of a general population as opposed to a vulnerable population, and which can lead to different dynamics in these different populations, such that you could have a situation where in the general population, you get a kind of spread which you hardly notice because the symptoms are so similar to many other symptoms of cold and so-called, other even more severe respiratory illnesses. So you could have it, as shown in this orange line, the orange and red refer to what's going on in the general population. You could have an epidemic that's already spread and kind of petered out already, followed by a more visible one shown in the blue and the green in the vulnerable population. Alternatively, if the vulnerable population has been infected earlier, and if it's spread earlier within the vulnerable population, you could have a scenario where the vulnerable population, it peaks in the vulnerable population much earlier and is yet to spread through the general population. But you can have a variety of scenarios where you will not see in a second wave, for example, the kind of deaths that you see in the first wave. So what we stressed at that point is given these subtleties, that the only way we're going to be able to get a sense of who's going to die and how we need to manage the epidemic is by determining the levels of exposure in these different populations. And so in my lab, Craig Thompson, who runs the laboratory, set out and immediately developed a test to look for antibodies in individuals, which as a marker of who'd been exposed. And this is something that many other research groups also undertook. And also people were using measures of, they were also going out to see who was infected at all and trying to infer from that also how far it had spread in populations. So in other words, we have the means to measure this green line, or we thought we had, and this red line. And so that's what we all started to do, although not necessarily in a very joined up way, in March. And it has been a long slog. And the truth is we still don't have a very good idea of who has actually been exposed, for two reasons. One is that we've been focusing too much on how many cases there are, which is not because you are only PCR positive or you only carry the bug for a particular finite period of time. That doesn't give you a good sense of whether you've already had the infection. But secondly, and rather disappointingly for us, some of the tests that are normally very useful for infections like flu, where you look at the presence of antibodies in people to see if they've been exposed, are not doing the same job in COVID, because people don't seem to make antibodies as well, and those antibodies don't last for as long. So the levels of seroprevalence, which is to say the number of people with, proportion of people with antibodies in their blood, that we've been observing, does not seem to indicate that it's spread as widely as one might have hoped, which would give you the very, very low infection fatality rates, which would give us the all clear for going ahead and abandoning all measures to protect people from death. However, there is a third piece. So in other words, those, the results of these studies to look for how many people have been exposed to are typically returning values that people do not expect to be at the level of where you would get enough immunity in the population to preventing from spreading. But that leads to myth number 3, which is a statement that is very widely and indiscriminately thrown around, which is that we're nowhere close to herd immunity. And this is, it's very irresponsible actually how this statement is being made, because it's being made on the basis of a very simple calculation, which is based on an SIR model, again, with no heterogeneity in either exposure or in resistance or in vulnerability to infection. What we're starting to see now, a number of fascinating new studies are showing that with this new virus, we are actually, many of us actually have resistance, either from previous exposure to circulating seasonal coronaviruses, or due to better innate immune responses, or because of structural features such as not having the right receptor for the virus. For a variety of reasons, it appears to be that a proportion of the population is innately resistant, or already has a resistance to this virus. And once you factor that in, as we have recently done, you can show, and a couple of other groups have also looked at this issue from a slightly different perspective of how people are mixing, you can see that the herd immunity threshold can come down very, very rapidly under these, once you factor that in, once you factor in the resistance that is already there. And so this notion that we're nowhere close to herd immunity is really, again, a sort of myth that's being trotted out. And the reason I call it a myth is because what we're faced with now is putting together pieces of a jigsaw puzzle where we are seeing consistently that in places where cases are apparently rising, there are still no deaths in some of the areas where there have been a significant number of deaths. So some of the previous hotspots, such as London or New York, or indeed Madrid, where there are some hotspots where cases aren't rising at all, such as London, some areas like Madrid where cases are rising, but no deaths. So this is all very difficult to reconcile on the basis of simply social distancing being maintained in some of these areas. So it seems to me that one way of fitting together all of that data is by taking into account that herd immunity thresholds might be a lot lower than you would expect were we all equally susceptible to infection by this virus. So these are ideas that need to be out there, that need to be part of the debate, part of the policy making concerning this virus. And overall, I think taken together, what they suggest is this workable solution where we can go ahead and shelter the vulnerable to our best abilities, that we can, having done that, allow immunity to accumulate and monitor this on a very fine scale using the rather imperfect tools we have at our disposal. Obviously, at the same time, we need to invest in therapy and vaccination, but very crucially, we need to remember this is just one axis along which this tragedy is unfolding. We need to think outside national boundaries. We need to think along other axes, such as obviously the socioeconomic, but also what this is doing to what I call the aesthetic axis, what this is doing to the way we live, what this is doing to the arts, to our properties to our compassion and tolerance, and on all those ideas that we've tried so long to cultivate within our societies. So with that in mind, with all, these are my personal recommendations, and I think that what has disappointed me is that all of this is being treated as a kind of heresy against the sort of religion of lockdown, social distancing, and a sort of herd immunity, which is just a fundamental concept which Martin Kulldorff described, as basic as gravity. All of these are being dismissed in a manner that is very worrying. With that, I think I will stop and take some questions. Start. So with why did the Imperial College modelling get it so wrong, or why does it not seem to marry with some of the statistics we have? So what they projected was, as I said, it's completely within the bounds of what is possible, but it's a worst case scenario. So they took, essentially they're all the same, these models, they're all SIR models, and the only real difference between their projections is in this infection fatality ratio. So they used an infection fatality ratio which is very high. So essentially, how many deaths you're going to get just scales as the infection fatality ratio. Why did they do that? Well, their style of modeling is to have a very large computer model with lots of parameters in it, which they fit to available data, because that's what you do with that sort of a model. And their methodology was essentially that they took the large model, they fitted to what data they had at the time, which included this Diamond Princess cruise ship and a few other bits and bobs from Wuhan. And this was the best estimate they got using their statistical techniques. So their best estimate was the worst case scenario. And what we thought was that perhaps it was worth pointing out that actually that there was a very large range of scenarios that actually fit the data at the time, including one where deaths, for example, in the UK would have leveled at about 10,000. And I was rather hoping that that's actually what would happen. Now, of course, again, what apparently happened is somewhere in between. But our power of discriminating between those different scenarios is, of course, curtailed by lockdown having been introduced around the 23rd of March. But as you say, in Sweden, that didn't happen, although there was some social distancing and continues to be. some measures were taken. And so, I mean, basically at the fundamental level, I think there was the infection fatality rate was and continues to be overestimated. On top of which, the infection fatality rate is not a fundamental property of the pathogen. It is hugely age dependent. So that's one of the main, that's the main reason why you'd get it wrong, is you'd say lots of people are going to die when they get this. And that ignores the fact that many people are going to be asymptomatic. And it also ignores the fact, which you pointed out, that some people are innately resistant. Now, on that point, I think certainly my personal reaction to the news that that new virus had been detected, another coronavirus, was that, oh, well, we're not all going to die from it because we've all been repeatedly infected with other coronaviruses. But I assumed that T-cell immunity or antibody-mediated immunity to shared epitopes would be sufficient to protect from disease. I wouldn't have thought that it would actually protect from infection. But in fact, and this is why one needs to carry on learning as fast as we can through an epidemic, through a pandemic, it turns out that, or it seems very, very likely that these responses, particularly the T-cell responses, actually have an effect on infection, which is fantastic news. And that's probably, once you factor that into our thinking, everything starts to make sense. The low rates of seropositivity, the fact that it's not re-emerging upon easing of lockdown in many areas, the fact that it is apparently re-emerging in some areas, but there are no deaths. All of this starts to make sense once you put that in the mix.
Play devil's advocate, Jeanette, if we go back to February and March, where we really didn't have much information, it was a really dynamic situation. World Health Organization coming out with figures of 3.4. Could we argue that actually it makes sense at that stage to go with the worst case scenario, to come up with all, to use that precautionary principle? We simply didn't know enough. We didn't have enough data at that time. Does it make sense at that time to have made those decisions that we made?
I think one could certainly make the argument for it, and we were very careful at that point to say that if you did want to go with the worst case scenario, that would be the argument. Now, I think that argument, I think right from the start, though, that argument has to be made in the context of the socioeconomic costs of lockdown. So I think even at point 0, you have to start to think immediately about the socioeconomic costs. You can't delay that. So while you might think, okay, this is the worst case scenario, what can we do? Let's take the worst case scenario. I mean, you could start by saying, should we consider the worst case scenario, given that there is a probability attached to every scenario? And what was the probability really of that worst case scenario? Imperial College modelers would say the probability was highest for that worst case scenario. I may beg to differ, but anyway, let's say we first accept that principle that you must accept the worst case scenario, which I'm sure there are arguments against. Even then, we then have to start to think about what we need to implement in response to that. And then surely right at the outset, we have to start to consider the costs and the benefits. The lockdown has a very real cost. So maybe you could therefore come up with a solution where we do lock down for a month and get a sense of where this is going. I think at the point that we locked down in the UK, there was already sufficient information that the risk of infection was not, risk of death was not uniformly distributed across the population. So the potential for sheltering the vulnerable was already present. So, but let's if we wheel back a couple of months before that, you know, you've got a new virus, you don't know who it's going to kill. Well, yeah, maybe at that point you do lock down for a couple of weeks and see who dies in those weeks, and start to make decisions based on the observations. So it's a matter of gathering data, reacting to that data, but also not thinking simply along that single axis of this pandemic. Because even if you're thinking along the axis of public health, there are other diseases that are, you know, where the outcome is very adversely affected by lockdown. So even within the context of public health, it doesn't make sense to only focus on this one disease. But then, you know, there is the very important socioeconomic axis, which is absolutely critical. And so if we're thinking of a welfare state and how a welfare state should, or if we're considering, let's not even talk about welfare, if we're considering the overall welfare of the citizen, one needs to start to consider all these, take all of this into account on one single plane.
So Netra, you touched on this before in your presentation, and there, I've read some articles previously where you've touched on this, and you talked about the ethical aspects of lockdown, but you've also talked previously about a global social contract and what this means, not just for protecting our own citizens, but the damage that this is doing to other citizens and other people outside of our country. And I wondered if you could expand on that area, because I know it's an area that you're passionate about. It would be interesting just to get a little bit more understanding of what you mean by that. What's that social contract?
Yes, indeed. I mean, I would say that my main motivation for getting involved in this debate was that particular sort of sense of horror of what lockdown would do among people who were not in a position to sustain it for a very long time. In other words, the underprivileged, both in the UK where I live now, but also much more importantly in the rest of the world. So I have been horrified really by the acceptance of this sort of extremely nationalist perspective and rhetoric that surrounds the implementation of lockdowns and other, well, really anti-immigration measures that have come into place, or just restrictions on movement that have been introduced as a result of this pandemic. And I mean, the language of it is really quite disturbing. There was an article recently in one of the papers written by two epidemiologists who said, well, the UK should lock down. The UK should just close its borders. It shouldn't allow anyone to get leave or anyone to come in, because we can actually contain the epidemic. And this was supposed to be a communitarian statement. And to me, it's extremely insular and nationalistic in its content and thinking. I mean, the whole thought process around it is extremely regressive. So I find it quite strange that people are willing to adopt those sorts of attitudes and the kind of language that you'd normally, you know, really, you know, take exception to when it comes to protecting your citizens against a virus which by now we realize whose threat can be contained by using particular, by shielding the vulnerable.
So, Netra, I have one last question for you. So thank you very much for your time. And because this is a New Zealand conference, let's be quite New Zealand centric here. I want to be really positive about this, and let's look to the future and how we can make this better. If you were in a position to advise the New Zealand government, you're obviously aware of the latest information around our lockdowns, regional lockdowns in Auckland, but also nationally. If you were advising the New Zealand government, what would be your advice on how we should proceed? Are there any models internationally that we should mirror in terms of our approach? I mean, what would be your words of wisdom to New Zealand?
Well, I would recommend the Swedish model, and I would invest heavily in sheltering the vulnerable over a particular period, which is, as we can see, you know, it's not a long period. It's a period where of maybe 6 months. I know it's painful, but you know, it's the best we can do. And the alternative is to lock everyone down, which is going to harm the vulnerable, I mean, or have equal consequences for the vulnerable anyway. I would allow the virus to spread naturally and so that you do achieve the herd immunity levels naturally that seem to be protecting the rest of the world. And in the meantime, of course, I would also urge investment in, as I said, in research to mitigate the suffering of those who do, unfortunately, succumb to the virus and develop symptoms. And I mean, I think what was I going to say? I think the very positive note I would like to end on is that by doing so, New Zealand itself could emerge as a sort of perfect model now of how to deal with this pandemic.
Professor Gupta, thank you very much for your time this morning.
Thank you.
That was Sunitra Gupta, University of Oxford, speaking to Michael Jackson from Canterbury University on Friday afternoon. We've heard this morning from a range of international speakers who have provided some options for New Zealand, all of which have been very positive about how we can take advantage of the good start to show the world what the next steps out of coronavirus would be. That's the end of the morning session. We'll resume at 1:10 with Simon Thornley, Grant Morris, and Anish Chaudhuri. And we've had hundreds of people watching in over the course of the morning through participation in the webinar and over YouTube. I much appreciate that, and hopefully you've learned some things and have been asking yourself some questions. If you have questions, please send them to us, put them on the Q&A. We are trying to answer as many as we can, and we will resume at 1:10. Many thanks. Welcome back, everybody. We had a fantastic morning session with international speakers. If you've missed any of those, you can see the videos on covidplanb.co.nz website. There'll also be links on our Facebook page. And each of the videos will be separated out so you can watch any or all of them and bits that you've missed. We'll also be releasing a very short highlights video of some of the main things that were said. And it was fascinating to hear international perspectives on New Zealand's situation, and all of the speakers gave some solutions to us that they suggested we could adopt. If you liked any of those presentations, or you like any of the ones you're going to see this afternoon, and you want more from the COVID Plan B group, and it seems like we might have to be at this for a little while longer, please donate. This symposium has been made possible because of donations from the public, and that's the only way we can continue to do this. So go to the covidplanb.co.nz website, press the donate button, and give whatever you can. Many thanks. Right, this is the New Zealand section of the symposium, if you like. And first up is Simon Thornley. He is an epidemiologist at the University of Auckland, a senior lecturer. His research interests include epidemiological methods and the link between scabies and important diseases of childhood, such as acute rheumatic fever. Many of you will know that Simon Thornley is the founding member of the COVID Plan B group after one of his first piece, which I think was the first person to suggest that the approach New Zealand was taking was not necessarily entirely the right one. Simon has been leading light for the group and continued with his research over this period. So Simon, are you with us for this presentation?
Yeah, so
Okay.
Can you hear me, Mark?
Yes, we can. We can see your presentation on screen as well.
Oh, great. Okay. Well,
Over to you.
thanks everyone for coming along, and thanks Mark and Verity for putting this together. And it's very humbling to have the international speakers here, and many of them have had ideas that have influenced my thinking during this episode. So I'll try and give you my take on it from an epidemiologist's perspective, considering what's the magnitude of the threat, evidence for hard lockdowns, and what about the next step. We'll also touch on some of the modelling. So I think we've all seen the pictures of mass graves, intensive care units full, new hospitals in Wuhan, the potential source in the wet market. So digging into the science, what do we know? Well, a new coronavirus was discovered. That means that it was not necessarily new, but that it had first been discovered. So that's a novel coronavirus. And coronaviruses are not something that we know a lot about in medicine. And so I had to do a bit of study about this. SARS and MERS, the headline grabbing ones, but the ones that don't tend to grab the headlines are influenza-like, the ones that cause influenza-like illnesses, or the common cold like HKU1. There was a case series from Wuhan initially with respiratory illness, a characteristic pattern in the radiology, and a high mortality. And as Dr. Katz pointed out, particularly in people with chronic disease, diabetes, and cardiovascular disease, what he referred to as metabolic disease. And there was also the question about whether this was a zoonotic disease, so that the virus is similar to one found in bats, and that it may have been passed on through pangolins to humans. What were my initial thoughts? Well, I'd lived through the swine flu epidemic in 2009, and I've been part of the public health response at various times. And there was a real clamor about a high mortality initially from hospitalized cases, and public health units all trying to stamp it out. We're dishing out a lot of Tamiflu. And then once needles were put into arms, we showed that in New Zealand that the infection was almost ubiquitous. 1 in 3 of us had positive antibodies to H1N1 swine flu. And so things calmed down a little bit after that. What are some other things that we know about the seasonal coronaviruses that cause influenza-like illnesses? They are nasty when they get into rest homes, and they can cause a high rate of fatality in rest homes, not unlike what we've observed in this coronavirus. So my thoughts initially was, how serious is the virus? And we really need to look at the infection fatality rate. And the initial testing was confined to the symptomatic. So there was a perception that it was extremely deadly. 3 in 100 were reported to die from the infection, which makes it a lot more than seasonal influenza, which is about 1 to 5 in 1,000 die. And we've also seen evidence of excess mortality, and that was the question I asked for Jay, was that in Europe, for example, we've certainly seen high mortality in the older age groups, and that's been driving this spike of increased mortality in Europe. So with the infection fatality rate, the story goes that initially the numerator consists of the deaths, and the denominator is the positive cases from the genetic test or the PCR test done in hospital. And then South Korea started looking at the community with PCR, as did Iceland, and found that there were many more, many of them asymptomatic. And then serology started to get online with a few false starts and some inaccurate tests. And then we found also that T cells, there was a specific T cell response. And so this denominator has gone wider, larger, which has brought the infection fatality rate right down. So just digging a bit deeper into the numerator, the deaths from COVID, we see that there's been pretty clear that there's been an exaggeration of the deaths. There wasn't a good definition of death from COVID early on. And in fact, in an Italian review, only 12% of the initial fatalities were actually due to the virus in a government review. And we've also seen that the mean age of the case is about 80 years, which happens to be our life expectancy. And Spanish flu is the mean age of deaths, which has sparked some of the concern around COVID. The mean age of deaths was about 26. And the denominator, so we've talked about the denominator and how that's progressively enlarged as serology has come on board. And so Jay talked about the dialing back of the infection fatality rate to a median of 0.26 with a range between 0.02 and 0.86. And as we discussed earlier, with the peak in fatality, it's likely that it's a little bit more than the range of seasonal flu, but not much more. Here I compared the age of deaths of COVID cases from the government website with 2019 distribution of deaths, also from a government website during the same period the year before. And we see that the nature of these distributions is very similar. suggesting that survival with or without the virus is not dramatically changed. We know that rest homes are particularly vulnerable in almost all countries. A lion's share of the deaths have occurred in rest homes, and it's been between 20 and 60%. So that's where our priority was as a Plan B group, was to protect both hospitals and rest homes and the capacity in public health. So let's just think about the infection fatality rate in New Zealand. We had 22 deaths. This maybe needs to be updated now, but about 1,500 cases, fatality of 1.4%. We've seen that overseas, where serology has been done, that increases the number of cases, as Jay talked about, by a factor of about 50-fold. So that we get an infection fatality rate much, much lower. And that questions why we are taking such drastic measures. Obviously, that has to be tempered with other information that we've seen of mortality spikes. However, I think that is largely related to nosocomial transmission in hospitals and in rest homes. And there's certainly been public discussion of some mistakes that were made in terms of sending convalescing patients into rest homes where there's been large outbreaks of the virus. David Spiegelhalter, a hero of mine in the statistical world, probably one of the world's best known statisticians, compared the age-related fatality rate for British men and women with the fatality rate, which are the dots here, for COVID cases, and found that they were about the same. And his quote was, having COVID is like squeezing a year's worth of risk into a couple of weeks that you have the disease. And so there, that explains the peak that you can have in the overall mortality, whereas actually the area under curve for mortality, we'll only know this and once the epidemics died down, may not be substantially different from previous years. In terms of case series, we've found a high proportion of cases have metabolic disease, diabetes, cardiovascular disease, and cancer. And certainly previous work to this has been looking at sugar and refined starch as important causes of these diseases. And so one thing I got from this morning's session was Dr. Katz talking about optimizing and assessing our risk. And I think that's an important point. What about the lockdown? That was one of the most dramatic public health interventions I've seen. I question, where did the evidence come from? It came from China. In Wuhan, there was an early lockdown, and then there was a later harsh lockdown. And there's some evidence, I suppose, that there was some benefit, although it's very hard to tell in these time series analyses. What I saw early on was a paper by Wilfred Riley, a political professor in Kentucky, and he compared states that had lockdown with states that hadn't and found no difference. I built an app looking at his data and also at country data. And I'll just see if I can share that. May just take a little bit of time to see. But if you compare stringency of lockdown for each country, so here we have lockdown, oh sorry, stringency. So these are higher lockdown over here, lower lockdown over here. And we look at the cumulative cases in terms of deaths, or we could look at cases And we see on average, those who locked down, like Peru, Bolivia, Ecuador, Brazil, and Europe, we've got Italy here, they had higher rates on average of cases than those that locked down to a lower extent. Here's Sweden down here, one of the less restrictive countries. So certainly not strong statistical evidence of benefits of lockdown. And actually I've taken account of a whole bunch of other factors like testing, GDP, age, hospital beds, diabetes, and even after doing that, you don't see great benefits. Let's just get back to lockdown. So what we've seen also overseas is increasing evidence of immunity. So high levels in northern France, lower levels in parts of the US, but certainly much higher denominator and spread of the virus than we've assumed. So putting COVID in perspective, John Ioannidis, he's been referred to, Stanford professor of epidemiology, who I have a lot of respect for, said that the risk of COVID, even in heavily hit countries, is about the same risk of driving a car 15 to 100 kilometers a day during the pandemic. That's for people aged under 65. And so if young people or working age people and children are at so low risk, one has to question, why are we shutting down workplaces, shutting down schools? Why are we not protecting the elderly? There's a few downsides that we've observed in New Zealand from the lockdown. For example, a spike in rheumatic fever cases in Wellington. This leads young Māori and Pacific children to die early. Also, many more people going on the benefit since the lockdown, another 50,000 almost people getting out of work, billions spent, national debt escalating, about $2,000 per capita in New Zealand spent on the subsidy so far. And concern about particular areas that are dependent on tourism and our national debt, which we've only recently recovered from. We know there's a strong association between suicide and unemployment. And although we've been reassured that there's been no excess suicides, the government actually hasn't released the data on this from what I've seen. Seen internal documents from the government showing that a cost-benefit analysis is about 96 to 1 in terms of costs compared to benefits, and that's putting dollar values on lives. And so the government advisors were actually saying that the response was disproportionate. Modeling's been a feature, and Sinetra's given us a crash course in epidemic modelling, so I won't go through it. But basically it involves people moving from the susceptible to the infected and the recovered. And there's an assumption that everyone's susceptible and that the infection fatality is high, and we extrapolated data from overseas and we got very large estimates, 80,000 deaths in this headline. People must be wondering, how are these so inaccurate? And just going back, looking at modelling the New Zealand outbreak, question on my mind was, how effective was it and how many lives did it save? I want to get this work published, but here's an early view. The lockdown was instituted here. We expect after a week or so the effect of the lockdown, and we allow the curve to diverge, and it does from the expected, but it's rather subtle. If you total up the expected number of cases compared to the observed with and without lockdown, you get about 100 cases difference, which translates to about 1 death. Others have looked at Europe, and we expect this slow decline in the growth rate. That's something that happens during an epidemic and is responsible for the characteristic up and down curve. We've actually seen a delay in that, the slowing of the growth rate in lockdown countries. It wasn't so marked in Great Britain, but certainly marked in Italy, France, and Spain. So why did the models get it wrong? Well, I think there was an assumption that this is a totally new disease, a totally susceptible population. It's become clear that there's some cross immunity from other coronaviruses to SARS-CoV-2. And so the modeling really, it looks very sophisticated, but all it gives you is this characteristic curve. And as others have said, even the modeling itself doesn't justify reducing numbers or eradication, because the area under the curve is the same in each scenario. So this is comparing the model with the observed reality. And having some experience doing these models and trying to forecast epidemics, I know that it is very easy to get it wrong with models compared to modeling to analyzing observed data. So we assume that the New Zealand population was entirely susceptible. There's likely background immunity of between 40 to 60% due to other coronaviruses, and there's the reference to that. What about elimination? If you're going to pick a virus to eliminate from New Zealand, I wouldn't be picking coronavirus. Many coronaviruses are endemic, for example, HKU1. There's many asymptomatic cases, very difficult to contact trace. Sensitivity of the PCR test is not ideal. Clinical syndrome is is indistinguishable from some other respiratory viruses. And we may get very low cases because we're developing immunity. It would be nice if we had some information in that area. There's been some early promise, though. It's undeniable. There's been 3 months without a case, but I think it's too early to celebrate success, since the usual WHO criteria for elimination is interrupted transmission for more than 36 months, high quality surveillance, and confirmation with genotyping. And what's been concerning to me is the changing government goalposts on lockdown. So it went from protecting ICUs and hospitals and public health, the flattening the curve idea, to go hard and go early, and then elimination to vaccination, which Byram's covered, the vaccinations looking like a very remote possibility. And now we've got 4 cases, and I am now currently in level 3 in Auckland. So just wrapping up here, what do I think we should be doing? Well, I think there's a few lessons I've learned over this. Favor collected data over models. Vaccines a long way off, and as Byram's talked about, the people who are going to benefit most are going to be least have less of a response from the vaccine. I think we need to get back to work in schools. We've lost a lot of jobs. A lot of people are hurting financially. What do we need to do? We need to do good infection control in rest homes and hospitals. And I think that's one thing New Zealand has done well in terms of segregating COVID positive patients from other patients and protecting vulnerable people. I think elimination is unrealistic. Shutting the borders in society, is it really worth it? I don't think it's justified given the infection fatality rate that we've been seeing. And as Jay pointed out, serosurvey and understanding our immunity to the virus is I think, very important for driving policy decisions. So thank you very much. It's been humbling to see how many people have tuned in, and happy to take any questions.
All right, thank you, Simon. So yes, we do have a range of questions. I just want to assure everybody that we're watching the questions and trying to meld them together, the ones along certain themes when we're putting them to the presenters.
Sorry, I've gone over time a bit.
Yeah, Simon, that's okay. So we've got a couple of minutes to put some questions to you, though. One of them is this problem around modelling. I mean, at the start of every one of these epidemics or pandemics, we don't know things. So we do need models, don't we, to make decisions. How can we get the models better for next time?
Yeah, that's true, Mark. You know, I've been involved in measles outbreaks, and people have asked me for models, and I've made models to predict what's going on. One thing that I haven't seen in this outbreak, which I think is concerning, is that there's been very little updating of the models with observed data. And that was crucial for me to get things anywhere near right with measles and mumps. I think just a level of skepticism on the terms of decision makers with models, that there's a whole lot of assumptions, and it's easy to get things wrong, and putting too much confidence in them is a mistake, in my opinion.
So is it typical to be to know so little about a virus as the previous coronaviruses? Have we known little about them when they've started as well? Is it typical for the medical fraternity, public health fraternity, to know so little?
Well, I think coronaviruses have been really small type. I mean, obviously there's been the public health headline grabbing ones, SARS and MERS, but generally, we've just labeled a lot of this as influenza-like illness, which I think gives you an indication that it's an area that hasn't been studied in detail. And so it's been interesting to see that these papers that crop up with coronaviruses wreaking havoc in rest homes that really haven't been a major consideration in public health or medical decision making.
So you mentioned swine flu, and that when that had occurred here in New Zealand, you were ready to take, you and your colleagues were ready to take some action, but noticed that it was 1 in 3 people were infected, and so you'd sort of escaped the window of opportunity, as it were. It was out there. So the public health advisors changed their minds on the data. Why do you think that hasn't happened this time?
That's a good question, Mark. I was really hoping to see a sero survey early on, which I think was important in terms of understanding how protected or not the public are, what the exposure of the virus has been. Seems to me that there's no good reason not to do a sero survey. I mean, sero surveys in some parts of the world have produced disappointing results, and the prevalence of serology has been lower than expected, but T-cell responses to the virus seem to be more important than, for example, H1N1. So yeah, that whole area of population immunity, which from a disease modeling point of view and projecting risks and making policy seems so important, is really a black hole in New Zealand. And I can't really understand why that Ministry of Health is so lax on this, given the swine flu story.
A question about your study into lockdown, or the effects thereof. I mean, lockdowns are regulated thing that the governments have decided to try to do. But you will remember just before lockdown here, and a couple of days leading up to it, that people were already responding themselves. People were not going into work. We didn't see masks at that time, but people had already decided to slow down their public appearances, to go out into public. People were wary. So yeah, that's going to happen anyway. So you can't kind of measure the accuracy of a lockdown just by the government regulated period. There's going to be a natural tendency of people to be careful and wary anyway.
Yeah, well, it's not. Sorry, it's that particular analysis is just looking at the move from level 2 to level 4. So all the social distancing, everything that was happening before that is really not part of modeling that effect. It's really looking at that specific date of moving from level 2 to level 4. Did that do anything extra? Because it certainly had profound consequences for our lives.
Yeah, I think the point of it is, though, that some people are saying, well, people are going to be wary anyway. So the economic impact, you can't sheet home directly just to regulated lockdown, but to people's wariness and in response to what was being presented as a pandemic. Another question here is about whether or not you could explain the Swedish model versus the other Nordic models. Swedish model is back in contention again, let's say. In fact, the WHO themselves, special envoy on coronavirus, had said a few days ago that the Swedish model had a lot to commend it. So I wonder if you were able to explain the difference between that model and, say, other Nordic countries.
Well, yeah, I think the Swedes decided that social distancing and flattening the curve was a good idea, but they certainly didn't lock down, and they had this idea of writing it out with herd immunity, which is how we get over 99% of viral pandemics. And so I think they learned some lessons about protecting the elderly and particularly the rest homes, which I think we can learn from. But I think, from my point of view, it's a sensible model, and certainly that idea of monitoring our hospitals and public health capability and getting on with life as much as possible, I think, and protecting the frail and elderly, obviously. But for the rest of us who are very low risk, getting on with life, I think it's sensible.
One other question, I think, one time that's just popped up. Is the pandemic over? If you look at the rest of the world and the numbers, the results, would you say it's over?
Well, that's a good question, because that characteristic curve that you see from a viral epidemic, that can only really happen if the transmission of the virus is either interrupted or where the virus is running out of susceptibles, and immunity is more important. And I think overseas, where you've seen that the virus there's been many cases, that they're likely to have immunity, and that any second waves will be very small. It's still balancing, trying to work out in New Zealand where we're at is hampered by lack of data. We still really don't know what our immune status is. My guess is that immunity is much higher than we expect, but it'd be nice to see some data.
There's been quite a few comments about seroprevalence studies today and on the questions as well. But there have been those sorts of surveys done in other parts of the world, including the countries that are still locking down or trying to in various ways. Those, the changing IFR doesn't seem, influenced by the seroprevalence surveys, doesn't seem to have changed the nature of most of the Western countries regulatory response? Would it do so here?
Well, I think Europe, for example, is opening its borders and they're relatively relaxed about imported cases. Iceland is in the same boat. So I think you can see that the government has taken quite a different approach to the risk posed by the virus. And I think perhaps that information has helped. It's hard for me to get inside the head of the government to see how they're making these decisions. But yeah, I think we really haven't seen any indication that from the government that those early infection fatality calculations need to be updated, and I think that's important.
All right, thank you. There are a bunch of other questions popping up on my screen that have come in as you've been talking. So you're sticking with us for a bit longer? Yeah, well, if you could take a look and see if you could answer some of those questions directly written to them. So people keep on firing questions at the panel. Thank you, Simon, for that. We'll switch now to Grant Morris. Grant is an associate professor in law at Victoria University in Wellington, an accredited mediator, has worked as a facilitator and negotiator over the past 2 decades. His research areas include mediation, interest-based negotiation, and New Zealand's legal history. And he has also got involved over the past couple of months in the legal ramifications and implications of COVID-19 and the government's responses. He's also one of the COVID Plan B member groups. And over to you now, to Grant, with your presentation.
Cool, tēnā koutou, and thanks, Mark. Can you hear me okay?
Yes, we can. Go for it.
Right, I'll just share my screen now as well. Can you see that okay, Mark, with the PowerPoint slides?
Yes, we can. It's up.
Thank you. And today, as Mark said, I'll be talking a little bit about the legal ramifications of the COVID crisis. And as many of you will be aware, the Plan B group was set up as a multidisciplinary group led by public health experts such as Simon. But the idea was to come at this problem from a number of different perspectives, including law, economics, and other key areas. And while this is fundamentally a health crisis and a health issue, there's a lot of other things going in together. And we would argue as a group that they are interlinked. So you can't deal with one in isolation, but rather you need to deal with them as an overall response. And we've heard that today already from some of our speakers, where it's not lives versus the economy, it's not lives being separate from the economy, but rather an holistic perspective. So what I want to do today is just talk about some of the law related to COVID, and in particular, some of the legal issues that have arisen, and also in particular, those relating to civil liberties, and how that plays out in a New Zealand context. I started my journey with the Plan B group fairly early on in the crisis. So a week after lockdown, I wrote a piece for Radio New Zealand, asking questions about whether the government was approaching this in the best way in terms of getting compliance and support from the public, and whether there were other ways rather than focusing on fear and legal sanctions, other ways of getting the cooperation and necessary reaction from the public. And I'll talk about that later on today. So let's start with some of the legal frameworks for setting up the COVID regime. So basically, the government was relying on 3 acts: the Health Act 1956, the Civil Defence Emergency Management Act 2002, and the Epidemic Preparedness Act 2006. So those were the 3 acts which formed the foundation for the first lockdown in late March. Now, as has been shown, these acts had gaps, and they were not really fit for purpose in terms of dealing with this particular crisis. And we saw in particular during the first 2 weeks of the crisis that there was a lot of confusion. Could you go to the beach? Who was allowed to open? Butchers versus supermarkets. You know, what sort of exercise could you do? What were the rights and the protections on the citizens? What were the powers that were given to police? So there was a lot of confusion. And then when the subsequent Section 70 notice came in under the Health Act 1956, that clarified some of it, but there's continued to be legal questions around what was actually allowed, and also the legal robustness of the government's response. Because of that, we had recently Parliament passed the COVID-19 Public Health Response Act 2020. And this is really an attempt to fill those gaps and to make sure that for subsequent lockdowns, like the one we currently have, there would be a more firm footing for the government's actions. So Plan B was able to make a submission to the Public Health Response Act, which I authored and presented orally at the Select Committee. And there are some major issues with the Act, but it has to be said that it is more comprehensive than the other three. So the other three are still on the statute books and still supplement the specific COVID legislation. But we did need that specific act to clear up some of those problems. But that's only in the area of statute law, because we also have, of course, case law or common law going through the courts. And you'll be aware of two cases in particular that came up in the courts and received a lot of publicity. And the first one is Christensen and Director General of Health in May 2020. So both of these cases are judicial review cases. So that means that the applicant is basically saying that the government has not followed the correct process. And the High Court of New Zealand has to make a decision as to whether the executive has indeed acted outside the boundaries of the law or not. So in the first one, it was quite specific in the sense that it was the son whose father was dying, and he was looking for an exemption to be able to leave quarantine to visit his father. And of course, there'd been this blanket ban basically on those exemptions, but this applicant successfully applied to the High Court to get that reviewed, basically on the basis that the legislation, the Act provided for these exemptions, and when it was reasonable, they should be considered and granted. And so that was a success in terms of judicial review, remembering it's focusing on the process, so rather than the substance per se. The more wide-ranging and high-profile case, though, has been the Borrowdale case, which has recently been heard by a full bench of the High Court. So that's Borrowdale and Director General of Health in July 2020. And this case, brought by Andrew Borrowdale, who's a former law academic and legal draftsman, tests the overall legality of the first lockdown. So all those gaps I was talking about before and confusion. Was the government acting under the law? That's the big question. We were all hoping that someone would take this case and wondering who might be the best person to take it. Andrew Borrowdale has received support in taking the case. The court has received advice also from organisations like the New Zealand Law Society. It's a very important case, but it has to be said that any result from the case is largely going to be retrospective in the sense of telling us what happened rather than what is the state of play now, because a lot of that confusion has been cleared up by the subsequent act. But that's still important. From a legal point of view, we need to know that the government is acting under law and that New Zealand operates under the rule of law, and that even if the event has passed, what was the situation, and to make sure that if it happens again, things are done more effectively. Also, of course, there were a number of convictions under that first lockdown, and there will be ramifications, one would imagine, for those should the applicant be successful in that case. So there's a lot going on here in law, and my colleagues in the Legal Academy have spent quite some time debating this in public and providing seminars, and some of it is very exciting and very interesting, some of it's quite dry, but it's all important and it all intersects into the health debate as well, as I've noted with our multidisciplinary approach. I want to talk now about some of the civil liberties. My particular focus has been on civil liberties and how these have been affected by the lockdowns and the COVID crisis in New Zealand. So I just want to spend a bit of time on those because like other areas of the COVID crisis, I think there is some confusion out there in the public as to what the real state of play is. Firstly, we must note that our civil liberties as New Zealanders come from a range of different sources. They come from statute law, they come from common law. They reach back centuries. They reach back into the history of course, England and Britain, where we inherited our law from as of 1840. We can find those protections in Magna Carta, in the Bill of Rights 1688, which we incorporated into or inherited into our legal system in 1840. And more recently, we can find them manifested in our New Zealand Bill of Rights Act 1990. We can find them in famous cases like Intick and Carrington from the 18th century. The New Zealand Bill of Rights Act 1990 didn't necessarily create anything new. It really confirmed what was already in existence in other law, statutes, common law, and brought that through in one specific act. And as many of you will be aware, there are weaknesses to our Bill of Rights in New Zealand, our 1990s Bill of Rights. It is not supreme law. It is not entrenched. And if it comes into conflict with other law, it doesn't overturn or override that law, but rather the other law could potentially override the Bill of Rights. So it is not like the US Bill of Rights. It is one which the judiciary has shown strong support for, and one would say perhaps breathed life into, but in terms of its legal power, it is much weaker than I think many New Zealanders think. But I want to pick up on three rights that are in our Bill of Rights and in the other law that I've alluded to, and how they've been affected by the COVID crisis. So let's start with freedom of expression, because I think this is a particularly important one in terms of what we're talking about today, because we are today exercising our freedom of expression under Section 14 of the New Zealand Bill of Rights Act. And that's vital. It's also vital for the six of us who founded the Plan B group, because we're all academics, and therefore we all have protections under Section 162 of the Education Act 1989 to be able to publicly air our views based on our research in our particular areas. And indeed, we have an obligation to do so. It is our duty to contribute to the debate, and that's the same with the academics that you've seen more of in the news than us. That is their obligation and right as well. So there's that aspect of it. And then also there's the aspect of balanced debate. And it's really a story for another time, but as a group, we have struggled, it must be said, to get an opportunity to air our views. We have had the opportunity to do so, of course, evidenced by news reports and so on, but that has been relatively limited, and also must be said that our views have not necessarily been accurately portrayed. And that has been a problem. The debate has been limited, I would say, in terms of the way in which coverage has been provided. The second right I want to talk about is freedom of movement. Now, this is one that obviously has been curtailed by lockdowns and by the closed borders. So this is not to say that these rights are absolute. In fact, they're not. They can have reasonable limitations placed on them under our Bill of Rights, and many would argue that is what is occurring now. But the lockdown obviously has huge impacts on freedom of movement. And of course, closed borders do as well. Our ability to be able to move to and from our country and to get back into our country, and what will happen when we do through quarantine So Section 18 is one that has been heavily affected by the lockdown. Section 21 is one also that I want to touch on, and that is unreasonable search and seizure. So here we get into the whole issue of due process. And in particular, what are the rights of the police to enter your property, to check that there's not a gathering which is too large or that is breaching the Section 17 notice or the guidelines under level 3 and level 4. Now, our rights to protect our private property and to prevent others coming onto our private property stem all the way back into our law. They don't flow just from our New Zealand Bill of Rights Act. They go back to ancient, fundamental rights. And so therefore, when they are curtailed under law, whether it's the original lockdown laws or whether it's the more recent Public Health Response Act, these are serious issues. Now, again, the government can do this. The law stands. Parliament is supreme. But when it chooses to curtail those rights, it's absolutely vital to have an open public debate on them. And we saw that increase, we saw that improve once we got out of level 3 and we got to level 2. And here, you can see much more robust public debate occurring around these issues. So we got there eventually in terms of having that debate, but it took some time. There's a lot of issues flowing from those rights. As I said, they're not absolute. The way our Bill of Rights works is a very confusing interplay between sections 4, 5, and 6 as to the extent of the rights and when they can be curtailed and what can be reasonable limitations. And when we have this discussion, we're also having a discussion about the three fundamental concepts in our constitutional system: parliamentary supremacy, separation of powers, and the rule of law in New Zealand. Parliament is supreme in New Zealand, so it makes the laws that it chooses to make. And we've seen that. We've seen that with COVID-19 and the Public Health Response Act and the other law that we've talked about today. And Parliament will continue to make law in response to this crisis, as is its right under our Bill of Rights 1688 and other legislation, Constitution Act 1986. But due to our rather ineffective separation of powers in New Zealand, where we effectively have an overlap between our executive and our legislature, that is, if the government has the numbers in Parliament, which it does by definition of being the government, then it can push through legislation and will, be sure of doing so if it has those numbers. And so, therefore, Parliament and the executive have a strong overlap. And what are the checks and balances on that? So there are issues around that. And for me, the most important issue from a civil libertarian point of view is that idea of rule of law. We have to be operating under the rule of law. And so what the government does in this space, whether it's about movement or freedom of expression or search and seizure and warrants, is absolutely pivotal, and we need to have the debates. And just picking up on 2 issues which I've seen have come up through the chat today, and that is relating to masks and, if they are to be made compulsory, and it looks like we might be heading that way, can we do so under existing law, or will Parliament be needed to make new law? Parliament looks like it's coming back tomorrow as the election is delayed. And that is a question that the government currently has its legal experts examining. But Parliament can make new law to do that if it so chooses and if it has the numbers and the time to be able to pass that law. And we've seen, much of this has been done under urgency. So the legislative process is sped up, and select committee is often missed out, and that has issues of itself in terms of democracy. But again, Parliament can put itself into urgency. And then another issue which I've seen come up through the chat today is the vaccine. if there will be a vaccine, will that vaccine be mandatory? Will it be compulsory? And how do you make a vaccine compulsory? And what about rights under the Bill of Rights, Section 11, in terms of the right to refuse to undergo medical treatment? What will occur there? We know vaccinations are a vexed issue in New Zealand, and that we've had a real struggle to be able to get high levels of vaccinations for MRI and other vaccines. And you know, that I imagine that debate will continue. Also, we need to look at issues such as international law, and I think this is another area where there is some confusion in New Zealand, where some people will look at international conventions and say, well, look, you know, that's what United Nations said, then New Zealand should be doing it as well. Wherein the situation legally in New Zealand is that we enter into international conventions and then we take the next step of bringing those into our domestic legislation. And when they're brought into our domestic legislation, then they can be enforceable in our legal system. So it's not a simple matter of just looking at, see what the UN's done, but rather what is the way in which they have manifested themselves in New Zealand. Okay, so just to conclude, I think I have my coming up to 20 minutes now. I just want to finish with the, I suppose, the overall thesis that I've been working on and first aired in late March, and continue to argue, and that the approach that this government and many governments have taken around the world is to achieve societal compliance through fear, through making people worried and fearful about COVID. The line of pretend you've got COVID, pretend everyone else has got COVID, is not the only way. It is one way, but it's not the only way. There is another approach which is more consistent with the social contract in a liberal democracy. And I believe that that approach is one which is based on education, open debate, so hearing from all perspectives like we're doing today, and a certain level of trust in the population as well. A trust that the population can and will make rational choices without the need for fear, without the need or threat of legal sanction, but rather trusting your population. And you know, some people trust the average citizen and some don't, but I believe we should. And I believe that is the most effective way to achieve a long-lasting and effective outcome for this particular crisis. Thank you.
Thank you. Right, we've got a couple of minutes for a couple of questions. Thank you, Grant, also for answering a lot of those in your presentation. Just looking at a bunch that are coming up now. A lot of them are just to cover some of the same ground you already have, if you don't mind. People are asking, how is it that the government can do a lot of these things without necessarily either having the evidence or having sufficient public input? I think your answer is, yeah, Parliament reigns supreme, it can do whatever it wants. But is anything able to be questioned if it can't be justified?
Sure. So I suppose we've got two issues here. One is the fact that Parliament is supreme and its law stands as the law of the land. But then you've got the actions of the executive as well, so the actions of government. So that's what we see in the Christensen decision. That's what we see in the Borrowdale application as well, is judicial review. So we can use our third branch of government, the judiciary, to be able to challenge the actions of the government. And that's why the Borrowdale case is so important, because that needed to happen. Someone needed to challenge the decision-making and the process of decision-making of the government. So, you know, judicial review was and remains the most effective legal route to challenge what has happened. Beyond that, it's through what we're doing now. It's through open debate with the community and airing our views. That's why, you know, that's why the fourth estate is so important as well, because they allow us to be able to air our views beyond just our close circle, but rather to, tens of thousands, hundreds of thousands of New Zealanders. And so the media's role in this, in terms of supporting a liberal democracy, is absolutely vital. And they're in a very powerful position at the moment.
All right, to be specific, you with some of the things that are coming up, we've had questions over the past couple of months around laws that were introduced, and we're still going. There's more plans. There's possibly more lockdowns, possibly regional. There's a suggestion, or at least a response to questions from the government over the weekend, that they could try to make masks compulsory. There's been a few questions up here today around making vaccinations compulsory. If I get this right from what you're saying, the government could pass those laws. It has a couple of days now left in the parliamentary session to do it, and it could do it quickly, and it could do it without necessarily the evidence. Yeah.
So again, I think those are two vital issues. Masks, I think, is probably the more current one, given that we don't have a vaccine yet. And with masks, if Parliament needs to, if they feel that the existing law is not there, I think they're pretty confident they can do it under existing law. But if it's not there, then they will pass it. In terms of vaccine, that I think is going to be a far more controversial one. And I think I've mistakenly said MMR, right? I mean, MMR vaccination, that's been such a big debate in New Zealand. But to be effective, it may well be that it needs to be mandatory, that it needs to be compulsory. And how do you do that? And again, how does the Bill of Rights operate in that situation? We have a right under the Bill of Rights, but then the Bill of Rights is limited. So the government, if it creates specific legislation, then it can well override that right.
Two more questions quickly. So the Director General, if I think you're referring to the law where the Director General can make such, he could probably impose a mask, a requirement for masks, but he has to provide an assessment for the risk to public health.
That's what.
Sorry. Yep.
Yeah, that's what the government's currently investigating in terms of what is the most legally effective way that it can make masks compulsory. And as my understanding is, it doesn't have a fixed answer yet. We're yet to hear under which law it will actually do so. It's quite complicated. Otherwise, we would have heard more of it by now.
Yeah. And a wider question. What we've struck here is a problem for timing in response to emergencies, in terms of making law, government acting in a democracy. It has the power to do so, perhaps that is the answer, but it seems profoundly uncomfortable to a lot of people that it can act so quickly, and perhaps incorrectly. But that seems to be the challenge. How does it, in a democracy, how do you act quickly to an emergency if you can't do this?
Yeah, and it was, as I mentioned before, urgency has been used a lot in terms of being able to fast track legislation through Parliament. But the reality is that in a liberal majoritarian democracy, it is hard to move that quickly, and so the government's got this tension of needing to control an emergency, but also bringing the country with it and doing so in a way that has buy-in and has gone through the necessary kind of quality control, and it's a very tough situation. And so all we can, I suppose, advocate for is for as much public involvement and debate as is possible.
All right, thank you very much. I think we've covered a lot of what's been up there in the questions, but if you are hanging around with us for a bit longer, Grant, there are probably some that you could address if you can in written form.
Sure.
Okay. Thank you, Grant. Thank you very much. Moving now to Professor Anish Chaudhuri. Anish is a professor of experimental economics at the University of Auckland. He served as chair of the Department of Economics between 2013 and 2019. He's also founder and director of Decide, the University of Auckland Business Making Lab. He's ranked amongst one of the top 10% of authors in economics across the world, according to the Research Papers in Economics and Social Science Research Network databases. Anish is one of the founding members of the Plan B group. Welcome, Anish.
Thank you very much, Mark.
Turn it over to you.
Haramai, tēnā koutou, tēnā koutou, tēnā koutou katoa. Thank you everyone for being here. And It's been a fascinating few hours for all of us, I think. So I'm going to try and provide a slightly different perspective on this topic by talking about decision-making in a pandemic. So I'm going to start my slideshow. Okay, Mark, I hope you can see my slides. I'm going to turn off the presenter view.
Yes, we can see that.
Okay,
And
excellent. All right. Okay, so as Grant was talking about it right now, just a little while ago, I think it's fair to say that this is the current view of the COVID-19 pandemic in New Zealand, that we are surrounded by this massive disease. However, I think a number of the experts have talked about the actual risk, and this is from Coronavirus, Our World in Data. So if you live anywhere in the world, except for those red countries, India, United States, Brazil, maybe Russia, the situation isn't as dire as it's being made out to be. And the reason why the situation is so dire in those countries has some particular reasons. Some of them have been alluded to in terms of mismanagement, etc. So by and large, the view or the culture of fear that's been created is somewhat misplaced. Okay, so a large part of decision making in a pandemic or in scenarios like recessions is dealing with uncertainty. As humans, we crave certainty, and we are actually not very good at dealing with events that are uncertain because we feel an acute loss of control. And this in turn makes us vulnerable to some systematic errors of judgment that compound the problem. So what kinds of errors? So I'm going to talk about three themes or three biases. The first of these is often called the distinction between system 1 and system 2 thinking. So when confronted with a problem, we often tend to rely on our gut feelings. The second bias is something that's called confirmation bias. And the third one is a difficulty with probabilistic thinking. So many of these are connected. So I've written quite a bit on this topic, so some listeners may have heard this argument before, but nevertheless, I'll go through it. In the immediate aftermath of September 11, 2001, many Americans decided that flying was too risky and they chose to drive. In the following 12 months, an additional 1,500 people lost their lives on the road as they drove to their destination. This is more than the total number of passengers who died on the 4 planes, excluding deaths that happened, say, in the World Trade Center. Now, the reason we tend to do this is because we tend to focus excessively on identified lives, the loss of lives right in front of us. And we're afraid of losing a large number of lives in a short period. So Jay Bhattacharya this morning mentioned aspects of this. But in doing so, we miss out on the loss of what is often called statistical lives. But the point here is that these are lives versus lives. The lives lost that you can see right in front of your eyes, and the lives lost in the background, diffuse, that is not reported as much. Again, Jay Bhattacharya pointed out, but very briefly, what kinds of lives are we losing other than COVID? So the answers would be increase in mortalities due to other diseases. Sunetra Gupta talked about the social compact between developed and developing countries. Evidence suggests that about 80 million children have not been vaccinated in developing countries, and this has caused a surge in diphtheria, measles, cholera, and these diseases will again start to spread all around. J. Bhattacharya talked about lowered life expectancy from higher unemployment. We have had postponed doctor visits, screening, and surgeries. And so in aggregate, even though these are larger, they don't loom as large in our collective psyche. And I think J. Bhattacharya also referred to this psychological phenomenon. I'm going to not go there right now, but I'm happy to address this if there are any questions. So what is system 1 and system 2 thinking? So system 1 is kind of our automatic gut reaction. It's intuitive. It jumps into action immediately once we receive a piece of information. System 2, on the other hand, is deliberative, thoughtful, reflective, but it takes time to engage. So one way to think about this is system 1 is the elephant. As soon as you get a piece of information, the elephant launches into action. System 2, on the other hand, is more like the rider. The rider can turn the elephant around, but it is not easy. It takes a huge amount of effort once the elephant has set down a particular path. So let me give you a couple of examples. So now look at this for a minute. Suppose I asked you, and many of you have seen this before, suppose I asked you that looking between those arrows, if I asked you to look at these two line segments, A and B, between the arrows, and I asked you, which one do you think is larger? And if you look at it, I'm sure you would agree with this, even if you've seen this before, it seems A is larger, and in many studies, a large majority of people will say that the line segment A between those arrows is larger. Now, this is false. And the reason it's false is because of this. The two line segments are the exact same length. I'll tell you in a minute why I'm talking about this. Let's look at a next example. This is a study by Solomon Asch on what's called conformity. And he was interested in trying to understand why do so many people conform to a particular idea, even if the idea is not correct. So the question here is, if you look at the red line on the left, then which of the three lines, A, B, or C on the right, are the same length as the red line? This is slightly more difficult, but if you look at this long enough, you will realize after a while that the red line is the same length as the C line. Now, why is this interesting? Because there are enormous amount of studies that have shown that if for some reason a whole bunch of people claimed that the red line was the same length as the B line or the A line, a large number of people would willingly go along with that view. So those of you who are interested and who are listening, if you are not convinced, then you go on YouTube. Some of you are already on there. Look for a game, a study called, not a study, a show called National Geographic's Brain Games. And under Brain Games, just search for Brain Games conformity, and you will see this in action. This person, Jason Silva, he's going to have a whole bunch of people come in, and they'll all say that the red line is the same length as the B line. And then you will see unsuspecting study participants will all line up with that view. Now, the reason why this is interesting or applicable here is that in some cases then, having seen something and come to believe that this is correct, it actually becomes very difficult to unsee it. So once you become convinced of the truth of a particular position, once the elephant has launched into action, it's actually not that easy to turn it around, which is what you are seeing in the current scenario. And the this is where the second bias kicks in, that once you are convinced that COVID-19 is a major threat, at that point, you are only paying attention to the information that confirms your presupposition. You are going to actively disregard any information that doesn't line up with your already formed view that, oh my goodness, this is a major threat. So it is psychologically painful to change our minds. It can happen, but it happens with difficulty and possibly after overwhelming evidence has been brought into existence. So here's an example, because it's been a longish day. Maybe they'll find this funny. So this is Stephen Colbert. He is talking about George W. Bush at the White House Correspondents' Dinner 2006. So instead of playing the clip, I'll just read it out. So here's what Colbert said. He said, we, meaning George W. Bush, we are not that different. He and I, we both get it. Guys like us, we are not some brainiac on nerd patrol. We are not members of the Factanista. We go straight from the gut. That is where the truth lies, right down here in the gut. Do you know that there are more nerve endings in your gut than in your head? You can look it up. Now, I know some of you will say that I did look it up and that is not true. That's because you looked it up in a book. Next time, look it up in your gut. I did. My gut tells me that's how our nervous system works. So once your gut feelings have convinced you of a particular position, it's actually not very easy to change your mind. So that's what we see here, right? So when this whole thing first started, you had this banner headline saying the case fatality ratio is 3%. And then our system once went into overdrive. We said, oh my goodness, lockdown. We got to combat this major pandemic. But if you actually paused a little and engaged your system too, you could have found out some of the following fairly quickly. The first is that your system would have said, well, okay, but is 3% high or low? Turns out that the case fatality ratio for Ebola is about 50%, MERS 35%, SARS 9 to 10%. So 3% doesn't seem very high. And then, as has been pointed out repeatedly today, the case fatality ratio doesn't really mean all that much. What you want to know is the infection fatality ratio, but you don't know that unless you have tested extensively, right? But if you didn't take this step back and engage in this kind of deliberative thinking, then of course you are now locked into this entire story that this is a major threat that we need to combat. So then lockdowns. As has been pointed out, weak, if any, correlation between policy stringency and cases. But once again, the narrative became that it was either lockdown or let it rip. There was little consideration along the way that there's a whole continuum in between with associated costs and benefits at each of those levels. I'm not going to go too much into this, but New Zealand is a high trust society. People here follow instructions and they can be relied upon to do the right things, such as self-isolation when called upon to do so. Which brings me to the next part of my talk, which is these questions. Should we keep our borders closed? Should we have yet another lockdown? Should people have to pay for quarantine? These are all, as I'll argue in a minute, they're all related questions. And I want to address one thing Sunetra Gupta said. She said that we have violated this contract between developed countries and developing countries. I think Jay Bhattacharya talked about this as well. But in New Zealand, forget developing countries, we violated a basic contract between the government and our own citizens. All of a sudden, we were telling our citizens that if you want to have the privilege of coming back to your own homeland, you are now looking at paying an additional $3,000 to $6,000. So it wasn't even that we hunkered down between our own borders and our own nationalities. Even our own nationalities became pariahs in New Zealand. Okay, so quote endemus, where are we going? I think the common theme to those questions is a lack of understanding of small probabilities. Beyond the point, and this has been pointed out, I think, by David Katz, that the risk from COVID-19 is actually fairly small. And so beyond the point, it's really not worrying about low probability events. But of course, somewhere along the way, our story had morphed from flatten the curve to elimination. And as has been pointed out, elimination is not a feasible goal. We thought measles had been eliminated. We had an outbreak in Auckland in 2019. It's a global world. As long as people and goods travel, so will diseases, unless you stay hunkered down behind closed borders for the rest of your existence. Even when a vaccine arrives, it won't arrive very soon, as we found out. Not only do we need all Kiwis to get vaccinated, we really need every single citizen of the world to get vaccinated. So now we have created this vast bureaucracy and incurred these huge costs to deter a relatively low probability event. And what a lot of people aren't getting, I think, is that getting a probability down from 1 in 100 to 1 in 100, sorry, 1 in 10 to 1 in 100 may not be very difficult. But going down to 1 in 1,000 or even lower becomes prohibitively expensive. We cannot get this probability down to 0, and we do not need to. As I said, the current threat of COVID is less than getting into a car accident. So this trade-off between further risk minimization and incurring huge social and economic costs is not being appreciated, partly because now that we have staked our reputation on this elimination story, going back is very difficult. We have devoted so much time, effort, and energy into the country, the team of 5 million that could eliminate this disease. It's difficult to turn back. So now it's more about ego and hubris than evidence-based decision-making. I'm going to end by talking a little bit about something slightly different. This is work that we have done under a Marsden grant, and I want to point this out to people. So there has been this narrative that this COVID response is a liberal conservative thing. Liberals are pro-lockdown, conservatives are not, and that is incorrect. I'll tell you in a minute, and I'll explain why this sort of narrative that this is a major pandemic took hold so quickly. So this unidimensional view of politics between liberals and conservatives is at least incomplete, if not incorrect. And in a recent paper, we provide an evolutionary argument as to how some of us are liberal, some conservative, et cetera, and I don't know if David Seymour is listening, but he might appreciate the next parts. There are economic conservatives and there are economic liberals. And there are social conservatives and there are social liberals. These are different types of people. Economic liberals, so when we talk about liberals, these are the kinds of people we sort of think about. These are people who believe in equality, in redistribution and things along those lines. These are people who believe in cooperation, egalitarianism, and these people essentially viewed social physical distancing as a cooperative activity. They were strongly in favor of lockdowns, including military involvement. This is based on a very large study we carried out in England. Social conservatives, on the other hand, they tend to be sort of group conformist, group minded, and they are threat or what's called pathogen sensitive. So social conservatives, who are sort of the people who think of as conservatives, they perceive these lockdowns also as mitigating that pathogen threat, and were also supportive of strict lockdowns, including military involvement. And so you got a striking concordance in views of two very disparate groups of people who supported lockdowns for totally different reasons. But once the narrative got hold, turning that elephant around has been very, very difficult. Though I think we are beginning to make slight headway recently. Okay. So in the words of Dennis Miller from Saturday Night Live, that's my story. And I'm sticking to it. I'm happy to answer questions. A shameless plug, I just put that, sorry, that should be ananishchaudhuri.com. I put that there because in case you want my slides, those slides are available on my website. Thank you very much. Thanks for having me.
Thanks, Ananish. Right, we've got a couple of questions. I think people will be a little bit surprised to see the extent to which psychology had come into economics, which in my view is a good thing. So given your explanation for why people are thinking one way or the other, a support or not, I mean, what does it take to change that narrative, to turn it around, and how long would it take?
So I don't have a good answer to this question. As we discussed earlier, it probably doesn't make a lot of sense to tell people that they are wrong or they don't understand. I think what it takes is a very reasoned approach. And this, I've talked about my favorite movie, 12 Angry Men, where Henry Fonda tries to convince 11 other jurors by not so much telling them they're wrong, but by simply asking questions like, what do you think of this? Is this possible? What about the costs? Is this a sustainable solution, lockdown after lockdown? And as you know, in order to do this, you really need to have kind of a level playing field where dissenting views are given a voice. That has been difficult, I think, as a lot of people have realized. But I think the key has been, or key was, especially for someone like Simon, perseverance, saying this repeatedly and having a thick skin without, being able to bear the arrows of hatred, and kind of repeating the story by saying, look, here is what the science says, look at what the infection fatality ratio really is and things along those lines. But it's been difficult.
Another question, perhaps right on economics. Do you think people have appreciated the economic impact? It hasn't happened yet, or not decidedly, or not in any way that's kind of featuring everybody's daily lives. When might that happen? And can you probably put some description around what that might be like? A recession or depression even? Do you think it's likely, and what it would be like?
So two answers to that. So one, I think Jay Bhattacharya presented an extremely eloquent answer to that question when he talked about what a $3,000 per person reduction in income means, what it means for life expectancy. Let me just say two things here. One is, and Jay Bhattacharya alluded to this, one is this psychological tendency that we sometimes call loss aversion. And what loss aversion says is that I want to avoid a small certain loss now, even if that means a much larger expected loss down the road. Because that larger expected loss doesn't figure as much on our psyche for some reason. And here's the point. The point is that when unemployment gets to 10, 12, 15%, that can be catastrophic. That's when you get gated communities. That's when you have, confrontations between police and communities, right? You really don't want to go there, but it's not that surprising, because I think we would be foolish to think that New Zealand will never get there. Greece did, Portugal did, Ireland did, Spain did in the middle of the global financial crisis. Some of these countries went to unemployment levels of 20, 25%, and the economic cost of that is massive. And not to mention the social cost of isolation, kids not going to school and things along those lines. But communities can very quickly fall apart, and the falling apart part can happen quickly, but the rebuilding part may take a very long time. And recently, somebody asked me, all this money we are borrowing, who are we borrowing it from? And I said, well, really, we are borrowing it from ourselves. But if all the governments in the world taken together, the money they have borrowed, if one fine day, let's take New Zealand, if one fine day, all our creditors came and asked for their money back, we won't be able to repay them. The only reason this system works is because the creditors trust that we will not default, and therefore they're willing to hang on to their borrowing. So this is like an interest-only mortgage. As long as you keep paying the interest or a minimum payment on your credit card, you're okay. But for some reason, if the trust breaks down, then it can be catastrophic, because then you have something called capital flight, where no one wants to hold your loan anymore. That's when your currency goes into a complete tailspin. Inflation starts to rise. And again, I'm hoping we won't get there, but when your government borrowing starts to approach 50% of your GDP or more, the potential for that happening it's there. I mean, the probability starts to increase quite rapidly.
So predictions would be a bit of a mug's game, but it would be hard to imagine that we're not going to have some sort of economic dip.
We're certainly going to have a massive economic dip.
Yeah. Oh, okay.
By the end of this year, early next year, we're going to have a very massive economic dip. I mean, we have shut down our biggest export industry, tourism, and our fifth biggest industry, which is education. Right?
Yeah.
And I'm probably way out of time, but there's only so much dairy and meat and lumber you can sell, because these are primary products and there's a finite ceiling on their consumption. As countries get richer, they don't necessarily start eating a lot more meat, but they do start to travel a lot more. So in economics parlance, when income levels rise, your tourism dollars will bring you a bigger bang for your buck than your dairy dollars. So I don't see how this is a sustainable scenario where we shut down our biggest export industry.
Is that recoverable? By that I mean, can we avert some of it by changing soon, by changing before the end of the year, changing some policies, be it the border or anything like that? I mean, or is this actually not dependent on what we do, but actually internationally? Are we going to be influenced by the international recession?
Well, there are two issues. We're a very small country in the middle of the South Pacific, so obviously we are very much at the mercy of sort of large international countries. But in my view, the answer is reasonably clear. We open the borders. We have. I would probably say I know Grant probably won't agree, but maybe we should be willing to have contact tracing on our cell phones so that everybody could be tracked. Give up that privacy. Maybe we should be willing to give up on rugby games for now, but open the border. Maybe go to level 2 or something similar, which is what the European countries are doing. I personally, I'm a big sports fan, but I'm happy to have open borders and not go to games.
All right. Okay. Thank you. I think that's covered most of the questions that came up. Thank you, Anish. We're moving on now to Ben Smith, the last person presenting in this part of the day, just before the break. Ben Smith completed his PhD in psychology from the University of Southern California in 2019. He's an independent data scientist based in Auckland. And in some ways like Anish, he's published multiple scientific papers in psychology and neuroscience. He previously worked in data science at TradeMe and at Facebook. So Ben's with us now. He's going to be talking about safely opening of border, and he's got some data to show us as well. Over to you, Ben. Mute.
Thank you very much, Mark. So, kia ora koutou, good to see everybody today, and I will get a presentation up on the screen for you. Right. Great, we're underway. So a little bit about me. I think, thanks for the introduction, Mark. I have recently become interested in taking a look at modeling border risk and looking at the risk, because what I could see in the international data was a large set of differences between countries based on the amount of COVID-19 they have in the community there. And I think this is quite relevant to consideration about which countries we might allow into travel between New Zealand and which countries we don't. So I built the model in an interactive web app that you can check out online, and I approached Dr. Thornley to look over the work and sort of look into the epidemiological aspects. And today I want to take you through what I've found. So what I want to do is show you that excluding the world from New Zealand is not zero risk. People from many countries are very low risk, and we could actually reopen the border to many countries without substantially increasing the risk to New Zealand. So in the status quo, we're currently bringing in around 9,000 people to New Zealand each month. And actually only around half are New Zealand residents, and half are people who have an essential skill. Most, or they have other exceptions for coming into the country. Most are from high prevalence countries. So this is June to 2020 data, and this is the this is looking at the based on the June 2020 data of people coming into New Zealand, as well as the prevalence of COVID-19 in those countries. And what we're seeing there is that we predict most cases that we're getting coming into New Zealand come from the US, Australia, India, and the United Kingdom. But the status quo costs us. Tourism is around 6% of New Zealand's economy. International education is 2% of New Zealand's economy. New Zealanders also like to travel, and there's not a lot that we can do right now when the borders are shut. And more than 1 million New Zealanders were born overseas and likely have family and friends overseas. Many of us do. I'd estimate more than 1 million all up. And so there's a lot of different restrictions that the border controls place on us, and it's not just the economic situation. Peter Gluckman, Helen Clark, and Rob Fife wrote a piece not too long ago. They said, do we continue as we are now indefinitely, relying on a strict quarantine and a giant moat? We must prioritize exploring the ways in which we can more completely re-engage with the world. So what can we do? The first step to think about what we can do is to understand that countries are not all the same. The graph here is an estimate of infections per million of COVID-19 in selected countries. And there's a huge range among countries where we have quite a lot of travel between. And that ranges from Taiwan and Thailand, where there's actually 0 active cases right now within the community, right up to the United States, where they're seeing 12,000, 13,000 infections per million across the country. And the infection rate of travellers coming into New Zealand currently, if you consider that we had 30 COVID cases coming into New Zealand in July and 9,000 travellers, that works out to be 3,300 per million. So let's see how that looks when compared to countries where we have travel. Many countries are indisputably and clearly much less than that. So they have 0 COVID-19 cases. And right now, the Cook Islands, Fiji, Samoa, Taiwan, and Thailand all have 0 COVID cases. And they're all worth pointing out because we typically in normal times have a lot of travel between these countries. Right now, we don't have any travel except for New Zealand citizens and rare exceptions. And it's not clear why, given that these countries right now are COVID-free. There are other countries that do have some level of community transmission, but it's a low risk level. So you can see here on the graph, New Zealand, as of Saturday, had around 5 million infections per million within the community. So that's a lot less than what we have coming in. And so I think it's reasonable to understand why New Zealanders are really worried about having more people coming in from outside of the country, because you can see the current rate of travellers of COVID-19 among travellers coming back to New Zealand is pretty high. But when you look at other countries around the world, you see an opportunity to bring in more people to New Zealand that will not bring up the number of infections that we bring into New Zealand substantially. So for instance, China has been in the news a lot and has been associated with COVID-19 because the virus initially started there, but it seems that the virus is very much under control in China now. And from the international data, we can estimate only less than 1 infection per million in China right now, substantially less than here in New Zealand. Queensland also around the same level, less than New Zealand. Malaysia, Sri Lanka, and South Korea do have some level of clusters of cases. However, those levels of infection prevalence within the population are substantially lower than what we're getting coming into the country right now. So how do we control imported cases? Controlling importing COVID-19 cases, it depends on 3 main things. The first is the prevalence in source countries. The second is the volume of travelers incoming. And the third is the quality of our border control. Right now, overseas prevalence of COVID-19, and generally speaking, is high. We're looking at that 3,300 per million figure. And so what we're doing is reducing the volume of incoming travel to keep the cases controlled. And we're saying, well, we can only have New Zealanders and then rare exceptions like essential workers coming in from other countries. And that keeps our expected cases to a minimum, although as we have recently seen, even with this strict control, we cannot completely keep the virus out of New Zealand. But there's a better way. We can split out prevalence by source country. Some countries are high prevalence countries like the United States and the UK. There are other countries that have a moderate level of prevalence, such as Canada and Germany. And then you have countries with little or no prevalence, South Korea, Thailand, Samoa, and Fiji. And so we can split out countries into different levels, and then we can think about the level of border control that's appropriate for each level. So for high prevalence countries, we may want to stick to allowing only New Zealand residents and rare exceptions into the country. But for moderate prevalence countries, perhaps there's scope to allow more travellers into New Zealand with a strict border control. And that may mean the existing 14-day isolation applies, and quarantine applies to travellers from those countries. We might not get a lot of tourists coming from those countries, but perhaps people who want to get a job here or want to visit family for an extended period of time may want to take advantage of that. Then you look at the low prevalence countries, and we can see that perhaps I'll go through the risk. It seems like there's a fairly low risk of opening up a more permissive border regime for those countries. And what we can see as well is that the border controls themselves can help control the volume. So when we apply that strict border control, we're unlikely to see so many people coming through those moderate prevalence countries, and that helps us to moderate the risk. So the modeling suggests high prevalence countries are responsible for most cases. Let me take you through the two graphs on the screen. So on the top, we are looking at the cumulative monthly arrivals for June 2020. Last month, 2 months ago now. This is the latest data that Stats NZ have released, just came out a few days ago. We had around 9,000 travellers coming into New Zealand, and you can see from which countries they are coming. Largest is India. The United States is also there, not too many though, quite a few from China. Most of the rest are from Australia, different parts of Australia and the UK. Now then you look to the second bar at the top bottom of the screen here, and it looks a little bit different. So the colors are the same, it's the same countries, but there's different proportions there. This is the expected cases at the border that we can model based on the prevalence of COVID-19 in each country. So for instance, the United States feature relatively small in the top graph. They might be around about 10% or less of incoming arrivals, but based on the high prevalence of COVID-19 in the US, we'd estimate they may make up the 20-30% of the cases that we've had coming into New Zealand in June, those 30-ish cases. On the other hand, China, although we have had possibly around the same number of travellers coming from China as from the US in June, we wouldn't expect any COVID cases from China due to the low prevalence in China right now. And that's not something that I have checked back with the customs services. They haven't made that information available, but that's something that you could verify. We could verify going back to customs to see are these figures what they're expecting. So what does a staged reopening look like? So I've built a web app that allows us to examine changes in real time, and I'll go into that. What we can do here is track the prevalence of COVID-19 in different countries around the world. And we can take a look at the figures. So we can see here, Fiji, Taiwan have no active cases right now. Thailand has just a few. China has a few more. But then you can see that in terms of the infections per million within the population, those numbers are very low for all of those countries. And the data are updated every day from Johns Hopkins University for the COVID-19 data and Statistics New Zealand for data for people traveling into New Zealand. Now, we don't simply take the case counts, as we've heard today a lot. The case counts across different countries can be unreliable. It's likely that no country is accurately recording the true number of cases in their community. But what we can do is use the death rate or the fatality rate to estimate how many cases these countries have had. So international studies based on the Diamond Princess ship have estimated that there are around about a fatality rate of about 0.6%. And we can then compare that to the case fatality rates observed in different countries to see how much undercounting they're doing. For instance, the US has had around about 1,000 deaths per day in the last 7 days, and they've had around about 66,000 cases. And that suggests that they're undercounting their cases by a factor of about 2.5. And that can be contrasted with the UK with 30 deaths and around 700 cases. It looks like they're undercounting by about a factor of 7. So we can adjust the cases based on the active official cases to estimate how many infections they've got. And we can see in the US, case of the US, they're reporting 1 million cases, but based on our tweak, we can estimate they may have as many as 3 million active infections. And that will give us a prevalence that's a little bit more reflective of the actual rate of COVID-19 than the official case reports. So when we do this, we can see, and we use these data to predict how many cases coming into New Zealand based on those prevalence ratings and the number of people coming into the country, we can predict around about 30 cases coming in each month. And what you're seeing now is the prediction from the model I've described. And that matches pretty closely the actual number of imported cases that the Health Ministry has reported. That's the dotted line on the graph at 35, the active cases reported returning July 2020, and models predicting around about 30. So it's a pretty close match. And what we can also do then is weight up the figures to take into account perhaps travelers have a slightly higher prevalence than general population. Then we can take the data and we can look at how that might work out to be cases in the community. So Sean Hendy's research group at the University of Auckland has estimated a success rate of our quarantine system of around 99%. So we can work out that perhaps that 30 cases a month could work out to be around about 0.6 cases in the community that may be entering the community through a quarantine breach or some other problem. So the web app I've built allows us to simulate scenarios. What if we allowed people from Taiwan into New Zealand? Or what about Australia's ACT? Or what if we tried a 20 country scenario? So I've done that. I've taken the 20 countries where New Zealand has the most travel and taken a look to see how risk would change there. And it seems like under the status quo, we're having around about 6.6 cases exposed to the community each month. That equates to around about 7 a year. With 20 or 15 new countries out of that 20, we can open to 15 countries and the risk raises only about 1 case a year. And which countries would go into those buckets? So Cook Islands, Fiji, Samoa, Thailand, Taiwan, and ACT, they all have 0 cases right now. We could open the border completely to these countries with no risk at all. As long as we keep modifying those countries to make sure that they continue to stay in their COVID-free status, we can be confident that receiving travelers from these countries, we're not going to see cases coming in. There are also very low prevalence countries, most of Australia, China, and Malaysia, where there's very low levels of cases. South Korea and New South Wales, it's not very low, but it's low. And we could also allow in quite a few travelers from these places safely. And then there's moderate prevalence countries. And these countries would definitely need to continue applying a hard 14-day quarantine for people coming in. But if we were to do that, we would not face a lot of additional risk. And that's Japan, Germany, Canada, Hong Kong, and Singapore. There are no interventions safe enough right now, in my view, to allow people to fly directly from the UK, US, and Victoria. However, you could allow people to come from those countries if they flew to one of the safer countries, quarantined there for 14 days, and then came on into New Zealand. So countries can move up and down risk tiers. We see countries have resurgences of the virus as extra clusters break out, or they get on top of it. And that's why it's important to keep an eye on this data from day to day. If New Zealand were to open a border, we'd need some sort of kind of a classification system so that we could understand when to open up the border to a country and perhaps close it again, and when we could open up to new countries we were previously closed to. So why should we bring in more international visitors? It allow family travel for hundreds of thousands of Kiwis. So just in the COVID-free countries I've talked about today, 150,000 people in New Zealand were born there, and most of them will have family back in those countries that that would like to see now and then. From the low prevalence or moderate prevalence countries, there's around about 70,000 students that we see every year in New Zealand, and right now they can't come in. But if we were allowed to allow them to come in through the 14-day quarantine system, we could bring back around 70,000 students a year and get our education, export education industry going again. And skills for the economic rebuild. So you can see this is the Google Trend demand for jobs in New Zealand search in the United States. And there was a marked increase in searches for jobs in New Zealand in the United States by Americans when that lockdown period began, suggesting, we have an opportunity to take some of the world's best and most talented people right now, if we're able to open up to allow them to come into the country in a sensible and safe way. So thank you for listening, and I am open to questions.
Thanks, Ben. That is fascinating stuff. My first impression is that it shows that with the right application of data and thought around how you construct, how you use it, you can come up with a practical solution to not only letting people in, but perhaps many other problems that we face. A question there, looking at some of some which has come up. How quickly though could we adjust that data to take account of changes in countries?
Yeah, so the data is collected daily by researchers associated with Johns Hopkins University. That's posted online, and then we can pull that data as soon as it's posted by them. I think it's usually mid-afternoon, around about now actually, New Zealand time. And so when you go into the app that I've created, then you will see that data coming in right away. It loads it straight fresh from Johns Hopkins every time that you open the app.
Mm. Do you have any comment perhaps on the reliability of the infection or cases that we're getting through from other countries? Because that does, over the course of today, we've seen some skepticism about reliability, variation between countries about how they're counting.
Yeah. So I have made an assumption in this work that even though countries may not be, and almost certainly are not, reporting cases properly, they're probably reporting fatalities well. And there may be some different views on this, but when I look at the excess death rates, they seem to more or less line up with the COVID-19 fatalities that are being officially reported. So my view is that in the main, those numbers of fatality counts are generally reliable. There are countries where the health systems are less developed, where we would want to be more cautious. So for instance, India, I haven't made any assessment about India in this model because I'm not so sure the data will be reliable, looking at a measure of how developed their health system is. But if we can look to a country that has a health system at least developed enough to report fatalities accurately, then we can use those fatalities to understand how much cases are being undercounted, and then weight up the active cases to estimate how many actual active infections are out there in their country.
A comment from you perhaps on the psychology of the thing. It's perhaps thinking about it, it seemed to me that this data or this format, this calculator, could have landed well if it was presented to the public a few weeks ago before the latest cases with the outbreaks. Do you think, given, as I assume from this, that it seems to assume that there are going to be cases that will appear even if you let people through, do you think people are willing to handle that risk?
What I can see is that even before last week, we were looking at some risk, and it was really seemed to be the case that in the status quo, we're still getting around about 0.5, 0.6 cases a month, or expecting a small number coming into the community. I do think that with an outbreak in Auckland right now, and I'm here in Auckland and can't leave to come to Wellington, it is on people's minds, and I think people will want to be more cautious. But I think reopening the border as a project, that could be something that takes a little while, and we need to be thinking about it now, even if we're not ready to do it now.
Right. So this model could be used to allow a staged entry of people or opening up of our border.
That's right. And so people like Professor Michael Baker, the epidemiologist at Otago, has suggested, maybe we start with the Pacific and then look at Taiwan and other places that have eliminated the virus.
Now, as I understand it, other countries in Europe have opened up their border and then closed some of them. They seem to be doing an interchangeable borders between countries. They're deciding not to do. England decided recently to shut down with Spain with some changes there. Are they using models like this, or are they doing it somehow different?
I haven't looked in too closely, but I'm aware they do have some kind of a classification system where they're monitoring outbreaks in other countries and making decisions about the restriction they're placing on other countries as a result. And you can see on the page here that, for instance, France had previously been a country of concern, but at least in July, they'd gotten rid of enough cases where they'd be considered moderate under this model. So, in Europe, you're seeing that some countries are getting on top of that virus. And so it's unsurprising that they're thinking about ways to handle risk proportionately.
So there's a question just popped up. Can this tool be used to model comparisons between New Zealand and other countries? Could you run the same data through to see what's happened with other countries that have opened up their borders?
Yeah, that would be very interesting. I think I am not aware of, I think Thailand was looking at opening up a border, but so far they've got it closed. I think you'd look to places like South Korea and Taiwan, perhaps rather than looking at countries where the border was previously closed and then opened. You might look at the levels of cases that are coming in from different countries. So you could look at a country like South Korea or any other country that are having people coming in, and they release data on where those incoming cases are coming from. And you could look to see, all right, well, based on the numbers of people coming into that country, and then from each other country, and the number of cases that are being brought in from each country, does that suggest that the prevalence data that I've used here is a reliable way to measure the prevalence of COVID-19 in travellers from each country? So I think that's a great idea.
Right. One other good idea, possibly. Were you here for David Katz's presentation at the start of the day?
Yes.
He's got a mitigation strategy. Be possible to use your model to apply those kind of strategies. So by that, it means different ways of applying what people can and can't do when they're in New Zealand, either as citizens or visitors.
Yeah, absolutely. So I haven't thought about what people could do while in New Zealand, but certainly, if we were running a strategy that was not full elimination, it could be that we still want to moderate the amount of spread. We still want to flatten the curve. And so it may still be important to control the number of people coming from high prevalence countries.
All right. Thank you, Ben. Thank you very much for your time.
You're welcome.
That is fascinating. Thanks for all your work. Okay. We're going to take a break we're going to be back at 3:30. We'll be back with Caduff, who's Associate Professor of Global Health and Social Medicine at King's College in London. And we really appreciate him because it will be early in the morning, I think, for him when he connects in with us. And we'll also, and one of the fascinating things about what he's going to talk about, I think, is the psychology. So what the heck has happened here? Why are we all responding in the ways that we have? And that's the drivers behind the responses are what he's going to address, and that'll be fascinating. And then we have a short presentation, 10 minutes discussion from David Seymour about the political response. That is his interpretation of how politicians are responding, but in particular, what today's topics, the things we've discovered today, what that could probably mean for politicians and how they respond. And just quickly, just touching on why David is here, we had originally intended to do this at Parliament, this symposium, and hold it there, but due to the level 2 restrictions, we couldn't do it in person. Now, David had kindly agreed to do it. He responded quickly to allow us to do it in Parliament, and therefore we felt that it was only right, with the change to going online, that we gave him some time to respond today as well. So that's all coming up. Those are the 2 final presentations at 3:30. We'll see you then. Thank you. Welcome back to the COVID-19 Science and Policy Symposium and webinar. We've had hundreds of people tuning in today to watch the presentations over the course of the day from international and local experts. We've got 2 more to go. Next up is Carlo Caduff. He's an associate professor at King's College London, although he's based in India. His work explores the emergence of global health at the intersection of science, medicine, media, and the state. He's the author of the book, The Pandemic Perhaps, which discusses how pandemic influenzas became a global threat. The book argues that it's crucial to avoid the reproduction of universalist assumptions that in fact limit the very possibility of conceiving the global. In July 2020, he came to our attention because he published a paper, What Went Wrong? Corona and the World After the Full Stop, and examines the global response to the pandemic, COVID-19, and argues that we need to look beyond the virus. We want to understand the real seriousness of what's happening in the response. He suggests that the fear is fueled by disease modeling, by health policies, nervous media reporting, and even authoritarian longings of some people. Well, that's a heck of a mouthful, but it's something that's going to fascinate a lot of people watching, I know, which is effectively, what the heck is going on? Why are we responding? Why have we been responding the way we have been? Carlo, are you with us there?
Hello, can you hear me?
Can definitely hear you.
Hi.
Hi. I can't see you on our screen at the moment, so just 1 second. I'm just going to see if we can flick you on. Right.
Can you see me now?
Certainly can. Yep, you're on. Thank you. Over to you.
Thank you so much for this invitation. It's a great pleasure to speak at this symposium. I will try to share my screen now. Let's see if this works. All right. Can you see the presentation now?
Yes, we can.
Great, excellent.
You're not in presenting mode at the moment, though.
Let's see if we can do a full screen. Why is this not working? All right. Just give me 1 second. All right, now. Well, some weird. It's not working. Can you? What are you seeing right now?
We can see your presentation and the panels down the left-hand side.
Oh, I don't know why. If I go into full screen, it's not kind of changing to full screen. I don't know why. Maybe I should just close the presentation again and then try again.
All right, we've got a moment or two. Have another go.
Sorry.
That's okay.
All right, let's try again.
Just remind people that they can ask questions in the Q&A section. We should have time for a few minutes of questions at the end for David Seymour.
Well, it's not working. I'm very sorry about that.
That's okay, no trouble.
I think we'll just do it like this. I think it should be fine.
We'll be happy.
Okay. All right. So, I was asked to talk about the social, political, and economic aspects of the pandemic and the response, and that's obviously a very huge topic. So I just decided to focus on one particular dimension, which I think is very important. And I titled my talk, The Spectre of Comparison. And as some of you may know, this is a title that I stole from a book by Benedict Anderson, who wrote a book about nationalism in many. So you'll see how this talk is linked to the question of nationalism and the nation. Now, but I wanted to start with something else, which is statistics. Let's see, I hope you can read this. Just need to make this smaller. So some of you may know the word statistics comes from the German. It was invented by a German scholar whose name was Gottfried Achenwald. So he first introduced the word statistics in the 18th century, and it originally designated the collection and analysis of data about the state. So within the very word statistics, you have the word state. So statistics literally meant the science of the state, and in English, it was also called political arithmetic. It only acquired the meaning of collection and classification of data more generally in the early 19th century. So what I wanted to point out here is that the word statistics is very much connected with the idea of the state. I have here two quotes. One is from a scholar named Zimmermann. He wrote in 1787, "It is about 40 years ago that that branch of political knowledge, which has for its object the actual and relative power of the several modern states, the power arising from their natural advantages and the wisdom of their governments, has been formed chiefly by German writers into a separate science. This science, distinguished by the new coined name of statistics, is becoming a favorite study in Germany." So again, as you can see here, the idea of statistics was very much connected with the idea of the state. So the science that is called statistics teaches us what is the political arrangement of all the modern states of the known world. So it emerged in the 19th century in a context where European states were competing with each other and where nations were trying to match themselves against each other and trying to see what is their strength and what is their weakness. Now let's move on to today. What is the spectre of comparison today? And I guess this is an example of the spectre of comparison. We see different nations listed, and some nations are on the top, some are at the bottom. And they're listed according to the COVID-19 case numbers or COVID-19 numbers of death. This is another version of the spectre of comparison today. Here I chose Italy, Turkey, Switzerland, and New Zealand. So you can see Italy and Turkey have almost the same number of detected cases of COVID-19, but the numbers of deaths are extremely different. Italy had 35,000 deaths, while Turkey had only 5,400. Switzerland had 33,000 detected cases of COVID-19 with only 1,000 or almost 2,000 deaths. Then of course, New Zealand, which is very famous, obviously, had very few cases and very few deaths. So I wanted to talk about Switzerland and have a look at Switzerland in more detail because it's an interesting case. So Switzerland is a high income country. It has 8.6 million population, but it's a very small territory with a relative high population density because a lot of the territory is mountains. So the density is actually quite high. And it also has a considerable migrant population. As I was already mentioning before, Switzerland had about 33,000 cases of COVID-19 and around 2,000 deaths, which is not a lot. The Swiss lockdown took a very particular shape. It was a kind of a modest lockdown. It wasn't very strict and very severe. So on 28th February, large events were banned. Then on 11th March, the border to Italy was closed. Then later schools were closed. And then on 16th March, non-essential shops, restaurants and bars were closed. But there was no closure of offices. Work from home was encouraged, but not mandated. There was no ban on transportation, on public transportation, or restriction of movement. People were only encouraged to stay at home. So this was completely mandatory. There were no face masks required in public, and there was no curfew type of intervention. So it was a kind of a light touch, modest kind of lockdown. Then on 29th of April, all the shops, restaurants, markets, hair salons, and libraries were opened. And then later all the schools were opened. And then later on 1st July, the government introduced face masks for public transportation. Here, just the numbers, as you can see, something that we've seen in Europe, in most of the countries, a very rapid increase of cases and then a slow but consistent decline of cases again. Now, this is the most important graph that I wanted to show you. It's really interesting. So what you can see here is just the number of deaths per week in 2020. So this is just looking at how many people died each week. It's not based on any diagnosis or anything like that. So it's just the numbers of deaths in Switzerland. And the other interesting thing is that on the top, you see deaths in the age group 65 years and older. And on the bottom, you see the age group 0 to 64 years. So, and the green space just indicates the average expected numbers of deaths within that very particular week. So when you look at the age group of 0 to 64 years, you see that almost nothing has happened. So there's no COVID-19 pandemic that you could see here. Obviously something very different in the age group of 65 years and older. You can clearly see that something happened around March and May. There's a huge significant peak. So you can clearly see that COVID-19 has mainly affected people 65 years and older. But what's also interesting in this graph is what's happening just before the peak and what's happening after the peak. So what you can see is that the average mortality this year, just before COVID-19 started in Switzerland, was extremely low. And what happened afterwards is also that it went down to an extremely low level. Now, when you look at the total numbers of deaths in the age group of 65 and older in Switzerland, and you just count the numbers, you will see that in 2020, up until week 27, there were 31,278 deaths. But when you compare this with last year, you hardly see any difference. Last year in 2019, there were in the same weeks, up until week 27, 31,205 deaths. So if you just look at the absolute numbers, you can't really see any COVID-19 pandemic. So how can you explain this? There's a very interesting term which was suggested around heat waves, and it's what epidemiologists call mortality displacement. So what mortality displacement means is that is a phenomenon where the heat principally affects individuals whose health is already compromised and who would have died shortly anyway, regardless of the weather. So estimates of mortality displacement are often calculated for defined heat wave periods that include before, during, and after the heat wave periods, lasting typically less than 2 months. So what this means is that COVID-19 in Switzerland killed people who were already had already a very low life expectancy, and that's why the mortality rate fell after the COVID-19 to an extremely low level, almost below the average numbers of deaths expected. So there's a puzzle here in terms of Switzerland. On the one hand, there's a medium lockdown. There's a significant mortality displacement that has happened. There's a relative low number of COVID-19 deaths. So this raises the question, is Switzerland a success story? But we need to take into account contingencies here. So you could also say, well, maybe this was just sheer luck and Switzerland got lucky. Maybe it has to do with the demographic structure, the socio-economic structure of Switzerland. Maybe it has to do with the quality of healthcare, that the quality of healthcare is in generally higher in Switzerland than in other places. Maybe it has to do with the social welfare system. Switzerland has a relatively good social welfare system. Maybe it has to do with an efficient test, trace, and isolate system. Maybe it has to do with the fact that there were no large outbreaks in nursing homes. And maybe it could also be that there will be more cases to come over the next few years. So maybe by 2021, Switzerland will not look like a success story again. So this is just to show you that very different things happen in different countries, and that we can't take the US or Brazil or India as the kind of common models. In places like Switzerland, the pandemic took a very specific shape and raises very interesting questions. I wanted to talk about Turkey for a while, because Turkey is also a very interesting case with a relative low number of deaths. So despite the wide circulation of the virus among the population and rapidly increasing infection rates, what is striking is Turkey's relatively low mortality rate. So in Turkey, there were only 5,000 deaths in a population of 86 million people. And that's quite remarkable. The Turkish lockdown was also very specific. It was very different from other countries. First of all, there was a restriction of movement for those younger than 20, unless they were employed, and those older than 65. So the restriction of movement was only for this particular 2 age groups. Secondly, Turkey banned large events and they closed schools. So the strategy here was a targeted lockdown to protect those at risk, meaning those 65 and older, and keep the workforce mostly at work. So in Turkey, the highly polarized climate of the country created two camps around the official figures. The pro-government camp suggested that Turkey is doing great in its crisis management, but the opposition, on the other hand, focused on the rising infection rates and the unreliability of the mortality rate. So again, this brings us back to what I was saying before about statistics. This is a quote from two scholars who noticed that the crisis provided the ideal context for the government to show its commitment to deliver and for the opposition to make its case for the government's incapacity to deliver. The statistical figures ended up as the key references to objectively measure success or failure. So what we have here in many different places today is a return to the very original meaning of the word statistics as the science of the state. At stake is knowledge of one's own and other states' respective forces and capacities. So different states are compared with each other, who's doing well, who's not doing well, who has high numbers, which country has low numbers. And this happens in a very competitive framework where each state's strength is measured against each other. So what we are witnessing today are political contestations using numbers to determine a state's success or failure to contain the spread of the virus. But this is really tricky because it assumes that these things are comparable. So I'm just highlighting here one particular problem, and that is the problem of what counts as a death caused by COVID-19. So when you may know that in Belgium, COVID-19 deaths were counted independent of any testing. So of 52% of all deaths, only 4.5% turned out to be confirmed by laboratory tests as COVID-19 positive. Almost half of all deaths were merely suspected to be linked with the virus, but had never actually been tested. So obviously this makes it very difficult to compare then the numbers from Belgium, for example, with the numbers from Switzerland or the numbers from Turkey, because the system of testing and the system of counting and the idea of what is a death caused by COVID-19 is very different depending on different countries. A similar problem, what is a death caused by COVID-19 in the first place? So in Italy, COVID-19 related deaths are defined as those occurring in test positive patients independently from pre-existing diseases that may have caused death. However, test positive patients who die because of a heart disease or terminal cancer are not necessarily dying because of SARS-CoV-2 infection, yet they appear in the statistics. So again, obviously a huge problem. And that obviously has also an impact in terms of the numbers and the comparability of the numbers across countries. In England, NHS data on confirmed COVID-19 positive cases is linked with the NHS death register to identify COVID-19 deaths. So patients who have tested positive but successfully treated and discharged from hospital will still be counted as COVID-19 deaths, even if they had a heart attack or were run over by a bus 3 months later. So what we have today is a semblance of comparability. There's an assumption that we can compare numbers across countries, but this assumption is really very problematic. First of all, different countries have different ways of defining COVID-19 deaths. A COVID-19 death is defined differently in Belgium compared to Switzerland, compared to Turkey, compared to the UK. Secondly, there's often a confusion between patients who die with the virus and those who die from it. Third, there's an incoherent way in which COVID-19 deaths are counted. Comparison between countries is impossible, therefore. Lists of COVID-19 deaths and rankings of countries therefore create a semblance of comparability. I have here a quote from Sabina Leonelli, who's been working a lot on data. She's been saying the following: robust data interpretation would involve comparing the different conditions under which data are produced and collected, including the different testing strategies adopted by each country and sometimes each region and municipality, and the ways in which deaths and infections are counted. But that's not what we're seeing today. What we're seeing today are lists like this and news media reports which compare different countries with each other and then assign blame to different countries. So why this pandemic of comparison? Why this constant ranking of countries? Well, the practice of comparing states with each other on the basis of numbers reflects the original meaning of statistics, as I was saying at the beginning of this presentation, science of the state, measuring the power of individual states and comparing them with each other. This is a quote from Benedict Anderson. He was saying, the spectre of comparison arises as nations stir into self-awareness, matching themselves against each other and becoming through the exercise of the imagination. So this is very typical news reports. I took here a couple from New Zealand. COVID-19 success story, New Zealand hits 100 days with no cases. But then the question is COVID-19 in New Zealand really a success story? Why has the world singled out New Zealand for praise? So we could also single out other countries like, for instance, Tunisia, Taiwan, Jordan, Senegal, Vietnam, and Rwanda. So this is a question, why is New Zealand always presented as a success story, and why has there been so much focus on this particular country? The spectre of comparison. This is just a summary of what I was saying so far. The spectre of comparison, this constant comparison of different countries with each other, is part of a nationalist mindset, a mindset that is trying to compare nations with each other in global power competitions. So that's what we're seeing today, a kind of nationalist mindset. The second thing that we're seeing today is that the spectre of comparison is part of internal political contestations in often polarized party systems. So this is what I was discussing in reference to Turkey. But it's also part of a moral discourse, assigning praise and blame, which country is doing well, which country is not doing well. It's also part of an audit culture of measuring performance and effectiveness through seemingly objective numbers. And last but not least, it's part of a globalization process, standardizing things to make them globally comparable, even though, as I was saying before, the numbers are absolutely not comparable with each other. So how can we think beyond rankings and comparisons? To conclude this talk, I took a couple of quotes from a scholar who has been saying some really interesting things. And I just listed here a couple of his key claims. So this is from François Balou, who is at UCL. He said, the debate about how to respond to the COVID-19 pandemic is often framed as a scientific or a scientific economic problem. I do not believe it really is. Instead, it is primarily a moral and ethical conundrum. The main reason is that there is no solution, only trade-offs. The second claim that he made is, any rational, scientifically driven strategy would require addressing some uncomfortable, possibly unanswerable questions, such as, what is the relative value of a child's education, of the life of an elderly person in a care home? The third claim that he made is the following. Many countries do not seem to have a clear long-term strategy. For those that do, for instance, Sweden or Singapore, I believe their motivations and policies are generally equally moral and ethical. The difference is the weight they put on mutually exclusive objectives. And then he said, between country comparisons of COVID-19 mitigation strategies may not even be particularly informative with the benefit of hindsight. Countries are interdependent and every single epidemic is unique, with local and stochastic factors playing an important role. So each country faces a unique idiosyncratic challenge and has to respond with the means at their disposal. As such, it may often be pointless to compare the performance of their COVID-19 strategy at this stage of the pandemic. And the last claim, there's no solution, and those who claim otherwise are insufficiently informed. As such, it would be helpful if we could get over the endless sloganeering, engage in an adult and honest discussion about what we value most and reach responsible decisions accordingly. So let me just conclude with a couple of questions. Are interventions today mainly driven by seemingly objective numbers and a spectre of comparison? And I think the answer is yes. Has the obsession with numbers, comparisons, and rankings sidelined a concern with democratic norms and values? And have governments shown a commitment, or have governments shown a commitment to empower communities and build institutions for social welfare? Below, I have a quote from a newspaper article about the COVID-19 response in India. So this is from the Indian Express. They wrote, COVID-19 latest, India's top 15 states with highest recovery rate and numbers. Again, something that we've seen again and again and again, comparison of numbers, but I'm waiting for the day when we would see a newspaper article headline saying something like India's top 15 states with the most democratic and most ethical response. But obviously we're not seeing these kinds of headlines because everyone is obsessed with numbers, and because numbers have become the main language in which we're talking about the COVID-19 pandemic and the response. So how can we think beyond the numerical? So for instance, we could simply ask the question of which countries have enabled fair and equal access to healthcare, and we could have a ranking of all the countries which have enabled a fair and equal access to healthcare. Or we could ask the question, which countries have attended to socioeconomic inequalities? And we would get a very different kind of ranking and comparison. Or we could compare countries which have facilitated community response. Or we could ask which countries have enabled and respected opposition and disagreement. What would be the ranking if you would take this question as our main question? Or we could ask the question, which countries have cultivated openness and experimentation? Or we could ask the question, which countries have taken the pandemic as an opportunity to strengthen democracy? What kind of ranking would that be? Or we could ask the question, which countries have started to build a sustainable future? Again, all of this points to the key question and to the key problem. What does success mean? And what I've been trying to argue in this presentation is that we should look beyond numbers, because numbers are mainly not the most compelling way of understanding success. So I just want to thank you, and hope you found this presentation interesting and compelling. Thank you so much.
Thank you, Carlo. Goodness, hard to know quite where to start, because quite dispiriting in some respects. Can I? There's a couple. There are a lot of questions popping up now. The first question is, well, yeah. Oh, actually, it's about those questions you've got at the end there. Those questions are only possible to ask or answer when you're not panicked, when you're not in fear. Don't you think? Or is it possible to ask those realistically within the first few weeks of a pandemic becoming obvious?
Well, I think, well, first of all, we're now quite very long into the pandemic. It's now been going on for quite a while. So, it's, I think, talk about phases or whatever, but it's been going on for a very long time. And still we're kind of thinking and talking and looking at this pandemic with the same kind of language and with the same kind of mindset. And I think it's really important to now look beyond this mindset, to look beyond the numbers and start a different kind of conversation, a conversation that will be about access to healthcare beyond just COVID-19, a discussion that would focus on democratic values, a discussion that would focus on, what's the point of our strategy? Well, what kinds of values are informing that strategy? And very often this discussion, we're not having this discussion because somehow this numerical language has kind of, sidelined all these other concerns.
It seems as if you're saying one of the big problems around use of statistics is that they're not accurate. Assuming we could get them accurate and we could get them consistent between countries, is there worth of using it as a language for understanding whether we're right or wrong, or doing the right or wrong thing?
No, I mean, it's not. Different countries have different strategies, and some numbers are more reliable and others are less reliable. But there's no, I mean, it really doesn't make any sense. I mean, everyone knows that these numbers are not reliable. They're not accurate. So,
Yes.
you know, if you just look at the discussion around the fatality, infection fatality rate, you know, some people at the beginning were saying, oh, it's around 20%, and then people said, well, it's maybe 3%, and now it's down to 0.02%. So these numbers have been going up and down, and we knew from the beginning that they're not reliable. Nevertheless, people remain focused on the numbers, and I think it's the most important thing. But in fact, other questions and concerns might be equally important. Yes.
Interesting what you're saying around the contrast and comparison between countries, and particularly New Zealand being held up early on as an example of how things can be done correctly. It is interesting also that Sweden perhaps was held up as the opposite. I'd seen comments from people saying that there appeared to be a death wish against Sweden. But it's interesting also that in recent days, with New Zealand experiencing our own resurgence of COVID, that I've seen articles in America in particular where they almost seem to be laughing at the fact at our misfortune, and now it's our turn. So we, you know, it's almost acting as if we thought we were great, so it serves us right. That's part of what you're talking about. Why is that happening? Why are people being so mean to each other internationally?
Yeah, I mean, it's a great question. I think it has on one hand to do with the fact that everyone is focused on nations and states. So that's the kind of mindset. The second thing has to do with the fact that there's a lot of blaming going on. I think you would have to look at social media, because social media play a huge role in this. A lot of the blaming happens in and through social media, and obviously, you know, Twitter has always been facilitating judgment and opinion. That's what you do on Twitter. Something happens in the world, and you tweet about it. Your tweet has to be a judgment, right? It has to be your opinion. You like it or you don't like it. Do you think this is horrible or this is great? So the social media and the technologies and the way in which you communicate have definitely had an impact on how we think about the pandemic. You know, so I think there are a whole range of different factors. And then it's also the media. That's what the media have been doing. And so people reproduce the kind of discourse that they see and that they encounter. It's very difficult to get a different narrative out there. It's very difficult to change the language, to change the terms, to change the focus. But that's the kind of work that we have to do, right? We have to say, you know, we should look at democracy. We should look at what kinds of inequalities. We should look at social welfare. We should look at all of these different things. And we should have an honest discussion about these things.
Well, indeed, that's what we'll be trying to do here today. And there's been many hundreds of people tuned in over the course of the day. But there's 5 million in New Zealand. There's a lot of people who haven't been able to. It takes a day to have these discussions. It takes more. How can we make time for that, for the discussion? For the questions?
Well, yeah. See, I'm not so sure it's a question of time. I think it's more like just changing the narrative, shifting the discussion. I mean, at least in kind of my world, you know, COVID-19 is always present. It has this over-presence. So I'm not so sure it's a question of time, because everyone is now full-time focusing on kind of, you know, the newspapers are full of COVID-19. Everything is kind of work and life is full of COVID-19. People are already sick of it. It's become such a dominant thing. You know, they're looking forward to a kind of break. So I'm not so sure it's a question of time. It's more like you know, opening up our imaginary, opening up the things we could talk about, opening up the questions that we could ask, opening up the images that we could use. So that's been one of the key arguments in my paper, where I've been trying to say we need to open this thing up. We need to have a broader imagination.
You touched on in the presentation about mortality displacement. I think effectively you're saying that probably across most countries, the people who are going to die this year kind of have or will.
Yeah.
But that's been a very difficult discussion to have. It feels as if people, even losing a week or a couple of months at the end of your life seems to make one heck of a difference. What do you think is going on there culturally?
That's exactly the issue. I mean, it's a very tricky ethical question, and that needs to be discussed. But in order to even start a discussion, we would have to acknowledge that something like this is happening.
Yes.
So the starting point would be acknowledge that this is actually what's happening, and we should stop saying we're all in this together, or using this kind of language as if COVID-19 is a threat for every one of us. It's not. We know it's mainly a threat for people who are older than 65. It's mainly a huge high risk for people with comorbidities. So then you should have a discussion around that. What does that mean? How do you protect these people who are at more risk? What's the value of life? And I'm working on oncology, and in oncology you have these discussions all the time.
Yes.
Right? The drugs are extremely expensive. So how much should a week or a month be worth, and who should pay for this? So it's not like we're not having these discussions. We have them all the time, and the decisions are made in the hospital on an everyday basis. And in an ICU, doctors will make a decision like, for how long are we going to keep this person alive? It's not like we're not having these discussions, or it's not like these decisions are not made. They are made, where they're not necessarily visible. They're not in the spotlight. They're not on the media, but it's happening. So
how much of what has happened is down to the dominance of government, even in Western democracies? The dominance of the conversation, of setting the agenda. I get a feeling from what you're talking about. One of the questions was how much community involvement has been, working out whether a country has been successful based on that. But when I saw that question, I was thinking, well, perhaps none. I'm not sure I can see the difference between dictatorships and democracies in terms of the lack of conversation that's going on.
Right, exactly. I mean, what Italy basically did is they copied the Chinese response. But the interesting thing about the Chinese response is that it was very targeted. It focused on one region only. Yeah. China as a country was never under lockdown. So, they had a very different strategy that was very targeted and that was very differentiated. And then Italy took over this idea of the lockdown, but then imposed it on the whole country. So it made something that China never ever did, and that looked even worse than what China did. And then everyone followed. So I think it's absolutely right. It's independent on the political parties. It's independent of the political orientation. It's almost independent of whether a country is authoritarian or not. So, you could have something like India, which has the most strictest lockdown in the world, and is definitely an authoritarian regime, compared to Brazil, where the president ignored the disease and the virus. So it's, yeah.
Have you seen a country that has registered it at least anywhere on the list of those questions you asked, where you could say there's been a good conversation, where a community answer, where people have shared possible solutions?
It's a great question. I don't think I have a good enough overview to answer that question, but I guess maybe Sweden would be a good example, because there's been so much pressure on Sweden, they had to justify what they were doing. Maybe that would be a good place, but I don't know. I mean, I'm sure there might be other places which are outside of the limelight, where some of these conversations have been happening more than in others. I think it has definitely not happened in the US. That's for sure. Definitely not in the UK.
Yeah. Now, there's another good point in there that someone's brought up, and that's about the fact that there are no solutions, that there's only really trade-offs. But governments and other commentators have spoken as if there is only a solution. The trade-offs are can't even be countenanced. Is this the only time this has happened where we haven't discussed things in terms of trade-offs? Is it a common problem?
Well, it's definitely a common problem, but I think in the way in which this question has been sidelined, I've never seen anything like this before, especially on a global level.
So how do we get? Have you got any suggestions about how people could get involved themselves into the national conversation? Have you seen examples of the members of the public or communities beginning to try and take control or get back involved?
Yeah, I mean, there have been interesting cases like in India, in Mumbai, in the slums. There have been a lot of community mobilization, particularly because officials were quite concerned what would happen in the slums. So here in Mumbai, there's been a lot of community mobilization around that particular area of concern, and I'm sure in other countries there have been been other kinds of community mobilization, and I think we'll see it happening more and more in the future, partly because the virus is not going to go away, and partly because we see that these radical solutions are no solution at all, and so the focus will hopefully shift towards other kinds of interventions and ways of dealing with the pandemic.
There's been a couple of comments in the questions list. People talking about that even where people have been saying let's protect the vulnerable, no one's actually seems to have asked the vulnerable whether they want to be protected or what their choices are. And in terms of discussion around the imminence of death or otherwise, no one's. They're the ones who face it, are more likely to be facing those questions, and surely it's their decision. What do you think about that?
Can you say this again? I didn't hear it.
So the people who are most vulnerable are being spoken about as if they need to be protected, but it doesn't appear as if they've necessarily been asked whether they want to be. Is it their right?
I mean, that's going back to what would an ethical response be? Is it a kind of top-down approach, or do we choose a different approach, a bottom-up approach? So I think that's the question would be, how do you approach this question, and how do you start a conversation? Do you just assemble an expert committee and ask 5 experts to come up with the guidelines, and then you impose the guidelines using the police, which has been what has happened in a lot of countries, especially in India and elsewhere? Or do you have a very different kind of approach, and you mobilize a community, have a conversation, and you involve different stakeholders, and then you come up with a guidance that is more democratic, that is more based on people's concerns, and that takes them seriously? And then you have a very different kind of approach. And we know how to do this in the context of health, so it's not something new. But unfortunately, in this pandemic, everything has been, or a lot of the interventions have been kind of top down, driven by a few elite experts from some very particular institutions, and that's not been very
no. So one final question: how could it be done differently in the future? Let's assume we can't do it now. Is there a way of changing things? Because there was a time before COVID when all of these issues you're talking about were still live. When it was difficult to have community discussions, when government was still dominating, when the media were not taking an interest in deeper things, but just looking at the day-to-day. We didn't change it then. What are our chances of changing it in the future?
What's interesting is I worked on pandemic preparedness for 10 years, from 2005 to 2015 in the US. And I was working with a whole number of different experts who were concerned about the pandemic. And so what's interesting here is that there were, for over 10 years, experts, public health professionals in the US, they were coming up with plans and guidelines, and invested a lot of work and money into thinking about what would happen if a pandemic happens. How would we respond? There were endless numbers of guidelines, advisories, all kinds of things, including how to involve the community and so on. And what's been so surprising in this pandemic is that none of this has been taken seriously. It's like all of these plans suddenly disappeared. And instead, what governments relied on was this idea of the lockdown. And that's been so surprising. I mean, how can it be that you invest so much work, you have all the plans ready, they're all there, some of them are 200, 300, 400 pages. They looked at every single question that you could imagine. They were even differentiating the response in terms of the severity of the disease and so on. And all of these models, all of these concepts, all of these guidelines suddenly disappeared into thin air. That's been the most surprising thing. Like, how could this happen? Because all the resources were there, all the work had already been done, but very few of these ideas have been put into practice. That's the puzzle for me. I don't understand it. I think we need to understand that, because otherwise there's no point in trying to think how will we respond next time, and we come up with great, amazing plans, and then when it happens, we fall back on something that was never done, was never tested, and was just a complete disaster in many dimensions and contexts.
All right, Carlo, actually we're still waiting for David Seymour, so I will throw a different question in to final question. Social scientists seem to be almost uniformly around the world supportive of lockdowns, and this is a question I think which will be felt by many people watching in terms of what your answer is. How have you been treated by your colleagues, and how have you tried to convince friends and family and network to take this wider view, not to be so which, because you effectively sound like you're anti-lockdown, to think differently?
Well, first of all, I would not agree that most social scientists are in favor of lockdown. I think it's a question of who's visible and who's not visible, who's in the media and who's not in the media. I mean, obviously the dominant kind of opinion, public opinion, is, I guess, in a lot of places is in favor of lockdown. But I would say people, especially scholars, I mean, if you look at India, I don't think you'll find a social scientist in India who's in favor of the lockdown, because the lockdown has been a disaster in the way in which it has been imposed. It has definitely killed more people than the disease itself. So I think it really depends on the places. I think also in Italy and in France, you will find lots of people who are very critical and concerned about the lockdown and the way in which it was imposed. So I didn't have to convince many people. I mean, I had very good conversations with people. A lot of people agreed with, and it's, I'm not just against the lockdown. There are a number of other arguments which are important and which are kind of independent of the lockdown. So,
thank you very much. Thank you, Carla. Really appreciate you coming on and giving that perspective. That's incredibly been valuable. Thank you.
Thank you so much.
Right, now we're finishing up with David Seymour, the ACT Party leader. When we asked to present or hold this symposium at Parliament, he was the only MP who responded quickly with no ifs and no buts, no maybes, that he'd be happy to help host it. And on that basis, we went ahead. It is a non-political symposium, as you've witnessed today. It's all about the science. But when we had to go and put this online only, we thought it was only fair to ask him to still be involved. It's David, if you don't mind me saying, this is not a 10-minute political statement, but rather the question in front of you is your reaction to some of the presentations today. How have politicians, or how are politicians going to deal with the alternative views and the changing data that's put in front of them? Is there room for changing minds? Is there room for alternative perspectives? Is there room to adopt some of the data that's becoming clear in terms of political policy? So before you start on that, at the end of David's presentation or talk, that will be the end of today's symposium. we'll finish at that point. Thank you everyone for being here, and we urge you once again to donate to the COVID Plan B effort, which will be going on for a little bit longer. If you like what you've seen today. David's going to present, but we're not going to take any questions. He'll need to move on immediately afterwards. Thank you, David. Take it away.
Look, well, first of all, thank you for having me, and congratulations for trying to foster some more open discussion around this topic. I think that if we need to do one thing to succeed and thrive in this environment, it is move from a state of fear to a state of open debate. And so I congratulate you on actually being here and having that discussion. I am sorry that it couldn't be hosted at Parliament. I was really looking forward to hosting everybody and having this discussion at Parliament, because I believe that the open discussion of how our society gets through this problem deserves that level of prominence. And I just start with the observation that our pluralistic democracy does not have the advantages that an autocratic country has. There's some countries that are able to act very nimbly and decisively because they don't have to take a wide range of views with them. However, we also have an advantage as a society, which is that we are able to bring many voices, many ideas, and many perspectives to the solution of a particular problem. And the failing to date is that we have not been prepared to do this. I think, without wanting to politicize my discussion, the government's initial messaging, Unite Against COVID-19, had an enormous problem built into it. It said, if you are not the same, then you are opposed. And of course, in the quest for unity, we forgot a plurality of voices. So that's my first point. Second, I think that we have now got to a stage where the price of lockdowns and the price of the elimination strategy is becoming clearer to people in New Zealand. So previously, it seems that we could eat our cake and have it too. We could remain free and safe, and the only cost to that was being physically isolated from the rest of the world. Not an insignificant cost, it has to be said, but it seemed our island nation status might allow us to maintain that isolation and that freedom at relatively low cost. And the challenge was, how do we safely reconnect with the rest of the world? Now the price of domestic restrictions has been added to that cost, and all of a sudden people find that we have a much more expensive strategy than we might have realized. So I think that changes things somewhat. I also frankly think that the delay of the election, while the election is really a footnote to the inconveniences that people are facing up and down New Zealand, no matter what business they may be in. And I'm talking about, kids who are anxious about their exams already, now facing great disruption, people in business. I just use simple examples like a butcher I spoke to the other day who's down 80%. Those inconveniences are much greater than the delay in the election, but the delay in the election does mean that New Zealand has an opportunity to have a wider ranging debate. And I think one of the failings of the past 3 to 4 months is that we've spent a huge amount of time doing a victory lap, and we have consistently chosen worst case scenarios as comparators in order to make us look better. So for example, this is, we've been comparing ourselves for the last 4 weeks with Victoria, because doesn't it feel great, or didn't it at least feel great? Did people forget that there are 8 other states and territories of Australia, which have a totally different story. And I think the fact that we've chosen to focus on Victoria tells you something about the mindset that we've been in. It's been self-congratulatory, it hasn't been reflective. And, you know, it's almost like one of those children's fables. Of course, there are consequences for that kind of indulgence. What we should have been doing, instead of talking about Sweden, of course, and I'm sure many people will have spoken about it today, is talk about Taiwan. So if we cannot afford to keep having lockdowns, if we're not prepared to accept the costs of COVID-19 running through the population at any rate of reproduction, then we're going to have an intelligent discussion about how we can get better at contact tracing, how we can get better at testing and isolation and manage outbreaks in a way that prevent widespread, I guess, infection, because I don't think that people are prepared to accept that, and yet not have to resort to blunt and expensive lockdowns. And the framework that I would urge people to adopt is actually a framework of well-being. And this is something that the current New Zealand government has used, at least rhetorically, for its well-being budget. They have said that, you know, we need to countenance a range of different aspects of human welfare when we think about policy. And I would say that's quite an appropriate way to approach the current situation. I would say, look, it's not just about COVID, it's also about mental health, it's also about kids getting ready for their exams, it's also about the economy, you know, it's also about you know, other non-COVID healthcare impacts, not being able to do screenings and elective surgeries and so on. Once you take that well-being approach, one thing that becomes glaringly obvious is that we need to change our approach to COVID. It can't be as expensive as it is. It must become more intelligent. And through that lens, I think we can have a much more helpful and honest conversation. So that's the wider context. I think we now have a situation today where the Prime Minister has given the time to have the debate, and also the debate will be held against a backdrop where, you know, we're going to have to be you know, quite open about you know, what has happened and why it is we can't have the election, all the other people facing disturbance for the same reason. So let's hope that 1,000 flowers will bloom, that there will be much discussion that is fertile, and New Zealand as a country comes out of this as a much more thoughtful and much less indulgent group of people who are actually prepared to lead the world in living with, not dying with, but living with the reality of COVID-19. That's probably about enough from me, but I'm very grateful for anyone who's still listening, and very respectful and admiring of the organisers who have been prepared to put together a discussion that harnesses the pluralistic power of an open society like New Zealand, rather than the kind of united, but some would argue blinkered rhetoric that has dominated debate, or lack of it, on COVID-19 today. Thank you very much.
Thank you, David. And that was David Seymour, leader of the ACT Party. Now that concludes the COVID-19 Science and Policy Symposium webinar for today. Just as a reminder, the video will be up on YouTube for all those to watch following this presentation. And we're slowly uploading each presentation to the website and YouTube. Again, thanks to everyone who participated today. And until next time.